Good evening, everyone. It's a pleasure and honor to have you all. We have the esteemed faculties today for the session. I would like to invite Dr. Girish Bashaw, Dr. Nikul Panchal, Dr. Devendra Sharma, Dr. Rohit Mathur, Dr. Amol Agrawal, and Dr. Shibashish Sahu as the respected moderators and chair. Over to chair to introduce our speakers, the case, and then invite the speakers for the debate. Over to chairpersons.
Thank you. Thank you, dear. So I am Dr. Rohit Mathur, and it's always been an honor and privilege to be a part of Cardicon. And today the session is about ISR, and let me have the pleasure to invite Dr. Frank Kleber. He's a medical director at Paul Gerhardt Stift, Germany, and head physician in the Department of Cardiology. He is an interventional and conservative cardiologist, and he has been there for almost from June 2017 to June 2018. He has his expertise in clinical and experimental heart failure and interventional cardiology involving both coronary and extracoronary structural heart disease. And he has got many publications with his credit. Let me not waste any time and invite Dr. Frank. Dr. Frank, you are on the screen now.
Thank you very much for this kind invitation, for the kind introduction. And we'll take the next 10 minutes to talk about drug-coated balloons for a special case with instant restenosis with a non-treated diagonal branch, if I understand this correctly, and a stent in the LAD overlapping this diagonal branch. So what are the options with drug-coated balloons? Well, first of all, I'd like to mention that for treatment of instant restenosis, according to the European Society of Cardiology guidelines, and proven by a really huge number of studies, randomized trials, the drug-coated balloon technology is the technology of choice. First of all, because it's at least as good as a stent, and it does not bring additional material into the coronary tree. The basic benefit of drug-coated balloons in any situation is the mimicry of the Glago effect, which means that the vessel gets larger and can tolerate a higher burden of plug material. And then this physiological mechanism during the development of atherosclerosis is basically induced in this setting by the drug, which is mostly, as you know, paclitaxel. This has also been shown if you apply paclitaxel in animal experiments to the pericardium, you even, in this situation, you have the increase in vessel size, which you see here measured as the external elastic membrane area. Now, years ago, we were the first to describe this in de novo coronary disease, and we saw a rightward shift of the MLD diameters over the range of various diameters in a small to moderate size group of patients. So almost the big majority of patients after DCB application has a larger vessel 4 to 6 months after the initial PCI. This has been repeated by several groups with several technologies. Here, interestingly, it is the Korean group, and they showed when you have your early result of PCI here that not only the main vessel dilates, but also the side branch ostium. Of course, if you increase the size of the whole vessel, of course, the side branch ostium must increase, and this has been shown by OCT very nicely by Dr. Shin and colleagues here. Dr. Hare is the first author of this publication. We also did the first a randomized trial in bifurcations with drug-coated balloons. And as you see here, we were able to show, as compared to a regular balloon, the binary restenosis for the side branch goes down from 26 to 6% with DCB. So very good for side branches. This is not ISR so far. And also important, as you know, DCBs have a lower rate of thrombotic occlusion of the artery, as has been shown by the SCAR registry. So another advantage for this. Now, in terms of our case, of course, this is a very special situation, and we don't have so many data on exactly this situation. But we have, in terms of bifurcation lesions, a very nice meta-analysis by Simon Ecclestoll's group. And I show you, this is the amount of publications they put together, 688 lesions, predominantly LADD1 lesions. And in 281 lesions, they were just looking at main stent, main vessel stenting, and side branch with drug-coated balloon or not drug-coated balloon with various comparators. And this is basically these three studies which give you some information on this. Especially important, the study by Herrador, because he used a DS in the main branch and compared this to the regular treatment. And as you see here, overall, these studies showed a quite clear benefit for the DCB versus POBA for the side branch when you stent the main branch. But the question is, of course, whether you have to stent the main branch. But this is not our case today. And there's another interesting analysis by Dr. Zheng from Nanjing in China. And he looked also into several studies. And as you see here, the MLD of the side branch is better with the DCB treatment. The same is true for the diameter stenosis. The same is true for late lumen loss, better with the DCB for the side branch, and here for the binary restenosis rate. Overall, they looked also into endpoints, and for the combined endpoint of major adverse cardiac events, there was, by the time you see here from 1 month to 12 months, a increasing benefit for the DCB as compared to non-DCB treatment of a side branch. Another study looked at the impact of late lumen loss on clinical outcomes in side branch bifurcation lesions, published by Ikuta from Japan. And these authors concluded that 71% of the patients in this series had late luminal gain, as I showed you in de novo as well. And the side branch late luminal gain was associated with less target lesion revascularization and less MACE. So I think for the side branches, there is little doubt that the treatment with drug-coated balloons is the recommended treatment. This also goes along with the Asian Pacific recommendation, which says, therefore, it is recommended that DES-ISR lesions be treated with DCB if the angiographic results are good after balloon angioplasty, and if otherwise, they should be treated with newer generation DES. Most important, when you treat a side branch lesion or any lesion with a DCB, is to nicely predilate the lesion and to reach the lesion within a short time. Our attitude is to reach the lesion in most cases within 30 seconds. In some, we need 60 seconds, but almost all lesions are done within 1 minute, because you lose the drug if you don't take care that from insertion to the guide catheter to expansion of the balloon in the lesion, it should not be more than a minute. In our hands, we mostly treat de novo lesions. But in a untreated side branch, as is the case here in this case, I think the physiology is not so different that we could not apply the drug-coated balloon with mostly paclitaxel, currently at least, for the best benefit of the patient. I think this is about what we currently know about this situation. Of course, I have not seen the angiographic pictures. It might be useful to see whether this is also has to do with some amount of restenosis in the main branch, which of course would have to be treated before. But depending on the good result of the side branch predilatation, in our hands, this would be the preferred treatment. Thank you very much.
So, thank you, Dr. Franz, for your exciting enlightenment on the use of paclitaxel-eluting balloons. Dr. Amol?
Yes.
Yeah, Dr. Amol, can we invite the next one, please?
Yeah, so I have the pleasure of inviting Dr. Jayesh Prajapati, who will be presenting the counter argument whether drug-eluting stent will be better, especially thin stent in such a case if atherosclerosis is found. So to introduce Dr. Jayesh Prajapati, he is working as professor and head of the Department of Cardiology at UN Mehta Institute of Cardiology, Ahmedabad, also working as director cath lab and senior cardiologist at Apollo Hospital. And he has a vast experience in complex angioplasty and in various other high-end interventions. He has been invited as faculty for national international conferences like CAD, AICT, and EuroPCR, TCT, Asia Pacific, presented various papers at national and international forum, and is a principal investigator in PHF and F biometric registry. So may I invite Dr. Jayesh Bhai for his talk.
Good evening, dear friends or chairperson, co-chairperson, and of course the speakers. First of all, I'd like to congratulate Dr. Kamal for organizing such a wonderful CME with variety of topics. So just I share my screen. My screen is visible now?
Yes.
Yes, Jayesh Bhai.
Yeah. So of course, this is it's a unique case Kamal has posted that patient already been implanted 3 years back. DES has been implanted. So stent is patent and there is a diagonal which is large and it is in ACS situation, 99% occluded. So of course, what is that? So it's a, of course, it's a non-true bifurcation. I can say it's a Medina 001. And when it is a non-left main bifurcation, it is very difficult. Even with a left main or only circumflex ostium, it is also dilemma how to go ahead. And this is a non-left main bifurcation and Medina 001. So there are so many issues. Even with a most of the times say that diagonal is not an ACS situation. We have to see how much area is supplied. If the area is not significant, so of course we have to try the medical management. And then of course the option is, suppose you want to treat it, area supply is large, patient symptomatic. And this is ACS situation, large diagonal, of course need to be treated. So how we can treat it? So there are options available, of course. So today's discussion is DEB versus stenting or something other thing. So osteal lesions, at least we should profile, and then either we can use a lesion preparation is a must, because ostium is a different thing. It's a recoil with a balloon only. So we have to profile the lesion, then we have to prepare the lesion, and then we have to either do a DEB or the DES implantation. Issue is that when you do a DEB, there are 15% chances that you land minimal human area is less, or you develop with a dissection or recoil of the lesion, and then ultimately you have to implant a stent. So why not to go with a DES implantation statement? There are no clear-cut guidelines which is the better one, and there are not much studies available for non-left main bifurcation Medina 001. And of course, there are DEB, there are certain issues, which drug, how it is coated, which company, what is the carrier material, and we require large, there is no head-to-head comparison, large data available in Medina 001 non-left main. So of course, and there are certain issues, of course, related with the stent also. So stent, sometime what happened, except it is a very 90-degree angle, you can implant a stent perfectly. Otherwise, there will be either a geographical miss. So there are certain techniques where you can safely implant a stent. So there are no randomized data. So one thing is that we require intravascular imaging to see for the lesion more, because it's a new atherosclerosis. It is not a true bifurcation, as my first speaker has rightly mentioned. This was not a true bifurcation lesion. And of course, we know that the indication for the DEB is class 1 is only with ISR if you don't want to go with a much metal. So one way to profile the reason, and of course, we have to see the physiological assessment. But here also it's a 99% lesion, patient is symptomatic. So anyway, we have to treat because the ACS situation and there is an angina. So before treating just we have to be sure that it's a necessary for the patient. So everything is important: lesion morphology, territory, clinical scenario, and everything. So these are some of the small studies are there, and say the diagonal even up to 2 mm, 2.25, you can leave it. But here we need to treat it. When I gone through all this drug-eluting balloon data, of course, the numbers are not that huge, but all this study and all this meta-analysis says that the TLR was similar both with the DES and DCB. Both were better than the plain balloon angioplasty, and Reeves 4 has and the DES better. But of course, there are when we don't want to put more metal or the DAPT an issue, then of course the DES or BMS restenosis, DEB also one of the good, or I can say equivalent option compared to the DEB. For other, it is a debatable one. So when we see the guideline, there are not much updated guideline available, but the 2014 guidelines say that the drug-coated balloon are equivalent to the DES class 1A indication, particularly when it is a ISR only, that we should keep in mind. When we see the DNO, of course, already this trial has been discussed by my previous speaker. So when the meta-analysis versus DEB was for de novo lesion, even with a large vessel or the small vessel, the conclusion that DEB are not superior to the current standard therapies, either DES in treating the de novo lesion, and DEB efficacy seems to lie between the DES and BMS with a trend towards superiority over BMS alone. So if we are able to implant a DES in a good manner, then of course it is a better strategy compared to the drug-eluting balloon. So issue is that how we can implant this drug-eluting stents. So of course we have to profile the lesion with imaging technology, and we have to see, then we have to prepare the lesion correctly, either with a scoring balloon, cutting balloon, or whatsoever, and then we can use a various technique, like you can put a flush stenting, or we can put a balloon crust, or we can do a provisional stenting. So just we put a stent into the side branch to the main branch, and then we recross and we open the side branch, and then we can implant either a drug-eluting balloon in the main vessel and branch vessel, just to put a stent. So that is the one strategy you can do, or shoulder technique, like crush with a balloon and then complete the procedure with a drug-eluting balloon. So you all the diagonal, so cover diagonal origin and everything will be covered by a good drug-eluting stent. And there are Jabot technique, some of these kind of shoulder technique, this is available. And of course, there are some of the stents will be available, the dedicated bifurcation 001 stent. So that can change the future. So of course, if we can implant a DES in a better manner, it can be better compared to the drug-eluting balloon. And of course, when we consider in a diagonal treating, we have to see how much important to treat this vessel. So in a stable angina, if we can manage medically, it is better rather to chase a diagonal. But in a ACS situation, large diagonal, we can treat with a proper manner with a DES. Then of course, a DEB also one of the option. And of course, as I have told that with DEB also, there are issues like recoil. Of course, we don't know which drug, which balloon, or which company balloon, what is the technology, everything matters while using a DEB. While with the DES, we know we are very familiar with the DES, and long-term data with DES is always better. And when we see the cost-wise, particularly country like India, where the DES very cheap compared to a drug-eluting balloon, rather here drug-eluting balloon are costlier compared to the DES. So that is also we have to keep in mind. So my take home is that drug-eluting balloon, of course, is a good thing for the DES or a BMS-induced ISR, or when we want a short-term DAPT, this is also one of the good option. And there is promising data for additional indication have been reported in the treatment of de novo lesion, side branches in the bifurcation lesion in small vessel. However, data for this indication are limited to few small randomized trials and registries. Larger randomized trials versus newer generation DES using the clinical rather than surrogate angiographic outcome are warranted. All DEBs are not equal. Different manufacturing, drug release kinetic, need for head-to-head comparison for a more appropriate disease. And of course, this technology is very old, but still there are every time we are discussing regarding the DEB. While the DES implant is a preferred strategy as a first choice, if we implant it properly rather than bail out once we develop a dissection or the recurl, if we implant with a good technique, and of course it's cost effective also. So DES also is not a bad choice. Thank you.
Yeah, thank you, Jayesh bhai, for your very nice counter argument about implanting a DES vis-a-vis a drug-eluting balloon. Now we'll invite the to invite Samir for his talk, third talk, and it will be on sirolimus eluting drug-eluting balloon with nanoparticle technology. Dr. Dani is practicing for about 20 years as 24. He's been professor and head at the Institute of Cardiology and Research Center. Since 2007, working as director, Department of Cardiology at Apollo Hospitals, Ahmedabad, visiting fellow in interventional cardiology at CHU Hospital, Charles Nicolle, 1995, Rouen, France. Accreditation is an ex-honorary cardiologist to His Excellency the Governor of Gujarat. He has had many research articles and many publications. May I invite Dr. Samir Dani sir for his talk.
Thank you, chairpersons, for a kind introduction. Thank you, Kamal, for inviting me here. We have had very nice talks by Professor Kleber and Professor Jayesh Prajapati. Let me share my screen. Is it visible?
Yes.
Am I audible and is the screen visible?
Yeah.
Yeah, okay. So as Dr. Jayesh has already said, it's Medina 001, and Professor Kleber has put forward his arguments very clearly and very emphatically. And he has worked a lot in DCB area, and he is one of the authorities to talk about when to use or where to use DCB. So the issues here are whether we are going to use DCB or DES, and imaging techniques are must, or can they help us in deciding whether to use DCB or DES? And if we are going to use DCB, which I believe we should, then whether we will use a sirolimus coated balloon or a paclitaxel coated balloon. And then there are some technique related issues which are, kind of better answered by experts. There is no definite consensus whether you should do kissing balloon inflation or not, and whether you should do pot or repot or not. Well, for arguments for drug-coated balloon is very well put forward, and they're very clear as per Professor Kleber's lecture. No metal layers, policy or the philosophy of leaving nothing behind. There is reduced need for prolonged dual antiplatelet therapy. The whole procedure is very repeatable. There is reduced vascular inflammatory response because of polymer-free design. And this is all very important when we are doing PCI, and drug-coated balloon gives us advantage of all this. And that's why recommendations to use DCB is there in through most of the society's guidelines, and you can see that use of DCB in the treatment of bifurcation is recommended by almost all the consensus group. German, Italian, Chinese, and European, of which Professor Kleber also is part. So I would prefer DES in very small situations in this kind of scenario where there is a large side branch. But again, now we have enough data to say that even in large side branches, DCB is almost as good as DES or non-inferior. If you do not have DCB, then it's understandable that you can use DES. Then I would If there is suboptimal result of pre-dilatation, maybe yes, then in that case, you could go for DES. But most of the time, if you persist, if you use cutting balloon or scoring balloon or rotablator or whatever it requires to give you proper pre-dilatation, then DCB is possible, unless there is vessel occluding or flow limiting dissection. And sometimes when reducing the possibility of recurrence is the most important clinical concern, like you have a recurrent re-stenosis, that kind of situation, and then you want to put a DES and put an end to it. But otherwise, in almost all other conditions, as far as side branch is concerned, you want to avoid multiple layers. You want to, especially if you have high bleeding risk, and this like this first intervention in the side branch, an excellent result with pre-dilatation if you get, then I would prefer DCB. This is the list of commercially available DCBs. Out of that, Sequent, Please, Pantera Lux, and Impact are the only paclitaxel eluting balloons available in India. And we have Magic Touch, which is sirolimus eluting balloon, which is available in India. So we have, as far as I am aware, we have only 4 balloons available in our lab. And why sirolimus? Once we have established that drug-coated balloon is the right way to go, why sirolimus? Sirolimus has a lot of advantages, which we know, and that's why we have shifted in the stents also to limus eluting stents. The problem with sirolimus is that the tissue absorption is slow, tissue retention is short, and it is very difficult to coat sirolimus on a balloon and retain it and deliver it to the tissue. And that is why almost all the companies, when they started with paclitaxel. Of course, the difference between sirolimus and paclitaxel, you know very well. Sirolimus has a, I would say, that very wide therapeutic window, and that is why it has it become kind of drug of choice. Now, this company has an nanolute technology where it creates microparticles of sirolimus, and they are coated in encapsulated in phospholipid, which is an excipient, and then that is coated on the balloon. It has certain theoretical advantages, that it has better adhesion on the balloon surface, it is circumferential coating, drug delivery is pretty good, it has very efficient particle diffusion. Now, all this is okay, and if this is the drug dose, 1.27 microgram per square millimeter, which is much lower. Crossing profile is better because of the low drug dose, and the excipient is also less. The whole blood concentration, the PK studies are good. Sirolimus concentration in tissue is, one can demonstrate, was demonstrated in adventitia up to day 14. And these are the product specifications which is available with us here. But as we say, the proof of pudding is in eating it. So theoretically, sirolimus coated balloon may be better, but is there data? And there we are on little shaky ground, that we have a lot of clinical trials ongoing, but there is no head-to-head comparison with PCB. But at the same time, I can tell you that from my personal experience of more than 600 patients now, and we have enough amount of registries, though they are not randomized clinical trials, Nanolute SIMS, Brazil ISR, FASICO, Eastbourne registry, which is has completed more than 2,000 patients in Europe only, the Selfie registry, the UK sirolimus eluting balloon registry, which is ongoing, Transform, done by Bernardo Cortes and Patrick Saruz. PI is Antonio Colombo, who has already enrolled 74 patients. Transform 2 is enrollment has started. Piccolato 3, 400 patients, enrollment has started. The Magical registry is for US FDA proposed, and the Magical RCT also is proposed and is about to start. So in all, very robust clinical program. In our personal experience, it has demonstrated promising rates of MACE up to 3 years. The MACE rates are up to 3 years are roughly less than 7%, 6.7%. In complex cohorts also at 3 years, the MACE rates are acceptable in ISR, DES, ISR, and even in small vessel. And of course, Professor Kleber alluded to the technique. It is very important when you are using drug-coated balloon to prepare the lesion optimally. And if you have suboptimal angiographic result, then only you go for DES. So in this particular case, my steps would be IVUS or FFR, vessel sizing, pre-dilatation with appropriately sized balloon, plaque modification if necessary. We would prefer cutting balloon, DCB inside branch, and then you may think of doing a kissing balloon inflation or a pod depending on your IVUS results, and then do final imaging. These are just illustrative cases. I'm not going to dwell into that. It is possible to get good angiographic results with DCB if you are meticulous. So in my experience, DES is preferred. Just to go through it again, if DCB is unavailable, or if there is re-stenosis or a lot of recurrence, or when reducing the possibility of recurrence is most important clinical concern. But otherwise, in cases like this, I would go with DCB, avoiding multiple layers and reducing the bleeding risk. And out of DCB, at present, my preference is changing to sirolimus coated balloons. Thank you.
Thank you, Dr. Samir. Thank you, Dr. Kleber and Dr. Jayesh as well. So we had an exciting discussion about all the possible therapeutic options we have for such kind of cases. So as just to summarize the things, I would say that first of all, because of this is an acute coronary syndrome presentation, so we are bound to do and not to leave patients on medical management, as we have already been told that this was a sizable diagonal. What I would like to see is also the results of the stenting procedure done for LAD, if it is available at all, of course. And that will also tell us that how exactly the diagonal behaved at the time of stenting, you know. Otherwise, as all we have discussed, that we need to go for, say, wiring, and then, of course, visualization with IVUS or OCT is very important, so as to understand that what is the problem, why this restenosis has occurred, because this is going to play a major role in deciding the treatment strategy, whether there is a stent strut which has come across the ostia, or it is a neoatherosclerosis over which a thrombus has formed. Because this is a 001 Medina, we can always go for probably a smaller size, longer balloon to do a pre-dilatation at some lower pressure, and just see if this gets a TIMI-3 flow. If the patient can stay stable, there is no dissection. Otherwise, we have options of doing stenting. If your angle is close to 90 degree, take a tap or maybe T-stenting, do a final kissing, and DAB, the role of DAB has very well been explained by Dr. Kleber and Dr. Samir Dani. Over to you, Dr. Amol, Dr. Shivashish, and other co-chairmen.
Yeah, I agree with you, Dr. Rohit. We have this wonderful option of drug-eluting balloon, where we want to reduce the metal burden, and the role of antiplatelets also will play a role in the long run, because the need of antiplatelets post DCB is by recommendation 3 months dual antiplatelet. So definitely from the case-to-case basis, the decisions can be taken. And I would like to congratulate all the 3 speakers for giving wonderful insight into this very interesting topic.
Thank you.
Sir, I would like to add one thing, sir. Hello? Am I
Yeah,
sir?
audible.
Sir, actually, yes. All these are DCB or DES, they're potent to only de novo lesions while we are treating that. But we are dealing a case where there is already one stent put 3 years back in the main vessel. While you do use like drug-coated balloon without kissing balloon inflation, in bench testing, it has been shown there is stent deformation in the main vessel. So yes, you have to correct that. You see, also imaging, we have also seen if you do just kissing of side branch, you will have deformation of the end. You have that also. You have to injure the main vessel.
So you mean to say, Dr. Sahu, you want to say that when you do the diagonal, finally you have to the geometry should be either do a final kissing balloon.
Final kissing balloon.
Yeah. So with DEB,
My question to all of you, I would like to change the setting slightly. Now we have high sensitivity troponins. This case, if we are just mentioning a troponin positive, does it always mean it's an acute coronary syndrome? Would it not being a mounting an ACS with a large vessel, which is a side branch, still would end up getting a PCI? That's something that I want to ask each one of you. Professor Kleber, and then Dr. Jayesh Prajapati, and then Dr. Dani.
Well, for a large diagonal branch, independent whether ACS or not ACS, if the patient is symptomatic, I think we should treat this patient. In our case, we have the stent in the main vessel already done 3 years ago, and it's our attitude not to do a kissing in this situation because we think that the stent is embedded. If it's early after stenting, yes, I would do a kissing balloon dilatation with a normal balloon in the main vessel and a drug-coated balloon in the side branch. But let me say one word about sirolimus versus paclitaxel. I think this is a very interesting development currently. What we know so far is that probably the sirolimus balloon for in-stent restenosis is as good as the paclitaxel. And we have some confidence in sirolimus because we have this history of stents. For de novo, we just finished a randomized trial in Germany with the last patient in 2 days ago, and we'll see the result. My feeling is that paclitaxel causes probably or potentially more positive remodeling because it's a cytotoxic drug, while sirolimus is not cytotoxic. And that's what we see with the paclitaxel stents, that we have a lot of secondary stent malalignment caused by this positive remodeling behind the stent. You don't like this with stenting, but you like it in de novo. And you would also like it in this situation. Thank you so much.
Thanks, Dr. Kleber, for your comments. I want to, regarding the treatment of the diagonal. Yes, Dr. Kleber told rightly that if the diagonal, because patient was asymptomatic 3 years, he becomes symptomatic right now. And if the what I consider that if the diagonal more than 2.25 or 2.5, and there is no bigger diagonal after this one in that LAD territory, and this diagonal is very important, we have to treat. So size of the vessel, length, and distal to that diagonal, if there are major diagonal is there or not. And of course, that also makes a difference apart from the biomarkers. And of course, for the treatment, just I want to add on that why not kissing balloon in a DEB in a main vessel also when we finish the job. Suppose I implanted a DES into the side branch diagonal and I finished correction with main vessel with a DEB.
Professor Kleber, you want to answer that, or shall I go ahead with?
Well, very briefly, I think the data by Dr. Shin shows nicely that the side branch osteum has a benefit from treating the main branch with the DEB. So it's our current attitude to use two drug-coated balloons, and in most of the certainly not in all, but in most of the bifurcation lesions, we end up without a stent.
Yes. So I think coming back to Dr. Kamal's question, if this is a large diagonal subtending to a large area of myocardium, it is wiser to do PCI. But if you want, you can do an FFR. And there have been studies where they have shown that in spite of significant angiographic stenosis, FFR of that side branch is normal sometimes, and in those cases, you can leave them alone. So this is possible. If you want to do FFR, you can do that and then think about it. But certainly, if 3 years back, this vessel was not stenosed and now it has become stenosed, the FFR is likely to be positive rather than negative. And another thing is that when you talk about why not final kissing or kissing balloon inflation in all the cases, couple of reasons for that. If you have a strut crossing the side branch ostium and you have to dilate at very high pressure, then you may alter the stent geometry a little bit. But otherwise, since this is a 3-year-old stent, it is unlikely that geometry will be altered that much. And we also know that when you dilate with only a balloon, the carinal shift is less likely to happen compared to dilating with a stent. So when you are doing balloon dilatation, you are less likely to create a problem there unless the stent is freshly implanted. So freshly implanted stent, absolutely yes. In less than 6-month-old stent, absolutely yes. But 3-year-old stent, I would go with IVUS. If you have a default strategy of 2 SCB or 2 DCB in your lab, it's okay. You spend more, but you're not harming.
So I have one reservation. Why would you like to do FFR in acute coronary syndrome? I mean, would you take the results of FFR in acute coronary syndrome?
Yeah. No. Dr. Kamal rephrased it. He said that if this is not an ACS.
Yeah, I meant it's then
only medical management
components which can be there in patients when you're using now high sensitivity. So when you use high sensitivity, they may actually be reflector of a chronic coronary syndrome. You have a lot of patients. High sensitivity was primarily defined for chronic coronary syndromes, picking up patients who are at risk of developing event in future. So that's my perspective. So what Dr. Dani is saying is correct. So I mean, that's what sir is trying to answer. So in which case, I think imaging an FFR would be a good strategy if you think it's part of a false positivity. And that's why probably in some of the setups using not the high sensitivity troponin, when you're actually dealing with a definitive ACS, might be a better strategy. Again, debatable. You have different cutoffs for the both. But I think in high sensitivity in the casualty settings, to define with the cutoffs on the nanograms of 19 and 49 to diagnose an ACS is sometimes a higher false positivity rate, as we know from the literature, as compared to the not so high sensitivity, which actually give more true positive values as compared to false positives with high sensitivity.
I can show you a small anecdotal case if the time permits. A case where I put a stent in the main vessel, left alone the diagonal, which was 80%. And I thought that it was big, but it was not so big and it would do. I didn't want to disturb the left LED stent geometry. And I thought that he would do well on medical management. He did so for a couple of years. And then he came back with some kind of chest pain. And his troponin was negative. But he was very anxious that probably that diagonal is causing him angina. Though that angina didn't look like a typical angina. So I did his angio again. And his diagonal was, instead of 80, it was looking like 90. But I was not sure that that was giving him angina because the symptom was atypical. So I did his FFR there. And to my surprise, FFR was like 0.9. So I left him alone, reassured him, and he's doing well. So such kind of situation may happen. And then you may think of it.
So can we have final comments, paclitaxel versus sirolimus? Professor Kleber?
I think most of important points have been mentioned. I think this was a very good discussion on this topic. It's a peculiar case. I think we learn from each other, and we have to watch the field in terms of sirolimus to see whether sirolimus is indeed better for in-stent restenosis.
Dr. Dani?
Yeah, I totally agree with Professor Kleber.
Is there any is there any head-to-head comparison between these two balloon strategies?
Yes, we just finished a study. but we have no results so far. Yeah, but we just finished. Last patient in 2 days ago.
Okay, so result will be published.
It was under the lead of Bruno Scheller. We both did most of the recruitments, but there were other centers involved as well. And so we'll hope to see in a year or so, we hope to see the results.
Yeah, great.
We're eagerly waiting for the results, Dr. Kleber. Right. With this, I think, Dr. Kamal, we come to the end of this very exciting first session. I congratulate once again to the team of Cardicon 2022 for, what is said is that a good begin is halfway done. So I congratulate you once again, and I thanks all my speakers, co-chairpersons and chairpersons, and all the audience for joining us. Thank you.
Thank you.
Thank you, everyone.
Bye.
Bye, everyone. Thank you. We move to the next session, and for that, I invite Dr. Amit Soni, Dr. Chandrakant Usendi, Dr. Shobha Nanja as moderators, Dr. Shahas Lele, Dr. Naveen Agrawal, and Rajesh Toshani as chairpersons, and we have an interesting session on HOCM. I request chairpersons to introduce our international faculty and my new friend, Professor Srihari Naidu. It's a pleasure having him here. He's probably the highest alcohol septal ablator that I know from my circle. And it's a pleasure to have him. And I also have a surgeon who's going to be talking about Dr. Mehul Shah. So chairpersons, please introduce our speakers.
Hello. Hello. Am I audible?
Yep.
Yeah. So, first of all, is a very nice conference by Dr. Kamal and Cardicon 2022. I invite Dr. Srihari Naidu from USA, and he will be presenting in case of HOCM regarding a septal ablation by alcohol method. So we are proceeding with him. He is a medical director of cardiac catheterization laboratory for HOCM, and he is a former resident of New York Hospital, and he's a professor of medicine in New York Medical Science. So I invite Dr. Srihari Naidu to start.
Thank you. You can unshare your screen, then you want to introduce the surgeon? I'll go ahead. Okay, thank you everybody for inviting me. Kamal, I've never been part of this conference. I've heard great things, and I'm very proud to be here. So thank you for the invitation. You guys can hear me? Okay, yes. Good. So I'm going to talk about alcohol ablation for this patient. And the patient that was described is this young man who's 44 years old with clear HCM with significant obstruction, 22 millimeter septum, clear class 3 symptoms with class 2 heart failure, and severe provocable gradient and typical MRI and EKG findings. So with HCM, it's very clear that once you have obstruction, as you see here in the middle, after an indolent phase, you get all these problems. So the patients go from relatively asymptomatic to mildly symptomatic to profoundly symptomatic due to congestion, heart failure, intermittent syncope, and a higher risk of sudden death. Alcohol ablation or myectomy can mitigate this by interrupting this cycle and decreasing obstruction, decreasing symptoms, and decreasing LVH. So the question is not whether this should be done, and all the guidelines suggest that these should be class 1 indications in these patients. But the real question is, what is the safest way to get the same efficacy and the same survival? I've been doing alcohol ablation for a long time. My first one was 2002, first one on my own, 2004. And I've been involved in multiple textbooks and the guidelines, as well as a training course, proctoring people, traveling around to help people learn this procedure and launch it at their institutions. And then if it's done right, alcohol ablation works quite well. You take patients with severe gradient, provocable Brockenbrough maneuver, and you take them to a phase where there's no gradient, and over a course of about 3 months, this can completely resolve and improve the heart failure state. And you see by echo, this is a 1-year echo on one of my patients. You see the mid septum is still a little thick, but the basal septum looks like a pure surgical result. Wide outflow tract, normal mitral valve. In this patient, you can tell, will have an amazing result and go on for many years with no heart failure without surgery. Alcohol ablation, of course, then has been performed for about 25 to 30 years now. It avoids general anesthesia and intubation, and sternal incision and healing, maintains the clinical benefits of surgery when done well, and has reduced costs in all the studies and reduced length of stay. Patients in the hospital 3 to 4 days. Surgery is also quite good and perfected at centers of excellence, been done for a longer time. But of course, you require a sternotomy, intubation, associated morbidity, and there's more complications, especially as patients get older. There's a lot of good data now for alcohol ablation. This is the largest registry in the United States, showing that 95% of patients end up in class 1 or class 2 NYHA. So these patients do quite well and go on with their life. There's a low mortality, less than 1%, and pacemaker rate has come down to about 6.5% due to all these innovations that you see there. And in all the studies that we've done so far, and this is from the Cleveland Clinic, showing equal survival as well as functional improvement. From Duke, also showing survival is the same for alcohol ablation or myectomy. And in fact, when you adjust for confounders and comorbidities, the alcohol ablation survival rate is actually better than surgery. And even when you look at Mayo, which was a proponent of surgery for many, many years due to a high volume and preference for surgery, they find the survival rate is the same with myectomy and alcohol ablation, even if they selectively take the lower risk patients for myectomy and the higher risk patients for ablation. The survival at 8 to 10 years is exactly the same when matched for age and gender. If you look at long-term survival and other meta-analysis for all-cause mortality, 1.5 versus 1.5, basically for alcohol ablation versus myectomy in terms of annual mortality after these procedures. And for sudden cardiac arrest, it's 0.4% for alcohol ablation per year and 0.5% for myectomy per year. So there's more and more evidence that they're at least the same, if not better, for alcohol ablation. Now, in these large centers of excellence, there are some differences you see. When it's done well, there's still a higher pacemaker rate and redo rate with alcohol ablation, but the mortality rate starts to favor alcohol ablation. And I think I would beg to tell you that patients would rather be alive than have to live with a pacemaker or a redo rate like angioplasty. So in centers of excellence, NYHA class improvement is the same. More than 90 to 95% of patients get to class 1 or 2. Long-term survival is the same. Pacemaker and redo rates may be higher with ablation, but procedural mortality may be higher with surgery. Now that's centers of excellence. When you go to the real world, and this is a study that we published in 2016 in the Journal of American Medical Association, we found that in the real world, things are very different. Death rate is actually much higher with surgery than alcohol ablation. Pacemaker rates are probably about the same in the real world. Stroke is worse for surgery, bleeding is worse for surgery, and renal failure is worse for surgery. And this makes a lot of sense because these are morbid procedures. And my suspicion is there's probably some reporting bias in the large surgical centers, or they're just so good at reducing mortality and they typically don't report these other aspects of surgery. So in the real world, procedural mortality risk is higher with surgery. Pacemaker rate is probably the same, and there's more stroke and renal failure with surgery. And we know this from the angioplasty versus surgery literature too, so it's not a surprise. We then published this year. This is from my group in the NIS data, looking again that surgery has a higher, this is stratified by gender. Surgery has a higher mortality than alcohol ablation, but interestingly, all the pacemaker risk is in the women with getting alcohol ablation. Men actually have a very, very low pacemaker risk, much lower than even having surgery. And again, in the real world, you see surgery has about an 8 to 9% pacemaker rate across the board, not the less than 2% reported in the Centers of Excellence. So death again is lower with alcohol ablation. Pacemaker rate in the real world is actually 9% with surgery. And actually pacemaker rate in men is probably 3 to 4%, is much lower than in women. So who is the best surgical person? This is somebody who is less than 21 years of age, massive LVH, midventricular obstruction with or without an aneurysm, concomitant surgical lesions, membranes in the outflow tract, anomalous papillary muscles, or absence of acceptable septal perforators. Ablation can be done for everybody else. These are older patients with comorbidities, those with particularly perfect anatomy, such as this patient, pre-existing right bundle branch block, and patients who understand the risks and benefits of both, qualify for both, yet favor a more percutaneous approach. So the verdict is clear in this patient. Alcohol ablation is preferred. He's male. That's a low risk of pacemaker of 3 to 4%. The septum is less than 25. We can get that septum with alcohol. There's a good first septal perforator to that septum. There's a lower pacemaker rate compared to women or surgery overall. Lower procedural mortality than surgery, lower cost than surgery, lower length of stay than surgery, same functional improvement and same long-term survival. Thank you very much.
Thank you, Dr. Naidu. And we are proceeding with Dr. Mehul Shah. He is an eminent and most reputed cardiac surgeon of Ahmedabad city, and he's working with Apex Hospital. and he did his study from Ahmedabad and postgraduate and super specialty also, and he was attached with UN Mehta Hospital, and now he's a consultant in Ahmedabad in a Apex Art Institute. So we are proceeding with a myectomy is a surgical aspect in case of HOCM. Hello, Dr. Mehul Shah.
Yes, just we are. Okay.
Yes.
Hello, friends. I'm going to talk about the surgical aspects of HOC.
Sir, sorry to interrupt you. Can you please on a slideshow mode?
Sorry?
Put it on a slideshow mode, sir. Yes, sir. Right.
Okay. Let me first briefly introduce the operation septal myomectomy. 1 in 500 of general population has HCM, and around 70% of these may have variable degree of obstruction. That is why treatment of such common pathology is very important. Surgical myotomy was done as early as in 1958. It was Dr. Andrew Morrow who standardized and popularized the surgery in 78. Later, few modifications were done by Dr. Mesmer in 94. At present, we are doing transaortic extended myomectomy. Let me discuss the physiological effects of septal myomectomy. First, there is immediate drop in the pressure gradient after surgery. This is the immediate effect. In response to reduction in the pressure gradient, there is improvement in the systolic function in the free wall. Later, there is regression of LV hypertrophy that improves the diastolic function. Moreover, there is reduction in LV mass greater than that attributable to surgical removal. The SAM disappears, MR regresses, there is reduction in LA size 2. All this correlate with increase in functional capacity and improvement in NYHA class. More importantly, this translates in survival benefit after septal myomectomy. Talking about the advantages of surgery. Surgery is safe, predictable, and durable. It is a physiological treatment that has a potential to offer a cure. The mortality rate today is 1%, and complication rate is around 2 to 3%. After surgery, there is long-lasting relief from obstruction, and there is very low reintervention rate of about 1 to 2% versus 15 to 25% after alcohol ablation. These are the various reports quoted in many international publications. There is minimal residual gradient of 0 to 10 millimeter after surgery, while up to 30% of patients after alcohol ablation have gradients of 30 or more. This can predispose to fatal arrhythmias. Some more advantages of surgery: low incidence of requirement of permanent pacemaker after surgery, around 3.5% against 9 to 15% after alcohol ablation. There is greater improvement in NYHA class after surgery than alcohol ablation. Septal myomectomy is more effective in treating thick septum and severely symptomatic patients. Residual obstruction after alcohol ablation are best treated with surgery. Concomitant mitral valve pathology can be easily corrected during surgery. mid-ventricular obstruction is best tackled by surgical resection. I have to mention this high-risk group. Patients coming for surgery after unsuccessful alcohol ablation fall in high-risk group. They have higher incidence of complete heart block, cardiac failure, and even higher mortality. That is why, in first place, young patients should be treated with surgery as primary treatment to avoid such an outcome. Who are not suitable? Now, elderly patients with comorbidities like those with risk of severe stroke, bilateral pulmonary disease, and those in whom cardiopulmonary bypass is contraindicated are not suitable for surgery. I have to share a concern. At present, only tertiary centers are doing most number of cases across the globe. And even there, numbers of septal myomectomy are falling. Most busy centers doing 30 to 50 cases a year. Septal myomectomy is a specialized procedure and results are operator dependent. So concept of super subspecialization should be applied to it. More and more surgeons should take interest and expertise this very effective gold standard operation. I conclude by saying that though there is no difference in hospital mortality between the two procedures, surgical treatment is superior in long term. Therefore, surgery should be the preferred treatment. Our patient is young with a high gradient, severely symptomatic. I would certainly like to operate on him. Thank you, Dr. Kamal Sharma, for giving me the opportunity to present this.
Thank you very much. Fantastic talks. Professor Naidu and Dr. Mehul Shah, both of them are master of the subject. Over to chairpersons and moderators for the questions. I would just try to trigger a discussion. Wouldn't be the clinical profile be deciding factor in choosing what to do for the patient? Because we know now how elderlies would behave as compared to younger ones, how a presence of an LBBB pre-existing would make a case more for, say, myomectomy, or say RBBB pre-existing, and you do a myomectomy, you end up with a complete heart block, actually. So wouldn't the clinical cases per se scenario beyond what has been mentioned here would actually be helping us in choosing the therapy? We now know that the need for pacemaker is less for, say, a good myomectomy compared to, say, alcohol septal ablation. Recurrence rates may be more with LV function issues. I would like to have your comments on that. Professor Naidu first, and then Dr. Mehul.
Yeah, sure. So, obviously I did my presentation to stimulate discussion in the debate, but in our practice, we send about 60% of patients for alcohol ablation. The other 40% I take them through myectomy. So we have surgeons who do that. And we have a heart team approach where all the patients are presented and we discuss. I think that in general, I usually send patients less than 45 or 50 to surgery. However, it really depends on anatomy. If the anatomy shows that it's a very focal LVH of the basal septum and a good septal perforator, and there's not much more thickening, there's nothing wrong with the mitral valve like in this patient, and there's not a whole lot of fibrosis, which I think is very important. You have 15%, but you don't have 25, 30%. These patients usually have obstruction as the main etiology of their symptoms, and if the alcohol ablation can get that out of the way, they go back to class 1. So a lot of it is about predicting which patients will have the best efficacy. If you have a young patient that has massive hypertrophy, 2.5 to 3 centimeters that extends more distally to the base of the papillary muscle, that's an area where there's so much obstruction, and there's also concomitant diastolic dysfunction, both because of cavity size reduction as well as the fibrosis. Those patients do better with surgery. So really it depends on those factors and not a one size fits all. So age alone is not a cut point. I agree with the pacemaker issues in terms of pre-existing bundle and branch block. Obviously, we will send some of those to surgery routinely because the pacemaker rate is much less. And on the opposite side, some of them won't get surgery because the pacemaker rate is too high in that situation. The last thing I'll comment on is I've done almost 300 alcohol ablations. I've not sent one, none of them have gone for surgery. And I can say that confidently because compared to Mayo Clinic and Cleveland Clinic, where patients get lost to follow-up because they don't live locally, all my patients live locally. I mean, I'm in Manhattan. So I have the 3 states, 25 million people. I follow all my alcohol ablations for 15, 20 years. I know if they need more ablation, if they have to cross over to surgery. On the flip side, I've done up to 10 patients who've had myectomy who need an alcohol ablation. And so it can go both ways. I think it really depends on the expertise of the facility. And oftentimes those anecdotes drive what they believe in terms of which ones are better.
Mehul bhai, your comments?
Yes, I agree with you, Kamal. Each patient is different, and we have to do what is best for that particular patient.
Chairpersons, we have Dr. Thoshani is a cardiac anesthetist. So I'm sure he's there for both the cases. I mean, if he's to come for myomectomy or he has to myomectomy or for alcohol septal ablation, you'll keep a cardiac anesthetist standby. So how do you think how these patients do behave?
Yes, most of the time the role of anesthetist is very important in case of surgery is concerned, because assessment of septal thickening, we are using transesophageal echocardiography and we are assessing how much surgeon has to cut, because there is high chances of formation of ventricular septal defect if you are doing an over enthusiastically resection. So this part is very important. After coming off bypass, you have to check for the proper dissection is happening or not. Is there any LVOT obstruction? What's the gradient? So these are the parameters. If we can look properly, then we are giving a best add-on treatment to the patient in post-operative outcome.
We have
I would like to mention that.
Go ahead.
Yeah, I would like to mention that we have to have a transesophageal echo. Without that, if we don't have, we can't do the surgery.
Right.
Yeah, in the surgical suite, they have TEE, and we use isoprel. We go 1, 2, 3, 4 of isoprel before we start cutting, and we go back to the same dose that provoked the severe obstruction after the procedure to make sure that everything is gone away. I've insisted on that because I've seen at other institutions patients come back with more distal obstruction or problems with the mitral valve, and so we make sure that all that obstruction is gone, and they are heavily dependent on TEE as well as the anesthesiologist to make sure that happens. Yeah. On the flip side, we don't use anesthesia.
I think mavacamten is available in US. We don't have it in India. Are you seeing, is it the statin of HOCM? We see a lot of statins actually bringing more acute coronaries in cardiology. Does mavacamten does change the gradient or symptoms that much that it's going to be the so-called statins of HOCM?
Yeah, so let me answer that. First, I want to answer the question that we don't use anesthesia in alcohol ablation. My patients are awake. They get a little bit of morphine, but I talk to them the whole time. So they're wide awake. The risks are much, much lower in that situation, and you can really provoke good gradients when they're wide awake. So that's part of the reason I can affirm that the gradients go away, because they're not hidden by the anesthesia. Second thing is we were involved in the mavacamten trials in Valor. Valor will be presented as a late-breaking clinical trial at ACC 2022 in about 6 weeks from now. This is a trial comparing mavacamten versus placebo, standard of care, in patients who are already selected for either myectomy or alcohol ablation. And the primary result at 6 months is what percentage of patients still qualify for septal reduction therapy at 6 months in the mavacamten group versus the placebo group. I know the results, but I can't say the results. So those results will be out, and it is supposed to be simultaneously published in New England Journal of Medicine. We're hoping for that. We have not heard that yet. In the preliminary studies, though, mavacamten does appear to, in the phase 2 studies, decrease the LV outflow tract obstruction significantly. It is difficult to titrate. You have to be careful and go up slowly in these and echo guided. So they're not officially available in FDA yet. We're hoping in second quarter, but the full trials will come out. Now, in the preliminary data, it looks like myectomy and ablation increased the peak VO2 on CPET by about 4 to 6 points, whereas mavacamten in those trials have increased it about 1.5, which is very similar to exercise and losing weight. It's not to say that those medications aren't strong, because most people can't exercise and lose weight, but they will do at least that benefit. And the real question is that enough to get the threshold down to SRT? And that's what the trial is going to show us. But I do think that most patients are benefiting from it. The question is it benefiting enough? Will they prefer an oral agent versus a more permanent cure, as Dr. Shah mentioned, and whether there are any long-term hazards to these medications?
The chairpersons, moderators, if there are any questions, Dr. Naveen.
Yes, Kamal, I can say that this is only surgery where anesthetist can insist the surgeon, you should not go beyond this point. This is only surgery that anesthetist can suggest to the surgeon not to go beyond this point.
It is a difficult surgery. We're also doing more apical myectomy. I don't know, Dr. Shah, are you doing those there? We see more and more midventricular obstruction with apical aneurysm, and we know the aneurysms can cause scar, they can cause thrombus, they can cause arrhythmia. So I'm pushing my surgeons to do apical approaches, or both apical and transaortic approaches, reach through the midventricle, get rid of the, tie off the aneurysm and see how patients do. And we've had about 10 of those patients, not many, but they've so far done well over the past 4 or 5 years.
Yeah, I think all my patients that Dr. Mehul has operated, he's gone transaortic, and I mean,
transaortic, yes.
None of them had a VSR. So
yeah,
that's the good thing.
No, but I think, meaning I think that some of these midventricular with the ballooning apex, he might want to start going apically for those patients and getting rid of the aneurysm. We've had good results in young people. Older patients fall apart, but in the young patients, they seem to do well.
Yeah.
Moderators, Chair, if there is anything, Dr. Amit, Dr. Shobhanan, if you have any comments.
I will address also, if I have some time, the issue of education. Dr. Shah mentioned this, that is declining volumes for surgery. I think that's true. I think that the problem is that there's few centers who do it, so those places have to train it, and 30 to 50 a year may not be enough to train somebody to go out somewhere else and do it, so it becomes challenging. I don't know what the solution is to that is, because I do think that we need both surgery and ablation. I know there's no question. I don't offer my patients a choice usually. I usually decide which one's better for them. And if it is surgery, I tell them I'm going to get you through it, and you need the surgery, and this is it. And they usually trust me, and we go for that. And the surgeons are fabulous here. Dr. Spielvogel, Dr. Malik, and those two do all of our surgeries together with our cardiac anesthesiologists. So I'm confident about that. But I think the problem in surgery is that they're not going out and training. So I mentioned that I run an alcohol ablation course. I'm willing to go to hospitals and do their cases with them. And I think that's something that surgeons are busy too, but I think people have to do that. Oftentimes people are concerned about other people doing the procedures, but if we don't do that, then everything dies. And so we need to keep these things alive.
Yeah. Yeah, I agree with you. Yeah, that's right.
Dr. Amit, Dr. Chandrakant, Dr. Shobhanand, if you have any comments.
Sir, I would like to know, I have a question to Naidu sir, that is he using mavacamten in post-alcohol septal patient, ablation patient?
So right now it's not approved outside. So I haven't used it in anybody in the real world. I've only used it as part of the clinical trials, randomized. And those patients are not allowed in the clinical trial. That being said, I think it can be used for patients who have residual gradients after either surgery or alcohol ablation in the future, off-label. I will tell you that I know that historically alcohol ablation gets this issue with more residual obstruction, but really it's about planning, just like surgery. You can tell which part of the muscle needs to be ablated. I don't have any failures. I mean, you can come see. I've been doing it for a long time. And, I teach my fellows, they rotate through the practice as well. And then you can't lie with alcohol ablation and myectomy, because every single patient is being read by the echo lab. If it's not being done right, I'm going to hear about it very quickly, and the program won't grow. So these procedures do well, and but it has to go to the right people. I think one of the challenges in the real world, as I showed you, is it's not as good in the real world as it is in centers of excellence. I haven't had any of that, and we haven't had any VSDs for surgery. It really has to do with volume. And I think that's why if it's done in the best places, you can truly choose the right procedure based on the operator's expertise and decision-making of a heart team and expect the appropriate result without having to have many crossovers. I feel a crossover is a failure. Surgery to ablation is a failure. Ablation to surgery is a failure. Redo is not a failure, because I oftentimes will purposefully not do as many septals, hoping that I got enough without having to use a pacemaker. And I'll come back in 6 months to a year to do a little bit more if I need to. And the combination of the two separated results has a lower pacemaker rate than doing both of them in the same sitting. And so I offer that to the patient because it's a better safe result. and lower pacemaker risk, even though people may criticize that I have to redo. But redo, we're all interventional cardiologists and people, we do redos. Redo is not a problem. Patients never complain about a redo alcohol ablation. They've had it once, it's not been a big deal.
Yes.
So how small a septal is not worth enough,
That's a good question, because people think that the septals are small. Now we know from CTOs that these septals are long and they can go all over the place. So remember, the septal is not just the distribution of the septal. It's a lattice network in the septum. If I take a small septum and give more alcohol, I will diffuse into the neighboring area of the septum through that lattice. So you don't need to have a large septum. You need to have a septal to that area in the right location, and then you can give as much alcohol as you want, depending on the timing. I mean, obviously you need to have a balloon in there. So you need a 1.5, a 1.015 like that. At 1.5 probably is the lowest you can do. But oftentimes you give a little intracoronary nitro and the septum is larger than you think. And then you can reevaluate.
Thank you very much. Thank you. We had a very wonderful and lively learning session here. So I think we had a wonderful session. I would thank from my bottom of my heart, my friend, Professor Sri Hari Naidu and Dr. Mehul Shah and all the chairperson and moderators for this wonderful session. Thank you very much. Stay connected and hope to see you, Professor Naidu, soon, sometime, maybe next year, physically in the conference here in India.
Thank you.
Take care. Bye-bye. Thank you. So we move up to our next session. And for this session, it's my honor and privilege to invite Professor Dr. Tejas Patel, Dr. Vishal Sharma and Dr. Joel Shah, and the moderators Parminder Singh, Dr. Tushar Nikam and Dr. Prakesh Vajirani. But when Dr. Tejas Patel is there, I think nobody else should be speaking. I think with the core of my heart, from the bottom of my heart, I have very high regards for Sir. Sir is one of the pioneers of multiple things. And I always tell him that, sir, I respect your vision. When people were looking at femorals, you were looking at radials. And when people have started learning radials, sir is looking at robots. And when I tell this to him, sir, I appreciate your vision, he jokingly tells Kamal, I wear the glasses. I don't have the vision. But sir, hats off to you, and a pleasure to have you, sir. On speakers for the session is going to be Dr. Prashant Vajirani. He's an interventional cardiologist with teaching experience at Ujjain, and he has been trained in complex PCI at Tokyo in Japan with Mr. Hamazaki in Japan for a short duration, also with the Terremote training session, and he's been reviewer for multiple journals. Our next speaker, who's going to talk about IVUS, and the other person who's debating against us is no smaller a demigod. Next slide, we have Dr. N.K. Mahesh. He's been there with us for 3 years now in succession. Dr. Mahesh, thank you for being with us always. And it's always a pleasure, though he's been talking about different things a lot of times, but I believe OCT is talking for the second time. So pleasure to have him. He's a head of the department, Apollo Adelux Hospital, observer at Mount Sinai, member of CSI, of course, and fellow of American and European Society of Cardiology. Next slide. And I would hand over the session to Dr. Tejas Patel and all the chairpersons and and the referees and the scorers. Over to you for the case. Can you go back, please? Can you go back, please, for the case? So this is the case, 66-year-old male NSTMI, in-stent restenosis, ostial proximal RCA 4/28 implanted 8 months back, EGFR 44, preferred mode of imaging. Over to you, sir.
Yeah, Kamal, I think let us hear both the speakers, and we will have ample time to discuss pros and cons of both the imaging technology. I'm using both the technologies nowadays, left, right, and center. OCT, in fact, I learned OCT first, and on the basis of my understanding of OCT, I have learned high definition IVUS. And in our lab, almost 35–40% of the cases are image guided. So I will like both the speakers to present their cases, and then we can have good informal discussion. Yes.
Over to you, Prashant.
Thank you, sir. So we'll begin with the session. So dissection of the details given. So we have a osteoproximal RCA, and the previous stent was a 4 mm stent. So it is a large vessel diameter, and it is an early stent failure because the patient has come back with ISR within 8 months, and he has a renal insufficiency of GFR 44, which is stage 3B. So what more do you want to know now for the patient, like patient factors are whether he's a diabetic, whether he has other comorbidities, whether a stent which was placed in the previous event, whether it was a stable event or it was an ACS, whether he's a drug defaulter, whether he was on DAPT, which one, statins, and whether imaging was used in the previous procedure, whether malapposition was there, under expansion, what was his MSA at that time, whether there was plaque burden at the stent edges, and calcium, and etc. So why do I want to know all these patient procedure and lesion factors? Because all of these will ultimately lead to the ISR. So when we are talking about ISR in the drug-eluting stent era, according to the ARC Academic Research Consortium definition, they have still not included or updated OCT in the definition. But nevertheless, whenever you are using IVUS or OCT, your minimal cross-sectional area according to the definition should be less than 4 millimeters square, and in LM should be less than 6 millimeters square. So we all use this reporting for ISR, but by the Mehran classification, but this is mainly done for the BMS stent, which Dr. Mehran has invented. And now when we have got a visor, we have to report it by the Wexman's ISR classification. And because now we come to know about the mechanical and the biological causes. Mechanical like the stent under expansion and the stent fractures, and biological like the neointimal hyperplasia and the neoatherosclerosis. So why it is important to differentiate these causes? Because we know that early stent failure will be more of mechanical, while late stent failures might be because of more of the neoatherosclerosis. So whenever we are approaching a stent failure patient in 2022, two things are most important. One is imaging, and second is one of these fancy items you should be having in your cath lab, which is either a scoring or a cutting balloon, or at least an NC balloon, or a drug-eluting balloon, the DCB, and other things like a rota or a laser. Because this is how, depending upon what you have found out on imaging, what you have, like, do you have a underexpanded stent, malapose stent, or do you have NIH, do you have neoatherosclerosis? You will need one of these fancy balloons, and without which you will not be able to do justice to your patient. So now what do we want to know more with the imaging? We all in our first year cardiology were taught this Glagos phenomena, in which in the atherosclerotic vessel, this external elastic membrane expands. And this is what is called the positive remodeling of the vessel wall. And this can be made out only by the IVUS because of this greater depth penetration. So because of which the stent might have been under expanded. We also want to know about the plaque volume, the morphology, the residual plaque burden at the edges, whether there was any stent fractures or calcifications. So if I want you to compare the OCT and the IVUS images, you can make out the HD IVUS images of the external elastic membrane is more clearly discernible by the HD IVUS only, and whether OCT cannot be doing justice by making you know the EEM, because there is no penetration with the OCT. And because of this greater EEM delineation by IVUS, you will have greater lumen areas ultimately by IVUS. And you would have seen in the past that histological image is same as OCT comparing to histopathological image. But now HD IVUS will also give you the same images, because apart from the EEM demarcation, the fibrofatty, the lipid core is very much visible by IVUS and not by OCT, because because of the OCT signals, they get strongly attenuated by the lipids. If you make out this, we have all done plasties to such lipid-rich atheromatous necrotic core patients, and in which you'll see this OCT, you're almost blinded because of so much lipid. Whereas in IVUS, you'll be able to differentiate them, and you'll make out the correct EEM and make out greater lumen areas. So why is this happening? Because IVUS has a greater depth penetration with no need for any luminal blood clearance. And also, when you are using IVUS in a patient of an ostial lesion, then OCT will not help you much. And also for adequate plaque burden and characterization, then IVUS is preferred. So if you want to do a correct sizing of the vessel, sizing of the lumen, IVUS scores over. Adequate assessment of plaque distribution and characterization, again, IVUS has plus points. And if it is a ostial location, renal dysfunction, CHF, and live real time can be done only with IVUS. So similar to our today's patient's case, this patient had an LED ISR and LED implanted, and then after 10 months, he came back with an ISR, and when IVUS was done, you can see the distal reference in the normal vessel was 6.8 millimeters square on IVUS, and his in-stent CSA was 3 millimeters square. So that is vessel diameter is almost double the stent diameter. Now, why has this happened? Because this is the under-expanded stent. As you can see, there is no stent malapposition. Stent malapposition, stent under-expansion are two different things. So here the stent is well opposed, but it is under-expanded. This has happened because the EEM has not been taken into account. So visualization of the EEM with IVUS enables one to acquire a larger MSA compared with OCT. And this, as I discussed, why this is happening, because of greater soft tissue penetration and blood penetration, which is not there with OCT. OCT has excellent surface detail. The macrophages can be seen only with the OCT, but not with the IVUS. So you can see this very crisp images. If you see this A image, very crisp images of HD IVUS, where you can differentiate exactly the intima, the media, the adventitia, which was not very well initially with the other IVUS before the non-HD IVUS. And if you see this, the stent stress, the stent malapposition, calcium, was all very crisp images now seen with HD IVUS. And if you see this image C, the same thing, the fibrofatty thing, which is seen on media, is not very clearly seen on the OCT. This is because superior tissue penetration of IVUS permits full vessel evaluation through the fibrous and lipid plaque, whereas OCT signals are attenuated by lipid. So gone are the days when people used to say that you cannot measure your thin fibrous cap on IVUS. Now you can measure with HD IVUS. You can even measure your thin cap fibrous, and you can also make out the exact extent of your lipid necrotic core and your EM on the HD IVUS. So we discussed this, the exact extent of the plaque burden can be made out. And these are images on the Philips machine. This is not even HD IVUS, this image stent malapposition, and this is the intimal dissection. And this is now the chroma-4 technology, where when you have a stent which is malapposed, you will be able to see the blood RBCs which are going underneath, and you can make it out easier. So same histological pictures you can even make out now on HD IVUS. This is myoatherosclerosis, which is made out on the IVUS. The same thing on the histopathology, and the same thing which is made out on the OCT. So HD IVUS is now no less than the OCT also. And stent malapposition, previously it was difficult, now it is very easier to make it out. And gone are the days when people used to say that now you cannot make out calcium nodules cannot be made out on HD IVUS. All forms of calcium, whether superficial, deep, calcium plaques, nodules, can be made out on HD IVUS. And you can also even grade them. You can even make out the arcs, and the different gradings which are available for calcium can be done on the HD IVUS. So for correct vessel and vessel diameter and correct plaque length and assessment, HD IVUS should be used. So now coming to IVUS or OCT. So for better resolution and intimate surface details, the OCT will be favored. Whether for better penetration and correct vessel sizing, IVUS will be favored. So for plaque volume, morphology, residual plaque burden, its stent edges, and vessel sizing, IVUS has more points. Stent under expansion, MSA, IVUS has more points. It is calcification, stent fractures, malapposition, macrophages, of course, OCT will be favored. And when there is an osteoproximal lesion, a large vessel, and impaired renal function, then IVUS will be favored. So impaired renal function, I'm sure my speaker will tell more about saline OCT, but in this patient is not a patient for saline OCT, because it is a complete no-no for big proximal vessels, ostial and left maze, while saline OCTs can be done for calcific milieu and small vessels. And you can also use colloids in patients who have a low GFR, but they are also not renal friendly. Availability is one issue, but they also have many anaphylactoid reactions. So is there any head-to-head trial evidence with IVUS and OT? So multiple trials which were done, and one is a 70 small trial by Habara et al, which showed that the OCT guidance for stent implantation was associated with smaller stent expansion and more frequent significant residual reference segment stenosis as compared to IVUS. But it was a small study, 70 patient, which showed a greater stent expansion and smaller stent edge plaque burden with IVUS as compared to OCT. So another trial, opinion trial, it showed that OCT had a smaller MSA after PCI with a numerically smaller mean stent expansion index than the IVUS, and of course lesser contrast used in IVUS. But on follow-up at 8 to 10 month study, they also found a lower incidence of uncovered strut in IVUS guided PCI than the OCT group. So the same thing was found in the OPUS class study, that the higher MSAs were seen in patients who were IVUS guided rather than OCT. So ultimate summary was that the bigger the better concept, that 1 millimeter increase in the MSA is associated with 20% decrease in ISR. So the long-term outcome ultimately depends more on the result which you achieved rather than the device which you used. So there has also been one study of OCT as compared to angioscopy, not angiography, but angioscopy, where I would like to highlight that 18 OCT guided, where it classified that these are non-lipid plaques. Actually on angioscopy, they were all yellow plaques and white plaques and thrombus and ruptured plaques. So in this, it was found that OCT analysis was underestimating instability of instant restenotic lesions. So my concerns for OCT use in this patient, ISR in a large vessel, ostial location, it was an aorta ostial where the coverage of the exact ostium was not done. So where OCT will not be much useful. Also, we need to look for the EM, the positive remodeling, and the correct vessel sizing. And it is impossible with just saline OCT to get good blood clearance, because all we'll get is a blood walls. Some amount of contrast will be required for a good clearance, and with an impaired GFR, it is unfavorable in the era of zero contrast IVUS guided PCI. Also, plaque morphology and volume assessment at edges will have to be looked for. So for these reasons, IVUS will be scoring over. Also, if you go to the OCT information on the manufacturer side, they intend that OCT is used to use for only for up to 3.5 millimeter vessel, but we also use it up to 4 millimeters. So the take home is, whenever you want surface analysis for a plaque prolapse, tissue prolapse, more visible dissections, thrombus, macrophages, then OCT has more points. And when you want depth analysis, sizing, fibrofatty plaques, lipid-rich plaques, large coronaries more than 4 mm, LMs, LV dysfunction, then IVUS has more points. So, but if you have a cath lab visitor and want to show off your fancy new rich toy, then you can show them this 3D orientation with the OCT, or now you also have this colorful imaging of virtual histology IVUS, which is available. So in conclusion, HD IVUS identifies all histopathological stages of atherosclerosis, including your thin-capped plaque and all the mechanical and biological causes of stent failure, which we discussed. And HD IVUS, due to better depth penetration, has an edge over OCT in estimating correct vessel size and acquire larger MSA. HD IVUS is real-time, live, without any need for blood clearance, unlike OCT. OCT will need some contrast even if saline run style, which is usually not possible in large proximal vessels and predominantly ostial, without which you'll just get blood swirls. So early stent failures, HD IVUS is preferable, while in late stent failures, OCT might have an edge. Thank you.
So I think we can go ahead with second speaker, and then we will discuss everything.
Sir, you are not audible. NK Mahesh, sir?
Hello, can you hear me now?
No, I'm fine.
Yeah, so yeah, you can start your talk, Dr. Mahesh, and once it is over, we will discuss it out, everything.
I thank Dr. Kamal Sharma for this opportunity. It's been 3rd year in a row. Dr. Tejas Patel, sir, big fan, big admirer. We really appreciate your innovative ways of handling interventional cardiology. And I'd like to quote your statement, which says that I'm just an angioplastic. So I just have no theory to say. Prashant has done all the job that is done to be done. So I will just show the case and a few slides to show the differences. That's all. Greetings from the Parimala Heart Institute. It's a multicentric heart institute in a small village. So we have all these modes, which Dr. Prashant was trying to say. I can have a tissue mode. I can have a Lesion mode. I can have a stent-only mode, which will tell me where all the problems. I can also have a fly-through mode. Although they appeared fancy to you, they give an immense amount of information if used correctly. So in addition to that, I have angio co-registration. Angio co-registration is very, very important, specifically when you would like to find out areas of underdilatation, areas of where the stents are not covered properly. So angio co-registration is a big advantage. And in addition to that, this is the way in which the angio co-registration shows you the red plaques where the areas are not opposed well. And see the amount of techniques I have to find out whether there is the stent is opposed well. I have an apposition indication bar. The red ones show you're in trouble more than 300 microns. I have an L mode. I have a stent road map that you can see here. And I've also got a dissection, a cross-sectional view where you can see the red dots there. So if this OCT was done previous to in the original case of the case we're discussing, probably we would not have discussed this case. And if it was deployed properly, it wouldn't have happened. So now see the possibilities. Although there is 1, 2, 3, 4, it is basically neointimal hyperplasia, neoatherosclerosis, and stent expansion. Whatever you do, as Dr. Prashant was saying, IVUS is no less than OCT. That means IVUS is actually not as great as OCT. It is clear from this histopathology and OCT comparisons, homogeneous, bright, uniform layer, heterogeneous composition with instant necrotic core. Everything that you see histopathology can practically be seen in this IVUS image. And stent under expansion requires no great shades. But the cause of an ISR is invariably a combination of these, and it is not that it's purely neointimal hyperplasia or purely stent under expansion. I don't have a proximal RCA ISR. So I'll show you a proximal RCA disease, which I have imaged with this thing. You can see it's a huge vessel. It's a 4 millimeter vessel. I actually ended up putting a 4 millimeter stent in this vessel. This is pre-dilation. The vessel has been pre-dilated. After the pre-dilatation of the distal segment also, we got a flow through this. And then I did the first pre-run OCT, pre-run RCA proximal. Now you can see what is the information that you require, what is the type of the plaque that you have. It is predominantly fibrous. What is the amount of calcium you have? Little to none, very less calcium. And there is, you can see that there is a fibrous plaque. So all the information that you want on the about the vessel is available from here. It tells you about the diameters, maximum distally being 2.82, 2.33, in the mid 2.24, 2.45, 1.05 is the tightest area, and 1.76. This is the dimensions that you wanted. Area has been given to you, and then you do a post dilatation and you deploy a stent. This time we have used actually BVS or BRS, whatever they're called. It's a scaffold. Post scaffold, you deploy post dialysis, and this is the final image. Now I'll show you the images of the post pullback after the image. Now you can see that the whole area can be seen as clearly as you want to see. You can see there is no stent malapposition. The vessel is absolutely clearly seen. And this is the post pullback cross section to make it very clear. This is the only thing that you don't see when you do a saline OCT. That the small dots will be there, but that does not disable you from identifying what is the type of lesion and the opposition of the stents. So post pullback, you can get a 3D reconstruction to show, and then you can see an OCT pullback, the one so-called fancy OCT pullback. This is an OCT 3D pullback of a MERS where you don't see any stent struts anymore. And this is our final area. So how do I calculate the final area? Distal maximum 3.74. The stent opposition is very good. You can see the stent struts. And this is maximum 4.11 millimeter piece. Diameter is 4 millimeters. And I have shown you very clearly all the layers are in this OCT image. This is 4.59 millimeter diameter. And the surface area can be done. All this was done by saline. So this is the first article that I published in Indian Heart Journal, study of saline optical coherence tomography guided percutaneous invention. This was the first article. This was a pilot study, and that showed, these are the images we got from this pilot study, which shows at TCFA, calcium nodule, calcium dissection, everything can be seen. Double layered stent, ISR, red thrombus, cholesterol crystal, all the works. And this is how a saline OCT pullback looks like. There is no contrast. So saline was safe and effective as a flush media for coronary FD OCT. Following which questions arose as to, okay, what happens to the dimensions of the vessel? What happens to the exact length of the lesion for when you do a saline versus a contrast OCT? So we brought out the second article, saline as an alternative to radio contrast for optical coherence tomography guided percutaneous invention, a prospective comparison, where we compared in 26 runs, contrast 13 and saline 13, MLA, proximal reference area, distal reference area, and percentage of area stenosis. So all the factors were combined. And this is one of the pictures from the presentation we find. You will not find hardly any difference in the OCT and the contrast. Unless I tell you this is OCT, this is contrast, and this is saline, we may not be able to differentiate. And in this study, it was proven that there is using heparinized saline as a flushing media for coronary FD OCT may result in vessel dimensions that are comparable with contrast. Heparinized saline may be used as a contrast, saving alternate for FD OCT during PCO optimization. So that take-home message was saline OCT is feasible and safe. All morphologies can be seen. Saline does not significantly affect the measured parameters of this PCI. So in this case, I would say where I have shown you a 4.5 millimeter vessel OCT done with saline proximal RCA, the same thing can be applied to this case, and all the parameters which should tell you whatever is the type of the lesion that led to the ISR, what is the result of the cutting balloon on the ISR, what is the result of the stenting on the ISR, can easily be defined and clearly shown with OCT. Only thing is that angio-co-registration with saline is still lacking, in which case you have to use 1:1 saline and contrast. So thank you. Here I rest my case.
Thank you, both the speakers. Yeah, so both the speakers have put their case very strongly. Sorry, are you guys able to hear me properly?
Yes, sir. You are audible.
Yeah. So, my understanding of imaging says that first thing is whatever you are comfortable with and whatever your eyes are comfortable with to see and interpret properly for your patient is a good modality for you. Both modalities have their pluses and minuses, I agree. Because we have explored OCT too much. And nowadays we are, significantly exploring high definition IVUS. One thing I will like to tell that like OCT cannot be done in left main. That is what is the Western recommendation by and large. But 95% of the Indian left mains are perfect for OCT evaluation. And actually, we have now almost 90 cases of left main bifurcation done with OCT evaluation, and we are going to publish with the follow-up. So, because our left mains are never more than 5, and 5 is good enough if you inject well, and it will be seen. Only problem is the ostial left main is a problem, and sometimes when you have a contrast issue, when you want to really restrict your contrast, then it is a bit of problem. As far as high definition IVUS is concerned, I have started liking that modality also, and I don't know how I'm going to, use both the technologies in the best interest of my patient. I will simply give you one example. Today itself,
So you're not audible.
I think we have connection issues with any other panel members, Dr. Vishal, Dr. Joel, Parminder, Dr. Anand.
I would like to just ask the speakers that what is their percentage of use of both the images in their contemporary practice? Means how frequently do you use IVUS or OCT, sir, in your practice? So I think.
So I have the HD IVUS of Philips with the angio tri-core registration, which is a fabulous thing. So that gives me angio core registration as well as the pressure wire core registration. The tri-core registration of the Philips HD IVUS is what I am now looking at. I'm just learning how to do things properly. I'm not an expert yet, but my go-to imaging still happens to be OCT. Since I am not an expert at the IVUS so far, it will be about 80-20. And I do imaging in about 30 to 35% of my cases.
Prashant, of late, how many times you're doing IVUS?
So we are doing only IVUS at present. We don't have the OCT, although we had done OCT in between when we were trying to sort out which one to buy for the hospital. So now we are doing HD IVUS almost daily. We are doing it, and also we are also reusing it. So up to 5 times we are just ETOing it and then using, and we are getting.
Vishal has access to both. So Vishal, what do you use more?
I think as far as the cost issues are concerned, I think IVUS scores over OCT, frankly speaking, at institution level. But yes, as Sir said, Tejas Sir said, nowadays left main also, especially the Indian left mains, they are well visible OCT. I think imaging wise, OCT scores over IVUS as far as characterization and the clarity is concerned. It also depends upon the user's preference, or what he uses and what he's familiar with, as Tejas Sir said. So I think that depends on the familiarity. There are some cost issues. Otherwise, both have, I think, equal scores as far as the imaging and the results are concerned.
Dr. Joel?
Dr. Joel, unmute please.
Yeah, of late we are using started using OCTs. Previously we were only doing IVAS. But as Tejas sir said, I would agree with Tejas sir that whichever modality you are comfortable and whichever with modality you give good result, you should use that. There are certain aspects, as sir said, ostial left main and their OCT has some issues. But if you go with ostial LED circ lesions, bifurcation LED lesions, OCT images are much more better. So whichever mode is comfortable, I think we should go for it. And regarding the renal issues, nowadays, lesser contrast and with saline, we can always get good images with OCTs.
Yeah. Question moderators have comments. So can we conclude? So it is 1 minute, 2 minutes early. We can conclude.
Yeah, I think we had a wonderful session. Thank you, both the speakers, Dr. K. Mahesh and Dr. Prashant. Thank you, Chair. I think Dr. Tejas is here. We can hear from him. Sir, are we audible? Sir, yes, sir. I think you have connected back. Sir, please unmute. We can see you now.
Sorry for the interruption on
yes,
our
sir, no issues, sir. We were just taking the take-home message, and you are right at the time of giving the take-home message, sir.
So,
please, sir, go ahead.
Yeah. So, because of the time constraint, I will not be discussing the thing what I was supposed to discuss. But I personally feel that as far as the tissue characterization part is concerned, OCT scores over high definition IVAS even today. Now, angio co-registration was previously only with OCT, but in our lab, like we have angio co-registration available for both IVAS as well as OCT. So that is almost equal. Secondly, looking at intramural hematoma, subintimal hematoma, and even the smaller dissections and small strand strut fracture and all those things, I think definitely high definition IVAS plays a great role. And there are good number of patients when you want to finish your stenting in 20-25 cc's of busy pack, where you have no choice. Like a patient who has anterior wall MI who presents with you a little late and still symptomatic and has acute renal shutdown.
This has gone off again.
Yeah. Okay, we move to next session. Thank you very much. Thank you, everyone. Thank you, chairpersons, speakers. Bye-bye. Our next session, I would like to invite Dr. Parakshe, Dr. Kamaldeep Chawla, Dr. Dignesh Vasawa as chairperson, Dr. Bikramadit Padi, Dr. Viral Gandhi, and Dr. Anand Ahuja as moderators. Over to chairpersons for the next session to introduce our speakers. Over to chairperson.
Yeah, Dr. Singh has joined.
Yes.
Yeah, anybody amongst the chair?
Yes.
Please go ahead and introduce Dr. Dipesh and then the next speaker, and then we can have the debate.
Yes.
Both of my friends, yeah, please.
Welcome all of you to this academic fiesta. It is always honor and privilege to be part of Cardiocon. Congratulations and thank you to Kamal and the team of the cardiologists who are instrumental behind this academics. Dr. Dipesh Shah, he is the chief cardiovascular surgeon at and surgical director of heart transplant at Richmond, and he has extensive experience in cardiac transplantation as well as ventricular assist devices. And he will put forward his case for this particular situation of refractory heart failure and stage heart disease, where the 3 times admissions in last 6 months and not amenable to other medical management with normal pulmonary artery pressures. He will have his case for ventricular assist devices against Dr. Nayak, who will propose heart transplant as his modality of treatment of choice. As we all know, ventricular assist devices initially started as a bridge to transplant, and with the advancement in the technology and all, nowadays it is also considered for destination therapy. Let's see what both the speakers have to say. I invite Dr. Dipesh along with all my other chair colleagues as well as moderators. Dr. Shah, thank you.
Thank you, Dr. Shade. Everybody can hear me clearly? Yeah. Good morning from Richmond, and good evening to India. Thank you, Kamal, for inviting me to this wonderful platform, and in the presence of all these eminent dignitaries and all experienced cardiologists and few of my surgeon colleagues. Without much ado, I would try to present my case because of the time constraints. I'm not very tech savvy, so please bear with me as I bring my slides up.
Yes, we can see your slides and you are audible. Please go ahead.
Thank you. I'm going to be speaking in favor of LVAD as a bridge or a destination therapy for this case on hand. Just going right to the case. This is a 60-year-old female presented with the class 4 symptoms, recurrent hospitalizations. Most importantly, on exam, they found raised JVP and grade 3 pansystolic murmur in mitral area. You see the evidence of cardiomyopathy on the EKG with the QS in V2 to V4 and then DT inversion in V2 to V5, which points to the case being a chronic heart failure case.
You need to make full screen, show the PPT, go on the right lower, make it full screen. Right hand lower corner. Maximize, no. Yeah, okay, this is fine. You can move ahead. Go to the next slide. Yeah, please.
Okay. Yeah, the echo showed typical findings of a dilated cardiomyopathy. Sounds like bilateral ventricular enlargement, probably certainly dilated LV, moderate MR, and mild PAH. Coronary angiogram was 6 months back, but it was normal, so we'll accept it to make decisions. The right heart cath at the time showed PVR of pre-Wood units, and I'm assuming it was 6 months back as well. So considering the presentation, things may have changed from the perspective of the right heart. So in short, this patient is a chronic heart failure patient on a downslide with recurrent CHF readmissions. Importantly, the pulmonary edema every time she presents, and that's not a good sign. And with that, it is associated with worsening renal function. At the time, the renal function was found to be, I believe it was eGFR was 50. So I expect that the renal function is worse this time. The other most important factor was that this lady has blood group of O negative. And in next few slides, I will show how that is so important in this case. And the second most important point is the raised JVP and the declining renal function. You all know this. I don't need to dive into the details of cardiorenal syndromes, but the most relevant to our discussion today is the chronic cardiorenal syndrome, where it's the heart causing the renal failure. Because the increased renal pressure then leads to increased interstitial pressure, collapsing tubules, low urine output, volume overload, so on and so forth. We all know the treatment algorithm, how we treat these patients. You guys typically treat them in the initial stages, and how, as the heart failure advances, we have reached the final stage. It is the third pyramid that's now need for advanced heart failure therapies, which is transplant or an LVAD. This slide has been taken from a presentation by Daman et al. From the Journal of American College of Cardiology, which they clearly showed that in the CKD stage 1 and 3, once the medical therapy has failed, then LVAD has an important role to play to bring back the renal function, so that these patients can either become the candidates for the transplant, or they can continue with the destination therapy if they so choose. Impact of low GFR. Now say, what is the other option? The other option is heart transplantation. So we just hypothesize if this patient go on to get a heart transplant, then they have a very high risk of bad outcomes. They all go on to get they are very high risk for end-stage renal disease and go on to get the chronic renal replacement therapy or either permanent dialysis. And that doesn't bode well for their quality of life. If you look at the results in this slide, the end-stage renal disease, the hazard was 1.4 if the eGFR was more than 60, but as it goes down, the hazard ratio goes up. It's almost double and almost 3 times once it falls below the 30 mils per minute. eGFR at the transplant, again, it also decreases the survival. The mortality increases with worsening eGFR. And as you can see, the death during the follow-up increased progressively from 30 to 45% as the eGFR decreased from more than 60 to less than 30 mils per minute per 1.73 mils square. Patient survival, as you follow these patients up, you'll find that their survival also keeps declining. So it is very important that when we see these patients, we share this information with them about what's the best options for them. Maybe if you expect that their eGFR is going to improve, then it's okay to proceed with listing. But if you think that it's not going to improve, then it's better to bridge them with an LVAD. Again, this paper concluded by saying that if your eGFR is less than 70, then you have the highest risk of poor survival. This comes to the second point, and I hope this video plays. This is for the Star Wars fanatics. No, I hope not. Still, we just have to tell you. It's a Sith legend. Darth Vader, Dark Lord of the Sith, so powerful and so wise. He could use the Force to influence the midichlorians. He had such a number of understanding. He could even keep the ones he cared about from dying. He could actually save people from death. So this talks about the Chancellor Palpatine in this Star Wars Episode 3 about how this Darth Sidious had an amazing power to to save his loved one's life, but cannot save his own lives. In the end, he was killed by his apprentice, who he taught everything. And I think that the blood group O are in the similar category, that they are universal donors, but they struggle to find the hearts or the donor organs for themselves. And so that's why I feel like this is relevant. This meme is relevant to the blood type O recipients. All right, I'll move on to the next slide. Trying to get out of it. So this lady, ironic that she could save other people by being universal donor, but not herself. So that's why I want to focus on the blood type in this case. It's very important. Again, I want to make a disclaimer for our panel that my presentation pertains. This is from the U.S. perspective. I know that the transplant programs in India are relatively newer, but so the incidence, the number of transplant programs are also relatively fewer compared to Europe and the United States. So the number of the organ availability may be different, the competition may be different, and the criteria may be different. So I acknowledge that. This is from the ASIO journal from 2020. So it is really, it's not fair for the blood type O. So in this paper, about 3 million blood donors, about 46% are blood type O, and AB type is only 4.1%. And in the further deep diving into the UNOS data, they found that the AB type is 5 times more likely to get a heart than the type O, and the average wait time for the blood type O is about 22 months compared to the type AB. So let's see how the blood type also affects the outcomes in the heart transplantation. So if you look at the bottom of this slide, the hazard ratio for death just after listing the type O is higher, and it is statistically significant compared to blood type A, AB, or B. None of them are statistically significant. So having a blood type O does matter. It increases your risk of dying on list or dying after transplant. Why is that? In fact, blood type O is protective in terms of other cardiovascular diseases. But still, in the matters of heart failure, it is a huge disadvantage for these patients. From, again, the biocompatibility standpoint, they wait longer, they have a higher number of adverse outcomes. And also, another unfair point is that about 23.8% of the O hearts go to the non-O recipients. So that's just so unfair. But for now, that's the allocation policy we have. So I would like to know from the world if there is a different allocation regard to blood group in India. But again, how do we fix this? How do we fix this inequality? How do we fix this discrimination? And I think the answer is in LVAD. Again, from both the renal failure as well as the blood type discrepancy. So it was found that once you put the patient on LVAD, then the benefits are similar, but also that the relative benefits are similar, but also the outcomes are similar for all the blood groups once you put the VAD in. So it takes away the disadvantage from the having the blood type O, and these patients can then safely wait on the wait list without having the wait list mortality. Again, about 49% of VADs are being implanted as a bridge to transplant or a candidacy to transplantation. And the use of VAD is associated with increased wait list survival, meaning the patients are able to wait being stable on the wait list without having any adverse outcome or without dying. Again, it is in the summary, O is a significant risk factor for adverse outcome, but once it should be evaluated, these patients should be evaluated for early VAD implantation to improve their outcomes. This is another Just I wanted to mention the Momentum 3 trial, which concluded with the HeartMate 3, which is the latest device, LVAD device, which is beneficial to, which is more, which has got less incidence of the stroke and other complications compared to the HeartMate 2. But most importantly, they ended up removing the designation of destination therapy or bridge to transplant. So it's just because it's just one indication now, and they're trying to remove the designation as destination therapy. It's about improving the quality of life of the patient while they wait for either heart or if they don't qualify for the transplant, then they can just write it out. But it does improve the NYHA class. It does improve the 6-minute walk distance, all the health-related questionnaires, and European quality of life. All these were known to improve on the LVAD therapy. I want to thank the Cardicon and Dr. Sharma for this opportunity. It's my pleasure being in with this esteemed company. Thank you.
Parag bhai, you need to unmute.
Sir, you have to unmute yourself.
Thank you very much, Dr. Shah, for this crisp presentation. And now let us see what Dr. Nayak has to put forward for his case of heart transplantation as the preferred treatment of choice for this particular patient and situation. Dr. Nayak, please. Thank you.
Yeah, good evening, everyone. Thank you very much, Kamal and the team of Cardiocon for this wonderful opportunity. Dipesh, hi, how are you? Hope all well there. Congratulations for another family member.
Thanks, Tawa.
Yeah. So just, I'm like you, okay? Let me, okay. So, Parag bhai, how are you? All well?
I'm good. I'm good. Thank you.
Am I audible properly?
You're perfectly audible and visible to your slides. We can see. Please.
Thank you. So, thank you very much for wonderful presentation, Dipesh. I just want to commit one thing here. This today's debate is not to fight actually, but to understand both supermodalities, because still India is evolving actually in both things. So it is better to understand. Clinical data has already Dipesh published. She is a known case of established heart failure, and I agree. That's O negative blood group. Just PVR is slightly higher side, and eGFR is 50 ml. It is on the lower side. So these are three factors actually, which is more of a determinant for these ladies, whether we should offer heart transplant or VAD. Before we go, just the wonderful picture of history on the left side. So Michael Debicki with first LVAD, and the second on the right side, Christian Bernard, his first patient of heart transplant. It is always nice to see this history point of view. As I said today, just I'm going to stick a little bit of on informative side and lesser on debate side. So my few slides are going to be just on the on this kind of information. So this is the indication of a heart transplant or VAD, you can say. According to guidelines, it is any refractory cardiogenic shock with IABP or ventricular assist device, any cardiogenic shock which is requiring continuous IV inotropic support, peak VO2 less than 10 ml per kg per minute, NYHA class 3-4 with optimized medical therapy, recurrent life-threatening arrhythmias despite of AICD or antiarrhythmic medicines or ablations, end-stage congenital heart failure patients without evidence of pulmonary hypertension and refractory angina with without potential medical surgical therapy options. So these all are patients actually who falls, and these patients, they need either heart transplant or VAD. just in a brief, if we look at advantage and disadvantage of both modalities, heart transplant patients, they have a better, longer life. Most heart transplant patients, they enjoy better quality of life. They have a high energy levels. They have improved general well-being, and work and travel is quite easy. When we look at a VAD, as Dipesh shared, immediate availability is the most striking advantage of VADs, and we can always plan the intervention actually. Disadvantage, again, as he mentioned, lack of donors, and particularly for this patient, O negative blood group, it is definitely is going to be a difficult actually to get a good donor for her. Otherwise, immunosuppression, transplant, vasculopathy, infection, malignancies, as we all know. A problem with VAD, actually, it's very easy to say the word, but again, the patient, they become totally dependent on the device. We need continuous power requirement. They have to carry a bag. They have to always make sure that power is available, particularly in the night. Anticoagulation is a little bit of a more issue sometimes, and we have to check it very vigilantly because stroke and GI bleed, sometimes it happens, they are fatal. So there are so many publications has been happened for heart transplant because just we are doing since last 50 years. So I'm not going to speak everything, but this is one of the paper actually in a circulation heart failure in 2015, which not only shows the results of heart transplant, but they have just tried to establish the results between male and female patients also. And look at the numbers. They've enrolled almost 34,000 patients in the study. Almost 3:1 was the ratio to male and female. And if you look at the results of the transplant, actually, almost 10-year survival is 55 to 60%. There is no much difference between male and female patient. And unfortunately, we don't have any long-term data available for the VADs yet. These are this slide is only for reference. Green color is recommendation. Yellow color is moderate recommendation. And if you look at the recently published ECS guidelines, just published last year, and if we, for the selected advanced heart failure patient, heart transplantation is still level 1 class of recommendation, while the MCS to use as a bridge to transplant or bridge to destination is still moderate recommendation. Even the ACCH guidelines, that's a revised guideline in 2017, says the same thing. Whenever the patient is having refractory NYHA class 3-4, that's stage D, then heart transplant is strongly recommended. Then the VAD is class 2A recommendation. Cost is always an issue. Depends. I know you live in a beautiful country where the money is flowing like anything. These are the paper actually just compared the cost of all therapies. If you look at this red boxes, in USA, heart transplant costs almost 150,000 plus or minus 86,000. But when you just look at the VAD, actually, it's almost 600,000 plus or minus 200,000 bucks more. And this is for VADs actually. So many times with the function of RVD's function, patients, they need the BioVAD actually. Then Dipesh would be always happy to welcome all these patients. In India, till we have to think actually. My heart transplant patient, I just give them budget of almost 20 to 25 lakh, where that is also so many times difficult. And my first VAD patient, the bill costed me 1.2 CR. Depends, unfortunately, I haven't received the full money yet. Not going for this detail, this is not related to, but UNOS also has now reduced the number of VADs actually for the acute decompensated heart failure after 2018 guidelines. And now whenever the patients will come with the acute HF, till they just recommending to stabilize with temporary support rather than to go straight forwardly on the VAD. So I know the donation is an issue. And the surgeons across the globe actually working on that. And this is one more terminology has come up in the picture since last so many years. That is a donation after circulatory death. It's also called DCD. It's a bit of a long topic actually. I've tried to understand in one slide. So basically donation can be happen before death. That is a brain death. Our conventional patient, that's called DBD. And these are the DCD. And we have various types of DCD. And the most common is, in the category 3, where cardiac arrest follows planned withdrawal. So if any patient in ICU on a life supporting system, and the family is willing that no, we don't want to continue this treatment, then these donors, they can become potential donors by just donating the heart. Then we have death on arrival, unsuccessful resuscitation, and cardiac arrest in patient who is brain dead. These all are potential donors where we try to get good heart actually using this organ saving system actually. Now a few more companies are there, but Transmedics was initiator, and I think US FDA approved now. So that's how the society is trying to increase the donors. And these are the number of DCD happening in different countries. And if you see in the UK, since last 10 years, the DCD donors has just jumped like anything. The last year, the numbers were less because of the COVID. So this is one potential is there to increase donors. So just coming to some conclusion, like, now that's a very good paper from ACC in 2015 by Monica. So see what's he highlighted is the same thing. The current strategy for any patient with reduced heart failure is always to screen for the transplant first, and then if requires, then only for VAD. Organ availability, as I mentioned, it is a major issue, but then again, the DCD numbers are going up, so that can help actually to offer heart transplant. VAD support definitely improve the quality of life and survival compared to medical treatment. There are 2 years outcomes, which is definitely comparable with heart transplant, but we don't have any long-term results of VAD. LVAD complications are nasty sometimes, and there are so many innovations are happening actually. So future would be bright with LVAD, I'm pretty sure. So clinical trials, as I said, which needed actually determine which patients benefit most from LVAD versus heart transplant. Again, transplant, we had a very good news a couple of months before. Transplantation, while mature, it has a tremendous potential to growth. Again, modifying xenograft, genetically modifying xenograft transplants, that's only first patient is there, is doing well, I believe. And that could change the future of heart transplant donors. So in summary, for patient who is eligible for transplant but not VAD placement, definitely only transplant is an option, and we can reserve the VAD only in case of emergency. Secondly, for patient eligible for both, either for the transplant or VAD, the VAD placement, if the patient is unstable, like emergency, that is acute decompensated heart failure. And if patient is not fit for the heart transplant, then VAD definitely is the only option, and we can use as a bridge to transplant. If the heart recovers, then we can do heart transplant. If it doesn't recover, then we can continue as a destination therapy. So in given case, definitely O negative blood group remaining a challenge actually to get appropriate donor. I totally agree with Dipesh. Another factor is high PVR, which we can manage. Kamal did not mention about the urine output, though eGFR is on the slightly lower side, but if urine output is adequate, then either VAD or heart transplant, I'm pretty sure that kidneys will become normal if the patient recovers from both the therapies. I still think patient is stable, she is not in hospital, she is not on home milrinone, then I'll wait for at least some time until she becomes sick. If she becomes sick, if she comes back again in emergency or in the hospital with acute symptoms, then certainly VAD. But again, heart transplant is the choice for this patient. This was a picture on the right side. Dipesh sent me a couple of months before.
Yes, getting short of time.
About the xenotransplantation, and I hope the future in India and USA both would be bright with a lot of technologies in VADs also, and in this the cellular level, this genetically modified pig hearts also. So the patients would be benefited most. Thank you very much for kind attention. As I said, my lecture was more towards to understand to the both modalities actually in appropriate way, because still we are in the infancy level in India, Dipesh, and it is very much important that the patient must get the best treatment. Thank you. Thank you, everyone.
Yeah, I have a question for both the speakers. Can I go ahead? Am I audible?
Yes. Yes, go ahead, sir.
So a very crisp presentation, and both of you putting your point across the board for the given patient. Now, Dr. Dipesh, Dr. Sharma and his team have prepared this case for you, and a heart is available. What would you do? And in the same breath, I would like to ask Dr. Nayak, the same patient has been referred to you and the heart is not available. What would you do?
Yeah, Dipesh, you first.
All right. So let me make sure I understand the question correctly. So you said if the heart is available, what to do?
The same profile patient that has been made by Cardiocon team over here. Dr. Sharma is referring you this patient and the heart is available. A donor heart is available. What would you do? And in the same
if I have this same patient, I would not list the patient. So heart would not be available yet, because I want to stabilize the patient first. I want to make sure that the eGFR is declining. I mean, it's improving. So I will list the patient only when the eGFR comes above 60. So before that, I'm not going to list, and so I won't get any hard offer for that.
Yeah, I think the message was pretty clear. I mean, the whole concept of creating that debate was to identify cases who can be listed and who cannot be listed. And it's been a pleasure actually looking how heart transplant has, Dipesh, evolved ever since you left to US. I mean, when you were here with us, Dipesh is a good friend. We've been together for MBBS, and actually Dhaval has been the same. We all have been in the same batch. And I think Dhaval has done some 25, 26 transplants since, and Dipesh is doing a lot of LVADs in US. So it was fantastic to have you guys, but the whole concept was to identify, and I'm really happy that the Roto-Noto things have actually been streamlined much more. And Dhaval was talking that day about a couple of cases, how they could get a green corridor and how they are trying to talk about in the waiver of the air ambulances. So I think once that sets in, probably more suitable patients. But looking at the patient pool, I think in India do have a lot of scope for LVADs as long as the finances can come into place. Chairpersons, Dr. Kamaldeep, Dr. Anand, your comments, please.
So I'm happy to answer, Dr. Kamaldeep. Just as you said, I agree with Dipesh that eGFR is on slightly lower side, but till I just want to see the urine output. If urine output is good, then maybe 50 ml of like 50 eGFR is, I know it's a borderline, but if adequate urine output, and if I get a heart now for this patient, I might, just go for heart transplant.
So again, my rebuttal is that the 50 GFR was from the last admission. So we don't know that. And these patients tend to deteriorate with the recurrent CHF admission. So who knows, his eGFR is even lower now. It's even less than 30 now at this admission. I wouldn't list this patient.
No, I agree, Dipesh. See, the depends, in India, actually, we cannot stick only with the papers and the numbers. Okay, so there are so many factors actually affect, with the outcomes.
So it's not just papers, it's evidence-based practice, right? So
no,
it's not just papers.
Okay, so that's what I'm telling you. It is not like that very randomly I'm going to enroll this patient, but that's what I'm saying. If urine output is good with slightly on the low eGFR, definitely also we should look for the sonography, all other parameters and everything. We must involve a nephrologist. But if it is a borderline, and if you get a chance to get O negative, this particularly I'm talking about O negative. If C would be AB, then I would wait for that.
Dr. Nayak, would you VAD him?
If she doesn't have money actually for LVAD, what you do?
No, she has everything.
So you bring up a very important point. So even if you look at the US criteria, if you don't have LVAD, if you don't have LVAD, then you have an option to put the balloon pump. So put the balloon pump, write it out, evaluate after 1 week what it does. I have a patient in ICU right now with the eGFR was 30. After 1 week of being on balloon pump, the eGFR has come up to 70 now. And I don't believe that you can just blindly trust the urine output. If it is 50 ml per hour, then you can just proceed with listing unilaterally. I would involve the nephrologist, go by their expert opinion, follow the labs. The labs are there for a reason, right? So I would not discount the renal failure like that so easily. In the end, what we want is a live patient and well-doing patient, not just because you have a heart available, you're going to put it in. I don't think that's the right approach.
I think Dr. Sharma better to end because
available
a lot of time.
as Dr. Kamaldeep is asking, like if everything available, then I totally agree with Dipesh that we should wait. We can if she deteriorates a little bit more, even if she is not responding to IVP, we can use ECMO or short-term VADs, and we should try to stabilize her. Okay, but definitely if it is anything but O negative, then we should wait for this patient, not to offer we should not jump immediately for anything.
Thanks,
but it's O negative, and in mostly if you say the patient overnight that just collect 1 CR, then the patient is 60 years old, the most of the time the family actually goes outside, and what they think actually, is it worth 1 CR? That's the first question comes in the mind. So we also want to do so many things, Dipesh, here. Like just now, I admitted one patient, just admitted, and I came here. She's a known case of a muscular dystrophy. She's a young female, actually. So the peripheral, the cardiology colleague outside, he has recommended straightforwardly VAD for her, this patient. Okay, so it is not like that I am going to jump on that for that patient for the VAD. Muscular dystrophy is not a contraindication to the heart transplant. There are so many, reports, case studies are there. So definitely we will evaluate this patient for heart transplant first. And if heart transplant is better, if it is possible, feasible, then we'll just offer heart transplant. But if she is not fit for heart transplant, then VAD, as I said, the main advantage of VAD is easily availability. And we can always plan any case according to that.
Yeah, I think we had, for the lack of time, we'll have to end the session here. Thank you very much, Dr. Dipesh, Dr. Dhaval, and all the chairpersons. We had a wonderful session. Thank you, Dr. Parag, Dr. Anand, Dr. Kamaldeep Chawla, for the wonderful presentation and the moderation and chairing of the session. Thank you very much. Thank you.
Thank you, Kamal.
Thank you, Kamal. Thank you, Dr. Shade, and all the panelists.
Thank you.
Thank
you later, Dhaval.
We move to next session. For the next session, I invite Dr. Ravi Singhvi, Dr. Priyank Modi, Dr. Nikunj Kotecha, Dr. Kamlesh Thakkar, Dr. Vipul Kapoor, and Dr. Tejas Patel, as respected moderators and chairperson. I request them to invite the speakers and introduce speakers, please. Chairpersons, please introduce the speakers.
Good evening, everyone. Am I audible?
Yes.
Yes, Dr. Kamlesh, please go ahead and introduce all the three speakers, and then we can have the case and then go to the presentation directly.
Thank you, Kamal, for the such a nice event and very nice lectures. So I will invite first our speaker, who is Dr. B.C. Kamath. He is going to say something about the stent selection in a given case. And the case is 50 years old doctor with a diabetes, having unstable angina, who is planned for a PTCA stenting to a tortuous, angulated, long segment 90% mid-LCX stenosis, which is having a large OM arising across it. The stent parameters that will help in managing this patient best would be Dr. B.C. Kamath is going to say about the stent design and its parameters like stir thickness, trackability, radial stent, which is more important. So, do we have Dr. B.C. Kamath?
Yeah, good evening.
Good evening,
am
sir.
I audible? Yeah, thank you.
Yes, sir. Yes, sir.
Thank you. Go ahead. Next will be Rajneesh after me. Yeah.
And then we'll have
Yes,
Dr.
sir.
Rajneesh and the next slide. Then we'll have Dr. Nikhil Panchure. Can we have the case, please?
Yeah.
The scenario, please.
Okay.
Yeah. The case is already shared by the chair. Dr. Kalmat. Next slide. Something like this. Next slide.
Correct. Okay.
Next slide. And we can have Dr. Kalmat. Over to you.
Yeah. Thank you, all the chairperson. Thank you, Dr. Kamal. It's been you're taken a hurricane effort to which are the latest concern? You've taken a lot of efforts to really conduct this conference, and Jignesh is there. My dear friend Jignesh, how are you?
Thank you.
Dr. Kamlesh Thakkar, and of course, Dr. Kamal Sharma is there. I'm sure my whole job is made easy by my dear colleague, my moderator, when he gave me said that when you have such a tortuous vessel, diabetic gentleman, long vessel with the bifurcation, then naturally you will definitely need a very important or very superior stent. So if you see the patients wherein you having such problem with the more diffuse and small patients with diabetic patients have more what do you call diffuse vessels, smaller vessels, thrombogenesis, and also they have endothelial dysfunction and impaired platelet dysfunctions, and these are all things makes we need to have a very really good stent to show that the rates are comparable to all the stents. That's why this patient being diabetic, a doctor, a bifurcation, and a long vessel makes everything important here. So ideal stent, naturally, being a doctor, they have said look for an US FDA approval. There's no doubt about it. We are not going to talk about other stents unless the why US is not running after the US, but US FDA has made such a stringent things to be included in the parameters. They have got huge data to unless the patient stent comes onto the platform, unless it is great deliverability, trackability, conformity. And especially there are some stents have got a diabetic role like Onyx, or you can say the Biofreedom, or even these stents have a major diabetic workup. We need a stent which is a longer, a reasonable drug elution period. I'm not say very long, reasonable, with stent a better over expansion capacity without fracturing and better radial strength, which enables stent have a not have a luminal loss and no force shortening and elastic required. So if you look at the platform and the delivery, I would say naturally the polymer and drug will not, because all the polymers have become, all the drugs have been equally good now. So what will important would be the polymer and the flexibility and the thrombogenicity and the radial strength and force shortening, because here is a diabetic guy who has got a real tortuous vessel. You saw the angio there. So we have three great strengths. We have Zynes, we have Synergy, and we have, of course, the great Onyx one from Medtronic. The biggest change which has occurred in Zynes has been the delivery systems and balloons. But the one thing which has rapidly evolved with Onyx is that not only delivery system, the polymer has changed, and the structural single coil structure has made it a very important stent in the market now, because it will take a huge development of other people to really compete with. Synergy has to come up something, or Alpine has to come up something to really come near, because this century if you see the strut cross section here, the Zynes and the Resolute and the Synergy, many of the square or even the Orsi or Biofreedom as a square thing, whereas the rounded structure makes it less traumatic to the vessel wall, and the thickness should be something between 75 to 85, because too small like 60 or 0 is not good for large vessels, and too thick like Biofreedom we had 112, which is little, because okay, that it does not have polymer. That's another different story. Here we want a good polymer or a great drug which is good enough, and also most important, the thickness and the structure of the stent is very important. So we have three workhorse stents here which are competing here: the Synergy, the Expedition, or the Alpine, or the Resolute Onyx. Of course, Ultimaster is not behind, and Biofreedom or Orsiro are not behind, because Orsiro has some characteristics which are thin strut, which makes it more trackable. But there is a bench strength when you say trackability between Onyx and Orsiro has been also great, that Onyx and Orsiro are very comparable. Very few instances we may say the Orsiro can cross better, but compared to Synergy and Expedition, Onyx is superbly trackable because of the structural single coil structure, and also the rounded structure of the cross section of the stent. And this makes a huge difference in deliverability. Here we want a very deliverable stent, good drug, and a great side branch access because of the great OM coming there. That's why we have a moderately thin strut, that is 80 microns of Onyx, or 75 to 80 microns of synergy would be comparable here. And of course, 61 microns is not comparably because we are larger vessel, 3.2 vessel here. So if you look at one of the trials telling that the ISAR stereo, which said that strut thickness too bigger will not be good enough because it causes luminal loss and laminar flow will be lost. So 61 to 80 microns is great. That's why we have, when you assess 10 choices, we have driver platform of Onyx and Liberty was slotted tube and multi-link vision is what is a time immemorial. Science has been playing that. So real competitor, I would say, Synergy and Onyx, and Onyx will have a greater role here because of the trackability and a single wire technology. It makes it very, very sinusoidal, makes it very trackable, and most important, gives a great conformity of the vessel, makes it a lovely stent here. So I will bet my money on Onyx here because of the enhanced radio opaque. Also that another thing is important, if you look at in this slide, that how visible is this because of platinum iridium, which is the alloy which is used, unlike the other metal alloys where is a platinum iridium makes it visible. At the same time, it is not a nickel, which sometimes causes more endothelial dysfunction, as we've seen in the Science platform, other platforms. So thinner struts, reasonable struts, good opacity, and stent platform, which makes it fantastic. If you look at the cross section of when you do an IVUS or even we do the OCT, we look at the side branch, wherein side branch accessibility has been phenomenal for the Onyx, because we do so many left mains with the Onyx. I did 2 left mains today and 1 left main yesterday with the Onyx with a greater approach, and it was so smooth for me to get into the vessel, side vessel, and do the job like kissing balloon or crush or DK crush, and you could see a small momentum in how the stent conforms here, and because of the single coil structure, which makes it beautifully adherent to the, and also it has great radial strength. Radial strength is comparable between them. 4.2 of Synergy versus 4.1 of Onyx makes it also greatly having a good the radial strength. And there's always a little because the strut structure is peak to peak makes it lesser fracture, unlike peak to value of Synergy, which is also becomes a little hindrance here. So in this, my align the crowns are peak to peak and makes it more conformable and more. And then the foreshortening is also come down. So this all makes the foreshortening comes down. Why, my dear friends? Because the peak to peak does not allow it to fracture and foreshorten. And the sizes like 3 mm can go to 4.2, 3.5 can go to 5 mm, and 4 can go to 6 mm, makes it a phenomenally important stent for left main and other bifurcations. So I would put my money on Onyx to do it here, great job here. And of course, Synergy as my backup and Orsiro as a backup here, because they're also great stents with great platforms. So, and these are the many. So looking at the patient history, he's a diabetic having small vessels, diffuse disease, tortuous anatomy, and a big side branch, and a diabetic gentleman. I would, as I already declared you, that my first would be Onyx and of course the second would be Synergy or Orsiro. Thank you, Chairman. Thank you, gentlemen.
Thank you, sir, for such a nice lecture about the stent design in treating this patient. Now I will invite Dr. Rajneesh Kapoor from Delhi. Dr. Rajneesh Kapoor doesn't need any introduction. He is a very well-known cardiologist of our country. So he's going to say about the drug platform, because today we have availability of very nice delivery system like GuideZilla, GuideLiner, and very nice catheters. And so he's going to say about the drug platform and the polymer, whether it's a biodegradable polymer for this given case. Over to you, sir.
Thank you. It's really a privilege, and it's quite. Am I audible?
Yes, sir.
Yeah. So it's quite visible that how much effort everybody has put in, and special congrats to Dr. Kamal Sharma, who has done a lot of hard work in preparing for this meeting, and the enthusiasm is quite visible amongst all speakers and all attendees. So although for our nation, it's Gujarat coming to Delhi, Gujarat is managing everything. but here Delhi coming to Gujarat, little opposite. Okay, so given this,
sorry to interrupt.
Sir, please. Yes, sir. Yeah. Yes, sir.
Yeah. So given this special circumstance and the patient point of view for which we are discussing, that which stent we should choose based on the drug platform, polymer or the drug. My job is more of theoretical, mainly because this is a really extensive theory which I'm going to discuss, that how drugs are coated and the polymers and durable versus biodegradable polymers and no polymer stents. So we have wide array of stents available with us. And if we have to choose based on these things, then how should we proceed? So this is evolution of PCI. We know we are in a drug-eluting stent era, and once we talk of that, mainly now we are here. We are talking, we have stents with a biodegradable polymer, which contains the drug, and drug is slowly released into the system. And then there are stents where there is a no polymer, but still drug is adsorbed onto the stent surface. And then we also have stents. We had a bioabsorbable vascular scaffold, first generation, and we all know that somewhere there were lapses and that didn't continue because of some complications of late stent thrombosis. But still now we are almost there with the second generation bioabsorbable vascular scaffold. We all know we have been using cautiously, but I think data is further piling up, and the limitations which were there in the first generation, to quite an extent, those have been obviated with the second generation. So three components of a drug-eluting stent: drug, polymer, and a stent platform. The key components of drug-eluting stent is the drug, and we all know sirolimus, everolimus, zotarolimus, biolimers, paclitaxel. We all have various stent platforms available which contain different drugs. Dosage, how is it coated? This is important. Another important stuff is polymer. So what is a polymer? Polymer actually is a substance which is a carrier for that drug. So now initially there were durable polymers, but then there were problems faced with the durable polymers, some inflammation, and then late stent issues were faced. And then almost all stent platforms, major stent platforms, have shifted from a durable polymer to a biodegradable polymer. Composition of polymer is important, and even now we have drug-eluting stents with no polymer, and they are available. Stent designs are important. My previous speaker has talked about that. I won't be going into that detail. The platform of the stent is again very important. Diabetic versus non-diabetic. This is a typical diabetic patient. So once we deploy a stent because of a polymer, some inflammation happens, and then there is a healing cycle. So that takes time. There are stents where a healing happens in few days in non-diabetic, but it's kind of prolonged in diabetic patients. Not going into that detail also, it's too theoretical. Coating polymer, drug carriers in drug-eluting stents. The non-biodegradable or permanent polymers, the era is gone. So we are now into the era of biodegradable polymers. The second generation, so we have various polymers, the fluoropolymer, Endeavor has phosphoryl choline. These are all biodegradable polymers. PLA, PGA, and PLGA. So these are the biodegradable polymers. And then we have stents with no polymer. Yukon from Translumina, and then from Concept Medical US. So and a nanoporous hydroxyapatite. This is how the coating is done in non-polymer. Basically, it is coated onto the surface of the stent without any attached polymer. Latest generation drug-eluting stents, as I mentioned, mostly we are dealing with biodegradable polymers. All the major stents are actually with this. The attractive combinations of controlled drug elution in parallel with biodegradable polymers, which then converts into inert monomers. After completion of biodegradation, that drug-eluting stent practically becomes a bare metal stent. So the late complications are all avoided by virtue of that. Stents completely free of polymer after some time and completely biodegradable magnesium and polymeric stents are there. Drug-eluting stents with biodegradable polymer, they have anti-restenotic benefits because we mentioned they are kind of eluting drug for quite some time, and then they after that to obviate the late stent complications, they get converted into bare metal stents. So these are the advantages. The data is very clear. Once it compared the biodegradable polymers with durable polymers, all results were in favor of less complications with stents with biodegradable polymer. These are almost the same things being talked about. And then also came an era. Now there is now a debate which happens whether the coating should only be on the abluminal side or it should be the circumferential coating. We have stents available now which only have a abluminal coating. We know Synergy, we know Abluminous. So these are the stents with abluminal coating biodegradable polymer. So it's a unidirectional drug delivery only towards the vessel wall and better in tissue penetration of the drug and more homogeneous. So this is what is being claimed. Non-polymeric drug-eluting stents also there is a data that it doesn't lead to any inflammation. So there's an improved healing with these kind of stents, improvement to the integrity of stent surface, and possibility of a shorter duration of DAPT in high bleeding risk groups. This is the advantage of non-polymeric drug-eluting stents. And this is what I was mentioning, a polymer-free and a durable polymer. The results were clearly in favor of the biodegradable polymer. So this is another stent where there is more innovative thing happening, abluminous stent. One, I mentioned it has a abluminal polymer which contains the drug. So it's a one-sided release into the vessel wall. Also, additionally, there's a fusion coating. The balloon on which the stent is mounted, the tips of that balloon. Now we know once we have a stent and a balloon, so there are some small fraction of a balloon which overhangs the stent on both sides. And we also know because of this balloon creating a trauma beyond the edges of a stent, the edge restenosis is fairly common. So what they have done a fusion coating where they also coated that balloon with a drug. So it's a drug-coated balloon and a drug-eluting stent combination. This is an innovative thing which they have done, and the results are also good with this stent. We are now fairly using this stent in large numbers. And once now we come to the comparison of all the stents available, it shows this diagram actually shows whether it's a full circumferential coating versus abluminal coating, the strut thickness, and specifically the abluminous. So, and the polymer coating. So last line is polymer coating, circumferential 7 to 8 micron, 6 micron, 10 micron. So abluminal, circumferential, abluminal. So now based on this, if we have to pick and choose the stent for our patient based on the drug platforms and the polymer, I think from the word go, it should be a biodegradable polymer, good drug, and good strut thickness. And circumferential versus abluminal, we don't have a concrete data that which is better. This is on theory, it looks that abluminal is better, but there is no consolidated data based on that. So resolute onyx, Zymes, or abluminous. And on third or fourth category, I'll also keep Synergy. So these are the stents which we can actually think of using in this typical patient based on the drug and the polymer coatings. So a key takeaway message for an ideal stent: it should be a limeless drug elution for 60 to 90 days, followed by complete absence of drug release. This is also very important. The pharmacokinetics of drug release should be that it should be giving a good cover for 2-3 months, but then no release after that. A very thin surface of biodegradable or a durable polymer. I'm not counting durable, only a biodegradable polymer coating, a very thin surface. The stent, that stent is a preferred stent. Stimulation of early re-endothelization. And we have data now with the Onyx. We have data with BioFreedom that one antiplatelet can be taken off in a month or 3 months, respectively, with these stents. So if somebody is going for non-cardiac surgery, these are the better stents. A very low profile stent delivery system, high flexibility, conformability due to a hybrid open cell design, thinner struts, minimal late loss, a thrombus resistant luminal surface, a minimal duration of DAPT, and low stent thrombosis or ISR rates. So fitting into these last slide, I think the stents which I named, either Onyx or Lines or to some extent Synergy and Abluminous, because of some innovative thing which they have done, I think these are the stents which we look at can give the best outcomes in our patients. Thank you very much.
Thank you, sir, for such an informative lecture about the drug platform and polymer. Now I invite Dr. Nikhil Pachure from Mumbai. He is going to say about new generation abdominal drug elution with a semi-absorbable platform that is being approved DES for such kind of patients, which we are discussing. Over to you, sir.
Yeah, very good evening, all of my colleagues. I'm going to make a case today for a new generation abdominal elution with semi-absorbable platform, and that's the only approved DES for such patients. I'm going to address the chairpersons and the moderators as my lords, and I'm going to be very precise, very robust in my presentation. I'm going to stick only to the evidence, and I'm going to bring in 2 expert witnesses to support my argument. One of them is going to be an international expert, my colleague, Roxana Mehran, and the other expert witness will be our very own Dr. Kamal Sharma, because both of them were involved heavily in determining the outcome for the stents which I'm going to make the case for. I'm here neither to make any lecture or nor to give you any stories. I'm here to produce and bring in only evidence to make my case. So my lords, what is the issue here? The issue here is about a diabetic patient who has come to the hospital with unstable angina and has been found to have tortuous, angulated, long diffuse lesion involving a side branch. In other words, here is a gentleman who is a doctor and who has been shown to have a complex lesion involving one of the coronary arteries. So the question here, my lords, is why do we need a dedicated DES for a diabetic patient? How is this stent different? And does it have any superior outcomes? And I'm going to stick only with this stent, and I'm going to present my case to support that this is the only stent which is suitable for this patient. When we look at this patient who is diabetic, which is a very frequent comorbidity found in our patients, and if you look at a very high volume, single center registry, all PCIs between January 2009 and 2014, what was the prevalence of diabetes? Almost 50% of all our cases, when we divide them into non-diabetic and diabetic, which proves that diabetes is very frequently found comorbidity in our patients coming to the cath lab. And indeed, our patient here is diabetic. So what is the problem with diabetes? Well, there's an increased risk of cardiovascular events and death associated with these patients. When we look at relative risk of CHD mortality, CVD mortality, and total mortality, it becomes very clear that if we take diabetes patient here alone, these mortalities are up to at least twice as compared to patients who are not diabetic. And this is very clear, and that is why we need to be very precise in dealing with these patients who are type 2 diabetic. Type 2 diabetic patients have more complex coronary lesions with increased necrotic core volume, increased inflammatory infiltrate, and increased calcification, as is shown in this study, where there are more macrophages, there are more T lymphocytes and HLA-derived DR. This is what makes these patients highly complex in terms of outcomes, where you have, my lords, already seen that the risk of deaths is at least twice as compared to non-diabetics. Therefore, we should take these patients, and this patient in particular, very seriously, my lords. Why? Because diabetes mellitus causes delayed vessel healing due to slow endothelialization and increased inflammatory response, leading to acute, subacute, or late and very late stent thrombosis, my lords, and a focal or edge restenosis, as has been talked about by the previous presenters. This is a very important slide, my lords, which clearly shows that the drug very commonly nowadays employed in stents is everolimus. And when we compare that with previous generation paclitaxel eluting stents, then it becomes very clear that as far as non-diabetics are concerned, everolimus has an advantage over paclitaxel in terms of target lesion failure. But when we look at the diabetic patients, there is no advantage, or the advantage which was there for non-diabetics has been lost in diabetic patients with the same target lesion failure as in both. And the same is true in diabetic patients, but the failure of target lesion is higher with everolimus eluting stents. So, my lord, this is more serious as well when we look at the diabetic patient. And remember, our patient here is diabetic with long lesion, tortuous, angulated, involving a side branch as well. So in general, my lord, the outcome data for target lesion failure in diabetics is very high as compared to non-diabetics, both in terms of events, in patient-oriented composite events as well. That diabetes specifically puts our patient at a very high risk of adverse outcomes. Remember, my lords, I'm going to stick only to robust evidence to make my case. So how do we mitigate these risks, specifically pertaining to our patient here? Well, we already know now that the strut thickness is very important. And our stent, which we're going to employ in this patient, has to be thin strut, which elicits less angiographic and clinical restenosis, as has been informed to us by previous presenter, that our polymer has to be biodegradable, number one. Number two, the drug distribution has to be abluminal only as compared to conformal. And polymer degradation time has to be shorter as well, my lords. We also know that type of anti-proliferative agent is important as well, where I'm going to make a case for sirolimus here, my lords. As you have seen, that the everolimus loses its advantage when it comes to diabetics. And nobody has spoken so far about stent balloon. And I'm going to make a case for stent balloon to be coated with drug as well, because our previous presenter clearly demonstrated that the edge is highly open for restenosis, my lords. You have seen this slide before, which clearly demonstrates that our stent called abluminous has only abluminal coating, number one. Number two, it's actually very thin and abluminal only less than 5 microns, my lords. So that is why this stent is superior to all other stents which are at the moment employed for all other patients. This is what is very important, my lords, here in this slide. I'm not going to talk about this abluminal, but this is very important, that in between the stents struts, the balloon itself is drug coated. And at the edge as well, where the balloon extends beyond the edges of the stent, that part of the balloon is also drug coated, so that this drug is actually delivered to the vessel wall when we fully deploy the stent. And we'll see, my lords, that this all what I have just said translates into advantage in clinical practice in terms of outcomes for our patient. And how does that happen? How am I going to make that case that this really translates into practice? Is by all these studies, my lord, on which the most important study here is Enable Registry, where more than 2,500 patients were employed. And that's where our own Dr. Kamal Sharma comes in. He has clearly published real world data of more than 2 years for these patients, my lord, which clearly evaluated the safety of abluminal stents. Primary endpoint was major adverse cardiac events, and secondary endpoint was stent thrombosis. And there you go, my lords, the MACE, death, target MI were so low throughout in these patients who were diabetics, which were comparable to non-diabetics. Remember, we have shown in this that our patients' outcome data of adverse events actually is very comparable to non-diabetic patients, my lord. And that is a huge leap forward for our patients. So in conclusion, my lord, compared to non-diabetic patients, studies show inferior outcomes in diabetic patients undergoing PCI. And innovative stent technology targeting the specific needs of our patients with diffuse disease is needed to adequately address the target lesion failure in diabetic patients. The abluminous disc, with its unique coating technology on abdominal surface of the stent, as well as the balloon delivery system, is a very valuable option for diabetic patients. And more ongoing studies will show that. My lords, I hope that I have made a very robust case for the use of abluminal stent specifically for our patient, because he's diabetic, has long diffuse lesion, and I have shown in outcome data that this is the only stent which actually achieves of reducing the risk of major adverse cardiac events and target lesion failure for such patients. Thank you very much.
Thank you, Dr. Nikhil, for such a hot presentation. It was like hearing a debate in a Supreme Court by one seasoned lawyer. Thank you very much. Now the forum is open for the discussion. My co-colleagues, Dr. Vipul, Dr. Tejas, Dr. Ravi, Dr. Priyank.
Hello. Can I go ahead, sir?
Yeah, yes, please.
Hello.
Yes, Priyank.
Yes, please.
Yeah,
please, Priyank.
Yeah. Just to summarize, BC Kalmat sir was in favor of Onyx, and the other were in favor of albuminous from Envision. Now, we very well agree that the technology what they promote is better. Two important points which no one discussed was, in today's era when we have such good delivery methods, usually it is never difficult to prepare the bed well. And when you prepare the bed well, most of the stents track down. Now, one basic difference which I have found with Onyx or the Onyx Synergy on one side and Indian stents on the other is when you track a long stent down and when you deflate the balloon, it is very difficult to bring the balloon out. And that is where Onyx has a difference. Like a 40 millimeter balloon, when you deflate after deploying the stent, you can easily pull the balloon out without the catheter being sucked in, which is an important aspect here because you are going to circ and you do not want to damage the ostium. And sir, Nikhil sir, if you are very pro, then why albuminous has not applied for FDA approval? And the drug also, the discussion on the drug was, you discussed everolimus versus Texels, and then it is a class effect in diabetic, whether it is sirolimus or everolimus. Both would be not superior to Texans. It's not that they are inferior, but they are not superior. Why Texels or plexitexel stents were thrown out, and we have limus stents, is because they were found to be superior. But in diabetics, they were not that superior. But then that's a class effect when you consider whether it is everolimus or sirolimus. So, sir, your points on that.
Yes, thank you very much for those important issues you have raised. First of all, FDA approval. I have not shown you in the lack of time that there is a very ongoing study called Dedicate, which is being masterminded from Milan. As soon as that data is out, everything is ready to be applied to FDA. Our own Dr. Kamal Sharma has shown, and I have seen their presentation in the past, that in diabetes with long diffuse lesion, outcomes with a repeat angiography in 6 months' time, and not one or two, significant number of patients who are presenting like this. Second question you have raised about the drug, which I agree with you, that probably the drug elution with sirolimus and everolimus are a class effect. But definitely, we have gone beyond the era of paclitaxel or taxol drugs, which are not as good as today's everolimus, zotarolimus, or sirolimus. Sirolimus actually came as the first, but it has stood the scrutiny of time in terms of outcomes, and that's why it has come back again, sirolimus, as compared to zotarolimus or everolimus. But I agree with you that probably the class is the same. Yes.
Thank you. Sir, I use both to the maximum because, anyways, thank you.
Congratulations, Dr. Kamal sir, for organizing such a grand academic feast once again for all of us. And I thank you. I thank all the speakers who presented their case very well. One question I had in mind, that the patient was a doctor with a tortuous large segment tortuous circumflex, which is a large OM. So the point which was probably missed by that with the large OM may need a stent selection, which we have a large cell size. So if the cell size is big, then probably if you need to intervene into that side branch of large OM. So again, I think Onyx would be scoring on that ground. What do you say, sir?
To me, question?
Yeah, I would like to, because
I can answer that. That's okay.
Yeah.
I can answer that. Yes.
Because the previous two speakers were right, little bit in favor of Onyx already. So maybe they are taken into account that factor. So I think I would like to put it to you, sir.
Onyx is a very good stent, brilliant stent, and has been proposed as one of the stents for easy access to the side branch. Having said that, there are some parameters in terms of patients' lesion morphology, which determines whether when you stent the side across the side branch, whether that side branch is going to be pinched or not. I have not seen any more criteria given in that, and I did not have time to look at the angiogram properly, but it doesn't look like that side branch stenting across with any new stents nowadays is going to be a problem in terms of pinching of that side branch. Although I agree with you that Onyx is one of the better stents in terms of side branch access. Yes.
Thank you very much, all the three speakers. You did a wonderful job. Thank you, Dr. Nikhil, for mentioning me more than once for the publication that we did. And I think I was the only one who probably was not the investigator in that trial. I was just the one who drafted that manuscript. You all guys did actually more of abluminous than probably I might have done for that registry. Of course, I do use it very often. That's a very well published and well accepted data now that we have. The whole idea was not to pitch one stent against the other, but was to discuss about the various aspects of the stents that are often overlooked. People end up choosing one stent for the sake of one or the other reason, but there are more than one reason that you all three beautifully highlighted, that it's not just the drug, it's not just the deliverability, it's not just the platform, it's not just the polymer, it's not just the side branch access, strut thickness, cell design. There's so many parameters that an interventional cardiologist should learn and understand before he chooses and becomes an implanter. He should know what he's implanting. So that was very well brought out by all the three speakers. Wonderful session, all the chairpersons. Thank you very much. Any closing comments, Chair? And then we can close the session. Chairpersons, moderators.
So I think we have discussed everything, but we missed about the BRS, which I was going to ask for this case. So if anybody wants to put a comment, Dr. B.C. Kamath, sir, what is your take on for a BRS in a given case? As the patient is a doctor, he may ask for the BRS, our Indian BRS nowadays.
I having burned once my fingers, not me myself, I would always be skeptical. I've used only 2 BRS previously. And I realized when a lot of big shots who were getting their BRS done in Delhi, coming back to Ahmedabad and getting the stent thrombosis, you also know, Kamlesh, that. And then I realized it's a playing with fire. I will wait for more evidences to come. So till then, I think I'm still going to wait around till the BRS actually gets you good data. And that's why we get good data.
Hi.
That's true.
Dr. Kalmat here. Hi,
yes,
Kamal.
Yes.
And Kamlesh.
Yes.
And I thank you for that. All my colleague Nikhil and even Dr. Arora came back saying that ultimately the Onyx will going to play a lot of role in all these patients because there's such a huge data. And thanks, Nikhil, for proving my point. So because the side branch and diabetic, I don't think you have any competition when you look at the all over the data all the world. Of course, but he's a great man. He's like a criminal lawyer. He can defend anybody and get them out of the Nikhil is like a criminal lawyer. Thank you so much.
Thank you
so much.
Thank you. Thank you.
Next slide, please. Good evening. I would like to invite Dr. Javin Jameria, Dr. Mukesh Jha, Dr. Pratik Rawal as a moderators, and Dr. Darshan Bankar, Dr. Mihir Tanna, and Dr. Apurva Vasavada as a chairpersons. Please introduce our speakers. Please, Dr. Apurva or Dr. Bankar, you can introduce the speakers, respective.
Hi, I'm Dr. Mihir Tanna. If none of them are around, I'll get the session going. We are here to discuss a case of a 55-year-old male with a 99% calcified long LED lesion with a TIMI2 flow, significant ECG changes, but negative biomarkers, but positive nuclear imaging scan. What would be the best strategy? The bout is between Dr. D.S. Gambhir, who will speak in favor of rotablation, old is gold, versus Dr. Prakashveer Parikh of Ahmedabad, who will speak on IVL as a game changer. We both know these two speakers very well. We have learned firsthand from these two speakers in our career. I welcome Dr. D.S. Gambhir, sir, to first talk on rotablation, old is gold. If he's going first.
So I think Dr. Prakashveer Parikh should be going first.
Okay.
Dr. Gambhir has got network issues. He's not able to go through. So we'll have Dr. Prakashveer Parikh sir presenting first. Can we have the slides for the presentation? RX Events, the slide show. The case, please.
My screen is, I think, disabled, I think. Can you change the screen? I'm not able to share my screen.
Next slide. Next slide, please.
Can you see my screen?
No, sir, you have to share your screen. There is a green.
Yeah, but they were, I think, disabled, I think.
Can you go, sir, Dr. Prakash V. Parikh, sir, you can share your slides, please.
Is it visible now? Is it visible now?
Yes, yes. Now it is on screen.
So can I start my presentation?
Yes, sir.
Yeah, first of all, I'd like to thank Dr. Kamal Sharma for inviting me to his presentation again in the CardioCon. As you know, before 3 years, I spoke on the same topic, the rotablation, old is gold. But now 3 years have passed, and now we have new technology, the intravascular lithotripsy, which is a very exciting and revolutionary technology. So I'll discuss this technology. As you know, the calcified lesion.
Sir, sorry to interrupt you. Can you please put it on a slideshow mode?
This slideshow mode, yeah. Is it okay?
No, sir. You are not on the slideshow mode. Kindly stop. Just click on the
from beginning. Click on the upper left from beginning. Yes, sir.
Okay.
Not okay, sir. Sir, sir, just once stop share your screen and reshare.
I think it's okay. Even with this, we can see the slides.
Is it visible now?
Yes, sir.
Can you see my slides?
Yes, sir. We can see your slides.
So can I start my presentation?
Yes, sir.
Okay. Is it okay?
So please make it full screen.
It is full screen.
Kamal, it's okay. We can continue. Even with this screen, we can see it. Not a problem.
Okay, sir. Okay, go ahead, please.
Okay, so the calcified lesions, the lesion preparation is the key to PCI success. Despite having several calcium modification devices, including balloon-based techniques and atherectomy techniques, PCI results still continue to remain suboptimal with inferior long-term outcome in calcified lesions. I think this is mainly because it's the inability to treat the deep calcium and eccentric calcium with the currently available devices, except IVL. And the previous, all the devices which are excellent atherectomy devices, but they were higher procedure complication rate. As you know, the mechanism of action of calcium modification devices, there are only two ways to treat calcified lesion. The first is creating cracks, and second is volume reduction. Creating cracks, the best devices are cutting balloon and IVL, and for volume reduction, we have rotational atherectomy and orbital atherectomy.
Sir, we can see only your first slide. It is not moving forward.
Sir, stop your presentation, restart sharing.
Yes, sir. Now we
Now can you see?
Not yet, sir.
Now?
Yes, sir. Now it is on calcium modification devices.
Yes. Okay, is it okay?
Yes, sir. Yeah.
Can you see this slide, calcium modification devices?
Yes, sir.
So when you select the calcium modification devices, the three important aspects are device crossing, is the ability to create cracks in the calcified lesion, and its ability to ablate the calcium. Can you see my next slide now? Rotational atherectomy.
No, sir.
I don't know what is the problem. I don't know.
Now we can.
So rotational atherectomy is an excellent device because it creates massive cracks towards the wire base side. It definitely ablates the calcium and makes the calcium thin. It's got an excellent crossability. Can you see my next slide?
Yes, sir.
Okay. But however, as you know, the rotational atherectomy is a complex procedure. It is a hard learning curve. It needs special training and expertise. And effectiveness and safety are technique dependent. Often requires larger guiding catheter, particularly if you need a bigger bore. Rotawire is not suitable for direct wiring in calcified tortuous lesions. So you use the conventional wire and exchange with the microcatheter. And of course, when treating important bifurcation lesion, you are unable to protect the side band with a second wire when you are using rotablation. In addition, there are special complications which are unique to rota procedure, like entrapment of burr, severe distal embolization leading to nori flow, slow flow, and periprocedural MI, perforation, especially in tortuous anatomy, bradyarrhythmias, particularly when you are treating dominant RCA or dominant circumflex, and which may require prophylactic temporary pressing. Often, sometimes the rota procedure itself can lead to wire fracture of rota wire. And this risk is particularly increased in special clinical scenarios like thrombotic lesions in ACS, if the patient has dissected arteries, patient who have low ejection fraction, and we are doing intervention on the last remaining artery. In addition, rota is not always effective. As you know, the rota ablation is contact dependent, and ablation is highly influenced by the wire bias because rota works on the wire. So in patients who have eccentric lesion with unfavorable wire bias, rota is not likely to work. In addition, it is less effective in modifying calcium in large arteries with relatively large lumen. And it can ablate only superficial calcium, and deep modification remains very limited. So the major drawbacks of rotational atherectomy are, despite being a very efficient device, the procedure itself is a very complex, not amenable to all the interventional cardiologists. It is associated with a life-threatening complication in a small number of patients. It is not consistently effective, and it's got several relative and absolute contraindications. So there is an unmet need for effective, safe, and operator-friendly device for preparing calcified lesions and improve clinical outcomes. Now, shockwave intravascular lithotripsy is a new vessel preparation technique for calcified lesions. It has got a unique, interesting mechanism of action. It has been developed based on the principles of kidney stone treatment, in which it has been used for more than 30 years. And based on the same principle, now the IVL has been developed to treat the coronary calcium. Basically, the device has three components: generator, connector, and catheter. Generator is compact, rechargeable, and via connector, it delivers electrical energy to the IVL catheter, which has got two emitters. And this catheter is like a routine conventional angioplasty balloon, the monolayer balloon. It can be advanced over any 014 wire using standard PCR techniques, and it can deliver up to 80 lithotripsy pulses. It has got unique mechanism of action. The balloon emitters receive electrical pulses from the generator, and that electrical charge will vaporize the fluid and creates the rapidly expanding coalescing bubbles, which generates the sonic pressure waves. And these pressure waves are unfocused, and they deliver circumferential pulsatile mechanical energy into vessel wall with the equivalent of almost 50 atmosphere pressure. And it interacts with the high density calcified tissue. It doesn't affect the soft tissue, doesn't damage the soft tissue, and it creates the multiple micro and macro fractures in the calcified plaque, which improves the vessel compliance, and thereby it helps in expanding the vessel and the stent. It is a very simple device to use. No special training or experience required. It's 6-friend guiding catheter and as well as 6-friend guide extension device compatible. No special guide required. It can be performed if the procedure with IVL can be performed on varicose wire. And you must be wondering why the IVL is so effective. I think because it's the best device to create fractures in calcified lesion. It creates multiplane, circumferential, longitudinal, and then sometimes even transmural fractures across the calcified plaque. And as you know, the higher the number of cracks, better is the vessel compliance. So by modifying superficial and deep calcium, it definitely helps to open up the calcified lesion. And there is no issue of wire bias because the balloon inflation eliminates the wire bias and it provides a circumferential calcium modification. As compared to rotabetter, it provides calcium modification only where the burr touches the arterial wall or calcified plaque. It doesn't ablate the opposite wall calcium. So IVL is a king of tracking devices, is effective across the calcium spectrum, whether it's superficial or deep, concentric or eccentric. Even it can crack the calcium behind the stent, previously deployed stent, either acutely deployed or chronically deployed stent. It also helps to treat the nodular calcification also. And most importantly, is not influenced by the wire bias. So IVL is a one-stop solution for all you need to treat the calcium. And then why IVL is very safe? It is simple, effective, it is safe. Why safe? Because it is based on the very important concept. Because it is the wave, sound waves, and not the balloon, which creates the disruptive force. It modifies the calcium not by balloon inflation, but by sound waves. Because balloon is inflated only at 4 atmosphere pressure. So because there is low pressure balloon inflation, it reduces the risk of barotrauma, dissection, and perforation. And it's a differential disruption. It doesn't affect the soft tissue. It is hard on hard and soft on soft. So it's very safe. And the calcium fragments which are generated by the IVL, they remain in the vessel wall. So there is no risk of distal embolization and no slow flow, no periprocessal MI. So IVL got exceptional safety. There is no risk of bradyarrhythmias, so no need for temporary pacing, no additional need for mechanical support devices in patients who have low ejection fraction because there is no risk of distal embolization and no reflow. Now, IVL is safe to use in different clinical scenarios like low ejection fraction. Even with the bipercussion lesion, you can keep the wire in the side branch because it doesn't interact with the side branch wire. You can perform intervention safely in the last remaining vessel. Even in target vessel which supplies the corridors to other important arteries, IVL is safe. You can use IVL if required in calcified lesions, during STEMI, during LMCA procedures, even in tortuous arteries and long lesions because there is no risk of perforation. These are all theoretical discussions, but I will show the data also. This is the safety and effectiveness data of IVL across the disrupt series studies. As you can see, the 30 days MACE is very low, around 5 to 7% in heavily calcified lesions. And procedure success rate was more than 90% in these complex patients. And as you can see, complication rate is very, very low. There is 0% incidence of no reflow, 0% of slow flow, abrupt close is extremely rare, perforation is extremely rare, no flow limiting dissection is extremely rare. So basically any angiographic complication using the IVL is extremely rare. So it's a very, very safe device, an effective device. And the data from disrupt CAD4, 1 to 4 OCD sub-studies. There is some controversy regarding whether IVL is effective in eccentric lesion like concentric calcific lesion. As you can see in this slide, despite the difference in the calcific arc, less than 180, 182 to 20, or more than 360 or 360 arc, IVL achieves a similar MSA across this different calcium arc, and stent expansion is also similar, despite similar even in concentric as well as in the eccentric lesions. And IVL can be used at all stages of PCI. You can use it upfront, or you can use it secondary when you fail with the other devices like high pressure balloon devices or rotablation. If you fail rotablation, you can IVL even if artery is dissected. You can use IVL even if you have by mistake by under preparing the vessel, you deploy the stent and the stent is under expanded. Still, you can use IVL to expand the stent completely. And patients who come with the late restenosis because of underlying stent under expansion because of calcified plaque, even if this chronic stent also IVL can be successfully used to expand the stent completely. So in short, the IBL is a reversion technology. It's simple to use, very safe, highly effective, and widely applicable in different subsets of lesions and clinical scenarios like bifurcation, thrombus, dissection, tortuous lesions, ACS, low EF, LMCA. It can be used primary, secondary, or tertiary also.
Sir, please wind up. Time is up.
Okay, thank you. This is my last slide. Okay.
So do we have Dr. Gambhir? He's able to join now. Dr. Gambhir, over to you. Your session, please, sir. So please share your slides. Over to chair. Meanwhile, if they can have some discussion as Dr. Gambhir shares the slide.
Dr. Vasada here.
Yes.
Hello.
Yes, I can hear you. Yeah.
I think Dr. Gambhir is
Am I audible?
Yes, sir.
Am I audible?
Yes, sir. Yes, sir. You are audible.
Okay. I think the case has already been presented by my opponent, so I would not go into the details of the case, but what I am supposed to do is what is the best strategy of a plaque modification, and I am supposed to speak in favor of rotablation, which is the time-tested technology, and as we say, old is gold. Now, when we talk of this particular case, there are three basic features which one has to keep it in mind. One is that long stenosis. Now, what is a long stenosis? Nobody has given a precise definition, but what I feel is that when the target vessel stenosis is more than 20 millimeter, I feel it's a long stenosis. Tortuosity is defined as presence of multiple bends before, within, or after the disease segment, as has been shown in this case, and presence of visible calcification, as has been said in this case, which can be seen even on fluoroscopy, IVUS, or on OCT. Now, when we talk of this case, which has been given to us, unfortunately, we do not have the angiogram. But what I feel is that there are three distinct morphological features of this high-grade LAD stenosis, which have been said in the clinical profile. One is calcification, the second is long length of stenosis, and the third is tortuosity of the vessel, as you can see in this angiogram. Now, plaque modification is required certainly. So what is the best way? What is the best way forward in treating such a case? Well, I would like to do first a image-guided assessment of this calcific stenosis, which is very important. And since I am very familiar with the IVUS, I would talk about IVUS. Now, there are a few features one has to see, whether it is a superficial or a deep calcification, whether the calcification is thin rim or is it thick calcium. As you can identify that the thin calcium, you can see reverberations behind the calcium, and thick, you do not see anything. Then what is the arc of calcification? Is it 180 degree, 270 degree, 360 degree? Because each one of these features carry a different subset of technology which needs for its treatment. Then the length of the stenosis, if it is more than 5 millimeter, or is it longer than that, or is it less than 5 millimeter? And then if there is a presence of calcium nodules or calcific nodule, all these features are important in assessing the type of technology that you are using. Now, more recently, there is a very latest publication which have given us a scoring system based upon the IVUS. And I must tell all the participants that how do we score this calcification and then choose the technology. Now, first thing is, if there is a calcium on angiography which is visible, then you do a IVUS assessment. And on IVUS, if there is a maximum superficial calcification, which is more than 270 degree, you proceed further. And then you do the calcium scoring on IVUS. Now, if the calcium arc is more than 270 degree in a length of more than 5 millimeter, you give 1 point, and if it is not there, you give a 0 point. If calcium score is 360 degree, you straight away give 1 point. If calcific nodule is there, you give 1 point, and if it is not there, then you give no point. And if the vessel diameter is less than 3.5, because this scoring system does not hold true in a vessel more than 3.5. So if the added up score is 2, 3, or 4, then you consider atherectomy in these cases. Now, which helps you to certainly allow adequate expansion of the stent and after plaque modification. Now, I'll give you a case illustration because we have not been given the angiogram. Now, this is one of the such examples which have been highlighted in this case. Patient who has got a highly calcific, very tortuous vessel, long stenosis, including the left main and all the vessels, but we will stick ourselves to the LED assessment. Now, we did a IVS assessment in this patient and took a pull back from proximal to the distal part. And you can see here that there are, this is a mid LED, and there is a 180 degree calcium in the proximal LED. There is a calcium ring. So all these features we have considered and then did a scoring, and we found that the overall score was 3 in this patient. So we straight away went with a rotational atherectomy in this patient, and you can see that this is 1.25 millimeter burr and 1.5 millimeter burr, which went on easily, decalcified the long region, the LED. And after deploying 5 stents, including the left main, and this was the result. Now, this patient has lived on for 3 years after that and is still doing very well. So that is the classical example of scoring system and how do we select the atherectomy. Now, it is said that if there is superficial calcification, rotablation is very good, but may not be a useful device for deep calcification, where most interventional cardiologists feel that IVL or a cutting balloon or a scoring balloon are possibly the treatment of choice. Well, I personally do not agree to this, and I will show you a case where we have done excellent rotablation in the patient who has got a deep calcification. Let's see this. Deep calcification and coronary stenosis where rotablation versus IVL. So a successful debulking was done by rotablation, but the only thing which I would like at the emphasize is the appropriate size of the burr. Now, this is a patient who has got a high-grade stenosis, something what has been said in this history, a high-grade stenosis which is highly calcified. You can see in both the views, calcification which is visible as such. We did a pull back of this LED from LED to LMCA, and you can see that the calcium thickness at the maximum point was as much as 0.75 millimeters. So it's a not only a superficial but a deep calcification, and a thick calcification is seen. Now, we did a rotablation using 1.5 followed by a 1.75 millimeter burr. And after 1.75, you can see now some reverberations are seen. That means some decalcification has been done with this burr. And then we did a balloon on this, and 3 millimeter balloon still fails to break the waist, and you can still see a significant amount of waste in the middle of this balloon. So we went ahead and did now burring with a 2 millimeter burr. So we upsized the burr to 2 millimeter burr, and that's a point which I need to emphasize, that you have to go to an optimal size of the burr. And when we took a 2 millimeter burr, there were still some areas which were not fully dilated. So at this point of time, we took a OPN balloon, and now the OPN balloon has allowed a successful cracking off of this highly calcified stenotic lesion, which could not be treated otherwise. And now you see a lot of reverberations, and you can see the thickness of the calcium has also been reduced. And then we deployed a stent 3.5 into 32, and you see the final result. So this case illustrates clearly that not only superficial but even a deep calcification can be done provided you use the optimal burr. Now, I would like to leave it here. The conclusion certainly is certainly in favor of rotablation, and there is no need for costly technologies like IVL, etc. Now, since I would not have the time later on, so I think I would like to also show you the limitations in few slides of IVL. Well, as my friend has already said that there are advantages of IVL, but I feel that it is usable only in lesions which are crossable, but in lesions which are not even crossable with balloon, you can't use a technology like IVL. It is difficult to use this device because of the bulky nature of the IVL balloon. The profile is 0.042. It's generally recommended for deep calcification, but I have used it in deep calcification in 2 or 3 of these patients. And then high cost of the balloon and other hardwares is the biggest limitation. Now, when you look at the Disrupt 3 trial, which is the largest trial on this device with 431 patients, you see that overall the failure to cross with the balloon was 2%, guide extension was required in 17%, and buddy wire was required in 3% of the patients. And pre-IVL adjunct devices like balloon dilatation was required in 55. How the cases required a pre-dilatation with balloon, and rotablation before in another multicentric registry was required in 5% of the patients. So you can very well see that you have to add the cost of all these things. Procedural problems are there. IVL catheter uses 1.2 catheter per patient, and you know the cost of the catheter. I need not. And outcome of Disrupt 3 Maze at 30 days was 7.8%, deaths 0.5%. And so I will now like to end up by showing a quick case where Rota has worked, where IVL has failed. Now, this is a very interesting case. Now, you see a highly calcified LAD with very tight stenotic areas in the proximal LAD and again the distal LAD, but in between the entire length of the LAD is highly calcified and stenosed. Now, we again did a IVUS pull back in this case, and the total score was 3. And you can see here that we first did a rota burr and rotablation using a 1.5 millimeter burr, and this was followed up by a IVL balloon. Now this is at the distal site where we first, you can see that ruptured the balloon. That's the biggest limitation of IVL. So we ruptured a balloon here, adds to the cost of another 2.5 lakh. So we had to use a second balloon, which finally worked on the second lesion, but it still did not work on the first lesion. You can see that the waste persists despite giving, I think, almost about 7 cycles. Then we went up and we now did a high pressure balloon dilatation, but we were still unsuccessful. The waste persists. Now, at this point in time, we were frustrated, and so was the company of which supplies IVL balloon was also frustrated. So I thought we should now fall back onto our time-tested device, that is rotablation. And we again introduced a rota wire, and now we picked up a 2 millimeter bar. Earlier, we had done the 1.75. So now we did a burring with a 2 millimeter bar. And now after this, we put a balloon, and now the balloon allowed the cracking of the lesion. You can see here that there are 3 wires inside. That possibly also helped. There are 3 wires, and this has been very well described, and we often use this. And after this, we deployed a stent, and you can see the final result. So this is a rare kind of a case where we had to use a rota after an IVL which failed to crack the stenosis. So friends, I conclude that it is feasible and safe to perform PCI in highly calcified coronary stenosis with adequate modification of plaque, which I have shown you in 3 cases. And the algorithmic approach using IVS is very important for plaque modification. And IVS guided imaging helps you to do the scoring and then pick up the device, whether you have to use a atherectomy or whether you don't have to use a atherectomy. And in some cases, IVL may be required. It's a very deep calcification and you don't have a burr of higher size. And debulking using rotablation can be performed successfully even after failed IVL, even after a dissection using appropriate size of the rota bar. The problem is that most of the people don't use a burr of an appropriate size, that is 1.75, 2, and even now 2.25 is available. And if you use an adequate size of the balloon, you can get into the deep calcification and you can get an ideal result and adequate expansion of the stent. With that, I thank you very much. And I am sorry because of the problem with the net in my department.
Thank you very much, sir. Thank you very much, sir.
Can't hear you.
Yes, over to chair. Over to chair.
Thank you, Dr. Gambhir sir. And as both the speakers kind of agreed on this, that of the 3 intentions where we use these devices for lesion entry, for cracking the lesion, and volume reduction, Rota scores over IVL for lesion entry as well as volume reduction. Yes, Rota has a longer learning curve, but it is not rocket science. With dedication, we can definitely overcome the learning curve. Yes, it does have a fewer more complications, but it is not like firing an assault rifle, and with proper case selection and planning, complications can also be minimized. Having said that, IVL is a fantastic new technology which does make things easier in quite a lot of cases. It is very expensive at present, but I'm sure the cost is likely to come down in near future, and it will find a much wider application in our cath labs then. Thank you.
Dr. Darshan Bhai, Dr. Banker, your comments?
Yeah, see, in calcified lesion, still we are learning a lot of things, and IVL has shown a lot of promise, but still we are, I mean, we have to take it with pinch of salt. We don't have very long-term data available for IVL. And we know since it affects the deep tissue, the same time how the deep tissue will react after years, we have no idea. So we have to, we started with atherectomy devices long back in 93, 94, and we know we don't even use it, okay? So the same thing applies, that we affect the deep tissues, how it will react on long term, we have no data. But ultimately in calcified lesion, failing to prepare the bed is like preparing to fail. So how you prepare depends on the size of the vessel, as the previous person told that it is like entry point, and the amount of stenosis we have, it depends on that. But apart from that, obviously we have a lot of exciting things coming up with IVL, because it is so easy. Anybody who has been trained in angioplasty can just put an IVL, do the calcified lesions now. Thank you.
Dr. Apurva Bhai, Dr. Jevin.
Yeah, I have certain things to point out. I just learned in a very expensive manner that IVL can fail also. Recently I had a case of proximal mediality, very heavy calcification. And we had planned for rotatripsy with understanding that if the balloon crosses and dilates, we will not use the rota. And 1.5 and 2 balloon dilated fairly well. And then
Yeah, Dr. Jevin?
Yes, sir.
Anybody from the chair?
There is a
other comments?
question from the audience, basically.
After the first 10.
Apurva sir, you are not audible. Dr. Apurva, you are not audible.
And that was it.
Can I make one of the comments?
Okay, can you hear me now?
Mr. Chairperson? Well, a small comment at the end if I'm audible.
Hello.
I think if you go by consensus, many people may raise their hands in favor of IVL. Why? I think the problem here is that people are not ready to use a very effective device like rotablation, because I agree that learning curve is there. People are somehow scared in using a rotablation because it needs a coordination of your eyes, ears, hands, and foot. And if you get trained in using a rotablation, there is no device which does so many wonders like rotablation. Now, IVL is a very simple, easy device to use, but understand that in 50% of the cases, you have to do something before IVL balloon really reaches the target size. And in some 5% of the cases, you have to do a pre-IVL rotablation. So you have to learn rotablation if you want to do an effective IVL also. And if the IVL fails, which I can tell you that in my experience, I've not done very many IVL. It failed in a lesion which was heavily calcified, but not very heavily calcified. So I had to fall back onto rota. So you have to learn rota. Don't go with the impression that IVL has come, so your job is over. No, you have to learn rota. Rota is the final answer. Before IVL, after IVL, everywhere rota has to be learned and then practiced. Okay, thank you.
Thank you very much. Thank you, chairpersons. Thank you, sir. Dr. Prakashveer Parekh, Dr. D.S. Gambhir. I've learned Rota from you, sir. I've been there in your lab, and I've learned Rota when you did. And I always say this with pride that I have seen Dr. Gambhir have a perforation which he seals off, and that gave me the confidence. Not the 6 cases that he went through, but he taught me that even if you end up perforating, that's how you manage the case beautifully. And that gave me the actual, I mean, if I would have been there with you those 6 cases where you not had perforation, I don't think I would have started Rota. Only when I knew how to tackle the perforation, I learned it. And that was the fantastic thing.
Therefore, I should not allow you to come to my lab, because when you came, then there was a perforation. Okay, thank
we
you.
move to the next session. Thank you very much. For the next session, I invite Dr. Parshvara, Dr. Keyur Patel, and Dr. Manjunath as moderator, and Dr. Hitesha, Dr. Pramesh Gayatane, and Dr. Himang Gandhi as chairperson. I would request the chairpersons to introduce both the speakers and the case, and then the video of the same, and then move to the debate.
Yeah, hello, Dr. Hemang. Dr. Vivek Wadhwa is a professor in Department of Cardiovascular Thoracic Surgery in UN Mehta Hospital. For me, now he is working in the Raipur in private hospital. Is very good. I have worked with him for a long time. He's very good in surgical hand with the all CABG and valvular, and even with the minimal invasive cardiovascular surgeries. So he's a very dynamic surgeon. He will give today on that minimal that pacemaker with minimal CABG. And second speaker is Dr. Shomo Bora. He is associate professor also in the UN Mehta Cardiology Institute. He is my colleague from the MBBS, so I know him very well. So I worked with him in the UN Mehta also, and is very good in the EP study as well as a good human being. He has a lot of publications, and is an editor in IPEG, and he is the author of chapters in the various books of ECG and EP studies. Both speakers are very good and very dynamic, so we have a very good discussion for today's topic. So you can hand over to the one of speakers.
Hi, Dr. Himang. Thank you so much.
Yeah.
Am I audible?
Yeah, audible.
So I would just switch on to my screen, and I think so. Is it visible?
Yeah, it's visible.
Yeah. First of all, I congratulate the team Cardiocon for such a wonderful effort they have put in, and I especially thank Dr. Kamal Sharma for having me here. Thank you so much. So I'll straight away shoot on to my case. We have a 88-year-old lady with a degenerative complete heart block here, who is on hemodialysis with right upper AV fistula and an occluded left AV fistula. So scheduled for a permanent pacemaker. She also has a 100% ostial LAD lesion with a good distal target. So we want to decide on a permanent pacing strategy. So before jumping on to my conclusion, I would like to know a few things like the symptomatic status of the patient, collaterals on the angio, LV function, associated other comorbidities if she has, her frailty score, and her functional status. So if she is asymptomatic and if the vessel is very well collateralized, I don't want to touch her. I would just refer her to Dr. Shomu to do whatever he wants to do with her, like whichever way he wants to deal with her CHB, because he best knows how to deal with her. But if it is not so, then definitely I would want to go ahead with MICAS, so minimally invasive coronary artery surgery, along with an epicardial pacemaker implantation. Why? Because I feel for an ostial lesion with a good distal target, MICS is a straightforward surgery with as good a result as open surgery with a single graft lemur to LAD. And especially in such older patients, I want to avoid sternotomy because with an old age and renal failure, they might have healing issues. especially for the sternum. So it's a safe, simple procedure. And then when I'm going ahead with a lima to LAD, the heart is right there in front of me. I just want to go ahead and put the epicardial leads. Anyways, even if I'm not, even if the patient doesn't have a coronary artery, even if the patient doesn't have a CHB, I'm going to put temporary leads for the post-operative period, which may be one the atrial lead and another the ventricular lead. So this procedure is going to happen. But if the patient has a CHB, I'll definitely put a permanent lead. Then the procedure is cost effective because leadless pacemaker, the other option we have, may cost fortune to the patient. It reduces the hospital stay because both the procedures are being done in one setting. The cabbage is being done along with the epicardial pacing. And in a patient, in a 88-year-old lady with CHB who has undergone cabbage, I want early mobilization and a faster recovery. I don't want to add another procedure of pacing at a later date. So I want to be job done in the one go. And transepicardial pacing, some may say that it has got higher threshold and the battery may last less and all that. But in a 88-year-old lady, I just don't want to go in for another procedure in the post-operative period. Considering transepicardial pacing to be an established procedure, I want to add it to the cabbage. Then why will I not go for leadless pacing? So as everybody says that all procedures do have their own complications. Why you want to add another procedure to it? Post cabbage, if the patient has some post cabbage, if you add another procedure to it, it may have complications and it will definitely add to the discomfort of the patient. You don't want to do it. Apart from cost, the complications, like I said, with leadless pacing, there might be pericardial effusions and cardiac tamponade due to cardiac perforation, and then rushing in the patient for another surgery. You don't want to do that. They might have another complications which may be trivial, but which will lead to immobilization of the patient in the post-operative period, and you don't want to do it, like the vascular complications or device dislodgement or device migration, thrombosis of the device or tricuspid valve injury. The numbers may be small, but can become significant in a post-operative period. So I'll definitely use transepicardial pacing along with cabbage in this patient. But there are places where I will not use transepicardial pacing and refer the patient to Dr. Shomu, and those will be areas when the patient doesn't need cabbage, or if the patient has associated comorbidities and a high frailty score or a functional status that makes the patient a high-risk candidate for cabbage. So I rest my case here. I would like to share a few things regarding epicardial pacing, because we are surrounded by surgeons and we are surrounded by cardiologists, and usually they don't see epicardial pacing being performed. So epicardial pacing is a routine procedure for after every cardiac surgery, in which we place simple leads in the post-operative period and they act like temporary pacing. But when the patient has CHB and we want to place permanent pacemakers, so we place permanent leads, which, as you can see in the figure, are fixed by sutures on the myocardium of the heart. We choose the place on the heart where the R wave has a good 4 millivolt potential, which can be very well tested with a technician around you. They place the lead on the heart, we place the lead on the heart, and they check the potentials, and wherever we can find the R wave to be more than 4 millivolts, we go ahead and fix the leads on the myocardium, avoiding the places where the fat is visible, where the lead can directly touch the myocardium. We fix the leads on the atria and on the ventricle for dual chamber pacing. We tend to use bipolar leads, which are always better than the unipolar leads. And we test the impedance and the threshold of the leads, and any threshold of less than 2 millivolts is good enough for the pacing. Then we make a say a pocket for the generator, and the pocket can be made anywhere where you find good amount of subcutaneous fat, and a good pocket can be created so that the the overlying skin heals nicely and there is no tension on the skin, and the pocket is very well cauterized, and so that there is no hematoma formation over the pocket, and all this can be done very safely. So I rest my case here, and now it is up to the opposing counsel, Dr. Shomu, to go ahead with it.
Yeah, thanks, Dr. Vivek. You'll have to stop your screen share before I start. Actually, you have...
I'll do that, sir.
Yeah, you have helped me give the debate very well, because you have already said that bypass is an option in only a few of patients. So before I start, I would like to thank Dr. Kamal Sharma and Cardiocon team for having invited me for the presentation. Respected chairpersons as moderator, if I'm audible very clearly, I should go ahead. Is it okay?
Yeah, you are audible. Yeah,
and the screen slide is seen well. Is it seen?
Not yet, sir.
Sorry?
Not yet.
No, Shomu, you need to share your screen. It's not visible.
Yeah. So, is it now seen well?
Yes.
Now seen, sir. Okay. Okay. So, we have this case and questions, as Dr. Vivek had already discussed. And it's very important that we need to know the activity levels, weight, comorbidities, and the family status, because the cost of the implantation and etc. would be very heavy. But it's very important that why are we doing an intervention? What is the cause of a CHB and what is the implication, clinical implication in an 88-year-old who has CRF and who is on dialysis? Also, why an angiography was done? Was it just as a diagnostic procedure, or was it because of symptoms or because of an MI? It's very important to know. And having a fistula in the right upper side means you have increased flow in the left right venous system, so you'll not be able to take that as an option for doing a pacemaker. And having known that the left upper limb occluded fistula is there, we don't know whether the left subclavian vein is occluded also. So these are the questions that I would ask before I go ahead. So performing a pacemaker intervention, even at this age, 88, it doesn't mean that you have to perform in all. 88-year-old, and if the patient is ambulated and able to perform own activities with a reasonable heart rate of 50 to 60, I would not even want to do a pacemaker unless the patient has syncope, breathlessness, fatigue, pre-syncope, rates are very low, or the patient has ventricular arrhythmia and an unstable escape. So a pacemaker implantation only if these are there. And revascularization in an 88-year-old, first and foremost, symptom status. Unless the patient is functional class 3 or 4, I would not want to intervene except with medications. Also to know whether there is scar or not, if there is viability possible, because with a CHB, how will you check viability without only a echo is there? So other parameters like collaterals, other vessels are very important, and revascularization with PTC can be seen based on the lesion if possible, because everybody is doing LMCA interventions nowadays. So these are the clinical questions I'm going to ask. First, asymptomatic CHB low risk and CAD low risk, medical follow-up. Narrow complex, if it is there, heart rate is more than 40, no long pause, nothing to be done. Now, if you have a symptomatic CHB, and there are two things. If the left subclavian vein is occluded, you have to do a pacemaker. So venoplasty, and then do a single chamber from the left subclavian vein, or use other sites like femoral, hepatic, or jugular, or do a leadless pacemaker. Epicardial pacemaker just for this without a CABG, I would not be comfortable. If you have a left subclavian vein which is patent, then there is nothing asking. You just do a VVIR pacemaker from the left side. However, the problem is if the right side goes and you have to again go to the left side, or because you are using heparin again and again, a leadless pacemaker can be of choice in patients who afford. Now coming to symptomatic coronary artery disease patients, where patients would require intervention as well as pacemaker, think whether angioplasty is possible or not. And if angioplasty is possible, even LMCS stenting would not be bad. You can optimize medications, you can attempt PTCA. Only if this is not an alternative, then bypass plus epicardial pacemaker is there. And therefore, of the case that is given, only 20% would be actually referred for CABG. And of them, if you see, because of the age, female, family structure, 80% or 90% would not even agree for surgery if you offer them also. So what is remaining is these 4% patients who would be offered getting or get ready for surgery. And then the surgeon, after seeing the patient, would say, okay, let me ask whether I would be able to do from a renal point of view. Is the left subclavian artery proper and the lima is proper? Whether the healing would be good because the patient has renal issues, and whether I have a good hospital who will take care of it. So of that, again, 50% will go. So only 2% would be going for surgery. And therefore, no discussion is required generally. What is required? Only a pacemaker is required. Now, which type of pacemaker? So epicardial, I think Dr. Vivek has already told that there is a problem with epicardial leads, but I think 88-year-old, even if the lead fails over 5 to 10 years, it will be taken care of and we can again go ahead with another if it is bypass is done. So epicardial pacing is definitely a choice if you are doing bypass. But what are the options now? If you're not doing a bypass because you don't have a upper limb vein to put in a lead. So pacing options, if you don't have a suitable subclavian vein, are either another access or leadless pacing. So we'll go one by one. You can see this example where both the veins are not there. So what do? So the first option, which may be technically a little bit demanding, would be to have a venoplasty. You dilate the area of block. It may be subclavian, it may be superior vena cava, and get an access, and then you deliver a lead from that and put in a pacemaker. A single chamber VVIR would be okay. The second option is put a lead from the femoral vein. Now, to get this long leads is a problem, and then the sterility in a femoral area becomes an issue and the stability becomes an issue. So people have also tried this transhepatic venous approach where they can take a hepatic vein, as Dr. Means we do clearly tips and all in our labs. So similarly, you can just go ahead and get a hepatic access, and then through that you put in a lead and put a pacemaker on the epigastrium. Maybe a simpler way would be to get this kind of thing transjugular if the jugular is patent, and go from the internal jugular route, but the lead will be tunneled a long way. So it may not be very good cosmetically, especially if the patient is thin. So then came these leadless pacemakers, and there are 2 currently in market and 3rd in development. They're very small, the size of a coin. If you see, they are just 2 grams in weight, and they basically have a simple structure. If you see, it's a 1 unit without a lead. So if you're seeing this, there is a full unit which contains the battery, the circuit, telemetry, and the pacing electrode directly. And this is the sheath system that is given. So leadless pacemaker indications, you should know that when leads cannot be placed because of venous access problems, or there is local site disease. Where will you put if the local site skin is a problem, where there is post-surgical, post-radiotherapy, or there are AV fistulas, or there is an active inflammation or infection. In high-risk individuals who have AV block with atrial fibrillation and you require only a single chamber pacing, or patient who have AV block, now the leadless pacemaker have a VDD mode also. So both patients, you can consider this. It can be a patient preference because it's a simple procedure and nothing is there below the skin, and it can be because of many places operator preference also. So I'll just put this a very small video. So this is the delivery system. So you have to prepare the femoral site only, have a TPI from the left side. That it's a 23 French dilator and sheath is 26 French, so it's large. So you need to have a very good venous access. If it is very tortuous, you'll not be able to put this sheath. So it's a single system, preloaded system, everything comes. So this is seen without blood. You will not be able to see this. This is then seen on fluoroscopy. So now you have nothing else, and the same pacemaker can be interrogated by using the same programmers that we use. So there is sterile, so chest need not be sterile in these patients, but we do prepare the patient in case there is a tamponade. So So this is how you need to do one by one on fluoroscopy. You take a venous angio, see whether it is well, the dilator is advanced, and then you deploy this device. At least 2 tines of the 4 tines should be there. And this is what you see on fluoroscopy. There is no lead. The whole pacemaker is within the cavity of the RV. So implantation successes have been good, 97%. It's very easy, the 16 minutes procedure, 28 overall introducer to outside time. Most of them do not require any repositioning, and the patient can be discharged the very next day. And this procedure time will decrease with experience. However, you should know the contraindications. If you have a mechanical tricuspid valve, though there are case reports in which they have done through a mechanical tricuspid valve also. And if you have an IVC filter which cannot be removed, or you have tortuous wave, the problem is morbid obesity. If the patient is very obese, you will not be able to interrogate or check. So such patients cannot be taken up unless you have a way to check whether these will be able to be interrogated. And if you need atrial pacing for any reason, right now atrial based pacing is not there. The advantages are less implantation time, immediate recovery, complications related to leads like taking a subclavian access like hemothorax, pneumothorax, lead fracture, insulation breaks are avoided. There is no pocket, and therefore infection, hematoma, and cosmesis is much better. Implantation time is less, and shoulder mobility is never restricted. Many patients come with a frozen shoulder post-lead implantation of a routine pacemaker. However, the disadvantage of a leadless pacemaker is the cost is around 8 to 10 lakhs. Specialized equipment and training is required. You need a femoral access. And if there is a problem, then specialized procedure for extraction needs to be learned. You don't have a complete for ICD or CRT. And what happens when the battery goes out? So it's not unclear. In the pediatric population, it's not possible. So there are, technically, it is much better, less complications overall. However, there is a steep learning curve, and one should know that before doing. So these are, as Dr. Vivek has already shown this slide, there are complications. However, the incidence is much less. So these are some examples that you would see how a device would look after some time. You can actually put 2 to 3 devices, even if the battery goes. The complication dreaded would be the device migrates, or there is a vegetation, or there is a AV fistula locally. So summarizing, for a patient, this is a 88-year-old for CAD, optimization of medical management or angioplasty instead of bypass. If there is only functional class 2 or 1, then pacemaker only should be done. Angioplasty or bypass should be avoided. Subclavian venous access is often preferred, but if it is unlikely, then leadless pacing can be considered. Leadless advantages in this patient would be that you use a VDD leadless pacemaker, you will have AV synchrony. The chances of infection in a renal dysfunction patient would be less. You can immediately start with dual antiplatelet, and hemodialysis can be done with blood thinners without a fear of a pocket hematoma. However, the disadvantage would be cost, femoral related issues, and chances of mild infection. So summary, leadless pacemakers, though costly, offer standard pacing with immediate return to normal activities, and that is the highlight of doing a leadless pacemaker, and the complication rates are less. However, you should be judicious in advising leadless pacemaker as well as epicardial pacing in such patients. Just because the patient had a CHB or patient had CAD, you want to intervene should not be the criteria. The patient's symptoms are of paramount importance, and clinical evaluation is a must before you decide whatever is required. Thank you.
Yeah, over to chairpersons.
Thank you, Dr. Somu.
I think very well spoken, both the speakers. I think we, in our setup, what Dr. Vadva was talking about, cost constraints, and what Dr. Shoma was mentioning. I mean, I discussed with Dr. Shoma, and he also said that he also has done only one. But I said, you are the only one who's done one. Nobody else in Gujarat has done any. So you should be the only one speaking about this, nobody else. So I think he was also accepting the whole concept. And then he said, we need to have a reason enough to be using micra, and I think he is very well justified and brought out the case, like you have no access for the upper limb, you can't access it, and then CABG or no CABG is a separate debate in itself, what Dr. Shomu has clearly mentioned. Dr. Hemang, you were saying something?
Yeah, the same question someone has raised. If patient has IVC filter or some issue with that, we can use the jugular vein. I think someone has put up that to Somu, Dr. Somu.
Yeah, means if you, for a leadless pacing to do from an internal jugular, you need to be very, very confident, because 26 French and the sheath and everything, so movement, everything going from the neck is very difficult. There is, I think, 2 case reports what they have done from, but these case reports actually are done in very high volume centers, and also you should understand that this patient has a AV fistula, and you have already a problem on the venous axis in the upper side. So if something happens to the SVC, then you are actually gone. So I would not go from superior, I would definitely want from the inferior, because the hardware is made for an inferior approach. Hardware is not made for a superior approach.
Yeah, good say. I have the experience of putting the jugular vein for a large cannula in case of MICS, minimal invasive cardiac surgery. We use a venous drainage through the jugular vein in some cases. And I myself put quite a lot of times. And initially it was difficult for me, but after that we have find it is very easy to put, and that is around large bore cannula around 14 or 16 size that we are using. So that's why I ask. But it's what your concern is truly true that. Anyone wants to ask question?
Yeah, Dr. Hitesh was asking.
Yeah, Dr. Somu. Yeah, that was a nice presentation by you. And the thing is, the most important message is like the symptomatic status of the patient at this 88 years of age with CHP, and that needs to be evaluated because option of MICAS plus epicardial pacemaker goes on merits ground to a less suitable option. Leadless pacemaker with micra is only the valid option even if the patient has a symptomatic angina. In fact, if patient has a low heart rate.
So if I think we had a wonderful session, if we have no more questions, then we can have move to the next session. Thank you very much. Thank you, chairpersons. Check your speakers.
Thank you very much.
Thank you. Bye-bye.
Thank you, sir. Thank you, Kamal sir, for inviting all of us. And it's a nice.
Thank you. Can we have the slides? Yes. So I invite Dr. Shaival Majumdar, Dr. Nilay Patel, Dr. Alpesh Patel. So we have two cardiothoracic surgeons here, and Dr. Mridul Sharma and Dr. VC Chauhan as two chairpersons who are cardiologists. Dr. Nilay Patel is a cardiologist, and Dr. Ketav Lakhia is a cardiothoracic surgeon. So we have a pretty balanced two surgeons as moderator and one cardiologist as a moderator, and two cardiologists as chairperson and one cardiologist as cardiothoracic surgeon as a chairperson. I would invite them, the chairpersons, to introduce speakers for the day. Dr. Priyank Bhatt and Dr. Mamas, my friend Mamas from UK. It's wonderful to see you, Mamas. It's always a pleasure having him. He's the most published guy. People used to tell me that, Kamal, how do you get these number of papers? And then I saw Mamas's profile. Last year he published 100, and he's 5,000 plus publication, and I have even yet to cross one zero taken out of it. I'm not even 500. So that's Mamas for you. I mean, of course we'll have official introduction. Over to chair. Dr. VC Chauhan, you need to unmute.
So can you hear me?
Yes, sir.
But I think you have to, Kamal, you have to read, because in my computer there is some problem. I can read only one line of the chairperson, the speaker. So by the time I fix
Dr. Priyank Bhatt,
let Priyank Bhatt or someone.
Dr. Ketav or somebody else from the chair. Please introduce both the speakers and the case, and then we move to debate. Ketav, please unmute. You are
now I can see it if it's required. So Kamal, I can introduce Dr. Priyank Bhatt.
Yeah, please go ahead. Please go ahead.
Yeah. So basically, I have never met Dr. Priyank Bhatt. It's a great opportunity to meet him today because of Kamal Sharma. So you made a lot of dreams come true. Basically, he's a senior cardiothoracic surgeon at Sal Hospital, and everyone knows how great Sal Hospital is. He's expert not only routine cardiac bypass surgeries or revascularization, but also in MICAS surgery, which is probably one of the essential things that all cardiac surgeons should know. If cardiologist is there, he should know Rota. Same way cardiac surgeon must know the MICAS, so that he's one of them. And he's also expert in doing mitral as well as aortic valve surgeries. And I think, Kamal, this is rare debate where cardiologists and cardiac surgeons are going to talk against each other. In majority debate you've seen, it's cardiologist versus cardiologist. And the second one is Dr. Mamas, who is, as Kamal very rightly said, is very famous, internationally known cardiologist from UK. He's basically FRCS for UK and MRCP from London. He has multiple current appointments. I'm not going to detail because his speech lecture will itself say what he is. But he is having a lot of international and national positions and responsibility, like actively participating in European Society of Cardiology, European Association of PCI, heart research of UK medical review panel, etc. So without taking much time, I'll ask both of them to go one by one for the debate. First is Dr. Priyank Bhatt, and I think, should I read the history or he will read the history actually? So Priyank, it's over to you to start actually.
Yes. Am I audible?
Yeah.
Please share your screen.
Yeah, I'm sharing. Can you see it?
Yes. Please make it slideshow.
Yeah. So at the outset, I have to thank Dr. Kamal Bhai. Thank you very much for having here. As Dr. Chauhan rightly said, it's like a dream come true. I have to also thank all his team. Prashant is here, Jignesh, Kalpesh, everybody. Thank you very much for having me. And I'll start off by disclaiming that I am a surgeon. I am like a rabbit in front of all of you lions. So please look at me in that sense. And as the history said, what are we supposed to do for a critical left main in a young patient? Usually there are three options, as we all know: CABG, bypass surgery. You take Lima and put it on the LAD, or you can do a PCI. You just put a stent in the left main, 1 or 2 stents, double kissing. How? And third is medical therapy. We are not going to go into it because it's proven that it has worse outcomes in managing the critical left main, and alone left main is totally insufficient. Surgery has been the gold standard for left main over the years. We all grew up learning that left main is like the holy grail. Once the left main was diagnosed, it was immediately sent. And when I was, learning cardiac surgery, left main was an emergency. It still is. And we used to treat it like that. We used to get a left main and we used to operate at 1 o'clock, 2 o'clock in the night. Because there is a large area of myocardium which is at risk, it necessitates surgery on the emergency basis. And it has been treated as such till now. Some of the recent trials and controversies about them have tried to change this path of care a little bit. This is 2018 AHA ACC guidelines. Left main was class 1 indication for CABG in almost all the scenarios except proximal LAD disease. These are the newer 2021 guidelines. I have just kept the screenshot of the significant left main part. That significant left main stenosis still remains in all the scenarios, whether it is anatomically complex or not complex. It remains grade 1 class 1 indication with or without the discussion with the heart team. PCI is in non-complex diseases is grade class 2A indication. This is 2021 guidelines, which it came into 2A from 1. Historically speaking, these are the trials that have happened over last few years. It started with Le Mans in Poland, and now it's the Excel, which is the multicentric US and Europe trial, which has generated the controversy. If we can focus on the last 3, Syntax, Excel, and Nobel, diabetes prevalence or the LVEF were quite similar in both the PCI and CABG subsets. Average Syntax score was also quite similar in all 3. Composite outcomes in all the cases, in all the trials, have been either inferior or non-inferior. It has never been superior except for the stroke rates in the Syntax trial at the end of 5 years for PCI. In all other scenarios, it has remained inferior or non-inferior. I would like to point out that in Syntax, we do not know how many Limas were used and how many surgeries were off pump. In India, especially, when you see that most of the surgeries are going to be off pump, almost all surgeries are going to use Lima, the stroke rates are going to be less, certainly. If we start off with Nobel trial, which compared stenting to CABG with regards to death, MI, and repeat revascularization, it found that stenting fared worse than by CABG for this combination of outcomes. The difference was mainly due to higher rate of MIs and repeat revascularization. There was no difference in stroke or death in the 2 groups. These are the results of Excel trials also at the end of 5 years, which say which had the similar kind of outcomes. The MI generated a controversy, which we'll see in a minute. Nobel and Excel were quite similar in their design and primary endpoints, but differed in the sense that repeat revascularization was not the primary endpoint in Excel, and periprocedural MI, which was excluded in Nobel. This became significant because Noble and Excel both had higher rate of repeat revascularization and non-procedural MIs in PCI groups. And this drove the major adverse effect for PCI. In Excel, the primary endpoint was death, stroke, or MI, and it was similar in both PCI and CMBG. The higher rate of repeat revascularization was in PCI, which was considered a secondary endpoint. While the rate of MI in Excel was similar in PCI and CABG at 3 years, this was primarily driven by the higher rates of peri-procedural MIs, and the definition and the criteria to define peri-procedural were changed, which we will see. So non-procedural MIs, which happened later on, which were used in Noble, tended to be higher in PCI for PCI in Excel at the end of 3 and 5 years. So this generated the controversy. This is the editorial article in European Cardiac Review Journal of 30th March last year, which showed that Excel trial had many strengths, including its recruitment and successful follow-up of a large number of patients. The interpretation of his finding has generated controversy. The lead surgical investigator, Dr. David Taggart, withdrew his name from its final publication. It reached to that extent. Moreover, in December 19, European Association of Cardiothoracic Surgery Council withdrew its support for the treatment recommendation on left main coronary artery disease, which were based on the Excel trial findings. We, as surgeons, had two problems. The committee said that the overall results at the end of 5 years in Excel for PCI and CABG were neutral. They were non-inferior. The authors reported that patients with left main coronary artery disease and low syntax score, the primary endpoint death, stroke or MI at the end of 5 years was 22% in PCI and 19% in CABG, and concluded that there were no significant differences. All-cause mortality at the also was considered quite similar. The mortality actually at the end of 5 years was 38% higher in PCI arm compared to the CABG arm. So we subjected the Excel data to Bayesian methods, which give probability estimates of clinical interest and allow the consideration for pre-existing evidence and how it can influence the test results. And what it showed, reanalysis, is that mean difference regarding incidence of primary composite outcome was 3% lower in CABG group, whereas mortality was 1% lower in CABG compared to PCI at 5 years. In multiple systemic reviews have generated the same results. So this suggested that long-term results with the use of PCI in left main are inferior to CABG. And second bone of contention was that different definitions of MI were used in the Excel trial. In the Excel protocol itself, the universal definition of MI from the European Society of Cardiology was used, and it was supposed to be used. However, Excel investigators used this Society of Cardiovascular Angiography and Interventions definition later on. This was problematic as universal definition was pre-specified secondary endpoint in the original protocol. So David Taggart, one of the principal investigators, stated that the change in MI definition related to the fact that main protocol, which was saying that we would be using universal definition, was not adhered to. In the appendix of the protocol, there is a new biochemical definition of MI that had never been employed before. So why this change later on? If the original plan was to use creatinine kinase definition along with this, troponin assessment was very optional, and it was not used in majority of patients according to the authors. A large discrepancy has become apparent in number of CABG-related procedural MIs when data using two different definitions are compared. I will just skip to a slide. When you are using different definitions, if you are using the second or third universal definition, which was supposed to be in the protocol, the MI in the PCI was came out to be 18% or 3%. But when you use the newer definition, the biochemical definition, the peri-procedural MI became 18% in the CABG. it is quite natural, as if you handle the heart, the CPK is going to rise, which may not be significant or which may not be translated as MI. So, a lot of societies, lot of surgeons had a problem with this interpretation of data. Indian Journal of Thoracic Surgery and Thoracic and Cardiovascular Surgery last year came out with the addendum and with an entire journal edition, when it said that medicine has been turned on its head. Again, they will, to quote.
Yeah, sorry to disturb, but consider more on the case that we are going to discuss in your case.
I will just,
otherwise time will run out. Yeah.
So this is the controversy. So if you look at the what you call the data or the original recommendations since 2018, or even the lower, later on recommendations, anatomically complex left main, which is the case, it should undergo bypass surgery if possible, which is possible in this case, as patient is a young patient, and it's quite possible. In patients of low or intermediate anatomical complexity, role of heart team is there, and surgeons, cardiac surgeons, cardiologists, and the patients can sit together and discuss and decide. I would just end my presentation with a quote from a book of Talmud, that do not unto others what you would not have done to you. That is the whole law, and rests are just commentaries upon it. Thank you very much.
Yeah, thank you very much. Now I would invite Dr. Mamas to say why in this particular patient, we are not going to discuss surgery versus angioplasty, but in given patient, why angioplasty would be preferable over surgery. Over to Dr. Mamas.
So thank you for the invitations, and congratulations to Dr. Batt for a very nice overview of some of the literature. It's a real pleasure to present my interpretation of the case, and in front of such an eminent panel of Indian physicians and surgeons, and to see my good friend, Dr. Kamal Sharma. So let me just load up my, why is it? Let me open. Oh, sorry, it's not letting me. Oops, let me just, sorry, it's, oh dear, it's just gonna, yep, okay. I'm gonna have to quit and reopen. I'm gonna rejoin the meeting. For some reason, it's not letting me do it. Let me just, 2 seconds, I'm gonna rejoin.
Meanwhile, chairpersons, any comments on what Dr. Priyank Bhatt presented? My comments is that it's why is the world so unequally equal? Why the rules differ from one person to other person? Why is acute MI defined differently for surgeons and so differently for cardiologists? Why is an MI post-procedural defined as 3 times elevation, but for CABG it is defined 10 times elevation? Why, if the infarction reflects the injury, it is not proportionate to the time that you spend, whether on pump, off pump, or putting a stent, and if it causes an injury, be quantifiable equally? So I'm just leaving some important questions. I'm not answering anything by the time we have Dr. Mamas coming and talking his aspect, and then we can take this. And then we have the data of Excel, where the surgeons tend to differ, and even pre-combat, and they say, no, we are not going to accept this because you have tweaked the definition of acute MI, and your MACE is driven by MIs, which we don't believe, because MIs are something that elevations are bound to be more in our hand. So yes, Dr. Mamas, you're back here. So I was just trying to discuss why the world is so unequally equal or equally unequal, why troponins are defined differently for surgeons and cardiologists. So we can have your presentation. I was just doing the time filler, brain thinking, analyzing kind of a thing. Please go ahead.
So my discussion now will be why PCI is the best treatment modality in this patient for now. This is the clinical scenario. We've discussed it, a young patient with critical left main stent disease. But the debate is not about whether CABG or PCI is better in this patient. He's young. He will need both. We know that coronary artery disease is a progressive disorder. He will need both CABG and PCI at some point in the next 30 years of his life. The debate should be about whether it is better for the patient to have CABG now or in the future. And that's the important question. In this debate, I'm going to ask 4 questions, which I think are very important. Number 1, what do the trial data show us? And are the trial data applicable to this patient, a 37-year-old Indian patient? Number 2, does either option provide definitive treatment for the patient? Number 3, what are the patient-relevant outcomes for a 37-year-old patient that are important? And number 4, where and by whom should this patient be treated? So what do the randomized control trial data show us? We've seen this. This is the Excel data at 5 years, no difference in the primary outcome, although there was a slight increase in the risk of death in terms of absolute difference. It was 3%, no difference in myocardial infarction, a big difference in revascularization. This is one trial. When we look at the characteristics of the trial, though, the average age was 66, 30 years older than this patient. 91% of patients in this trial were white. This patient is Indian. And only 3% of procedures were undertaken outside of Europe and the US. The Excel trial is not representative of the healthcare system or the patients that we are dealing here today with. When we look at the sum total of the literature, an individual patient meta-analysis, there was no difference in 5-year risk between CABG and PCI in left main, and no difference in 10-year risk in mortality, okay? The only difference is in revascularization. So in terms of the 2 options in such a patient, no difference in mortality. In terms of, are there studies to look at this patient group? No, there aren't. There are no studies looking at PCI versus CABG with 20 to 30-year follow-up data in young Indian patients, which is what this guy is. So does either option provide definitive treatment for this patient? Well, this is data from an individual patient analysis from the pre-combat trial, the trial with the longest follow-up data that's randomized. And you can see that in this trial, we have significant rates of reintervention in both arms. So this is not going to be definitive in either PCI or CABG. The patient will require further intervention down the line. This is 30-year follow-up following bypass operations. And you can see that after 10 years, both in PCI and CABG, you have an incidence of about 5% yearly for revascularization. This patient will need further procedures down the line. If we do CABG on this patient, who's very young, we will accelerate atherosclerosis in his native coronary vessels. This is data from this week's JACC imaging using sodium fluoride PET, showing increased activity in vessels that were bypassed. And you can see there's marked progression of disease in bypassed vessels. Look at the calcium score in the bypass vessel, increases markedly at 12 months. In those vessels where it wasn't bypassed, no change. CABG progresses disease in vessels. Why is this relevant? Well, this is an analysis that we worked with Dr. Kamal Sharma of 500,000 patients with prior CABG in the United States. And we looked at, if they need revascularization, what is the modality? And you can see that in 90% of cases, the most common modality for revascularization in patients with prior CABG is PCI. Only in 10% of cases do these patients get a redo CABG. Why? If you look at the outcomes of redo CABG, they are much worse than PCI. So if you do a CABG on a patient and they need further intervention in 10, 20 years' time, then you're restricted to PCI because your risk from a bypass operation is significantly higher. And so, given that this patient will need further interventions in the future, it's better to save his CABG, not for his left main stem currently, where there is no difference in mortality at 10 years, and when you look at the sum total of data, but when his disease progresses and he develops multi-vessel disease, that's where the benefit of CABG lies. And so do PCI now. When he needs further intervention and his coronary disease has progressed, do CABG. That's where he has a mortality benefit, not now. And what are other relevant patient outcomes for a 37-year-old? Well, first and foremost, 37-year-olds, he has a family, he has to work. This is our data from UK looking at same-day discharge following left main PCI. It's safe. In my unit, he'll come in, he'll have a PCI, he'll go home on the same day. He can carry on with his life. That's not the case for surgery. This is data from the Excel trial showing patient-reported outcome measures and quality of life. You can see physical activity. It takes the patient 12 months if they have a bypass operation to get similar quality of life with regards to physical activity as it does for a patient that has PCI. He's back to normal within a day for PCI. For surgery, it takes 12 months. Look at quality of life measures. Again, takes 12 months for the patient that has surgery to reach the quality of life that a patient has PCI. In a young patient, their quality of life is impacted up to a year with surgery. Better to have PCI. And where and by whom should this patient be treated? Well, I would argue that they should probably have PCI, but in a unit that does intravascular imaging. This is data from my group showing a significant mortality benefit associated with intravascular imaging with left vein stem PCI. So if this patient presents in a unit where you can't do intravascular imaging, you should probably go for surgery. The second thing is it needs to be done by an operator with a high volume of left main PCI activity every year. There is very much a volume outcome relationship between PCI activity and outcomes. This is again data from my group looking at every PCI undertaken in the United Kingdom for left main, and it shows a clear volume outcome relationship. So any operator doing these sorts of cases should be doing at a minimum 16 left mains a year. If your centre can't offer that, send the patient for CABG. So I think in summary, in this 37-year-old patient who probably has 20 to 30 years of life expectancy ahead of him, neither CABG nor PCI will be the definitive treatment in this patient. He will undoubtedly require further revascularization as his disease progresses and grafts fail and stents fail. In left main stem PCI versus CABG, there is no difference in mortality up to 10 years from randomized controlled trial data. And certainly there's better quality of life data for PCI in such a young patient. He can get to work the following day if he has a PCI. For surgery, it will be months. And before he gets quality of life similar to surgery, it will be a year. I would say save his CABG for later because this guy's coronary artery disease will progress. And we know that coronary artery bypass grafting has a mortality benefit in patients with multi-vessel disease, not in isolated left main. So do the revascularization in 10, 20 years when he requires it and he has more extensive coronary disease. If you do it now, you will restrict the ability, as shown in our US analysis, to do further surgery down the line. If you are going to do PCI though, do it in a centre that uses intravascular imaging and has a good experience and high volume operators doing left main PCI. So I thank you for inviting me and I apologise for my technical problems at the start. Over to the discussion.
So it was a wonderful talk, Dr. Mamas, and I think you focus on this particular patient. The aim was to give your views on this particular patient. So Dr. Priyank, would you like to change your views after hearing Dr. Mamas, or you still stick to surgery as a first choice?
Fair enough. Am I audible?
Yes, you're audible.
So I'll just make, I'll say that no, I would still prefer CABG because I believe that as he said that he has a long life ahead. But we are probably in this particular case, we are going to do a minimal invasive surgery. We are going to send him out of our hospital on 3rd or 4th day. So sending him on next day or 3rd or 4th day, I don't think financially or any other way, family-wise, it's going to make a huge difference, especially in this part of the world. Also, I think Lima to LAD is like our holy grail. We hold on to it. we revere it so much, that we have so much faith in Lima to LAD anastomosis, that we, all of us, believe that a good Lima to LAD will last a patient a lifetime if it is done nicely, good Lima to LAD. I was not aware of the article that he just mentioned. Probably it is just published recently that CABG enhances or increases the chance of the coronary artery disease in the native vessels. I'm actually not aware. I apologize for that. But notwithstanding, I would still want to do a Lima LAD for this patient.
See, is MICA surgery gives as good quality of distal anastomosis as open heart surgery?
If it is not, then one should not do it.
I agree. That's why it was the question. And I asked question to Dr. Mamas. You said that bypass surgery increases coronary disease, that we've seen in many patients. But is it proximal to the graft, or only proximal to the graft, or distal as well? See, whenever you put graft or Lima, it's definitely proximal disease progresses. But is it true even for distal vessel?
Yes. So if you look at this slide that I showed in this picture from JACC imaging this week, it's throughout the vessel. It changes the flow dynamics. So we do see both in observational data and this data as well, which I think is an important consideration. So I think this case really shows the beauty of personalizing your approach. If this was a more elderly patient, I would say CABG. In this such a young patient, I would say start with PCI. He'll need further revascularization down the line. Then you do CABG where the mortality benefit is.
And is disease progression same with SVG graft as well as Lima graft, or it's more with SVG graft and less with Lima graft, which has very nice flow?
So in this series, they didn't specify whether they're vein grafts or arterial grafts, but certainly there's a lot of other observational data that has reported both in arterial grafts and vein grafts.
If I have time for one last comment, that's exactly what I also would say, that traditionally we have been taught that, Lima releases nitric oxide and various substances which kind of makes it last longer than a radial artery or a saphenous vein. So this is quite interesting, and we must look into it if there are any technical changes that we can make. Bilateral memories and other success stories are because of the Lima, which flows through all these and keeps the distal arteries and itself patent, and the longevity of it. So
I think if you get a patient, as my friend Mamas was saying, if you get a patient with 37 who's got a left main 110, you're probably dealing with either a FHF, familial hyperdyslipidemia, or you have a lipolittle A in our part of the world, which is so common that almost 20 to 35% of the patient will have a lipoprotein small a mutations that they carry. And it's very likely that whatever you do, this guy's probably going to come back, maybe in 5 years, maybe in 10 years, maybe in 15 years, when you need to do the alternative therapeutic procedure, which may be required. So I think we need to also be talking about disease modification and medication, but also counseling and learned consent, that we need to discuss this, that probably this is not the last procedure. But telling him that the Lima will last your lifetime is probably going to be false, because he may come with the right coronary disease. And his patient is not going to comprehend that his Lima is flowing or not, because we've had a lot of times done patients with acute MI where the grafts were done to the whole of the left system, and he presents with inferior wall MI. Surgeon would have a time to explain it that it's not my graft, it's something else that has got occluded. Chair, any other comments from anybody from chair? Yes.
With the right coronary, he will reach you.
Kamal bhai, I think if there is a left main disease, he will also need a graft to OM. Exactly. So, you may have a longevity for Lima to LAD, but your graft to OM is not going to last for his lifetime for sure. Unless you put a Lima Y or something like that, or a Lima to radial Y graft to OM. So that is going to be another, and as sir said, this is likely to be, and he is likely to have a highly atherogenic milieu. So chances of him coming back for something else, or one of the distal disease is extremely going to be extremely high in this patient. So I think, in my humble opinion, it should be PCI now, and maybe subsequently wait for him to be reaching to Dr. Priyank at a later stage.
The thing is that you've got to also consider the individual expertise of each unit. I mean, yeah, as I tried to say, that the Excel trial and all these trials were in European population, North American population. We know that Indian patients are very much higher risk, present younger, much smaller coronary vessels. We shouldn't be doing left main PCI in centers that aren't used to doing it. So it should be a high volume experience center. And similarly with, off pump, I'm sure that your center has excellent results and you do high volume, but there are many centers in the US, particularly where they have very low volume surgical experience. And, the patient shouldn't be having surgery in those sorts of centers. So you've always got to consider, where the patient is at and the experience of the surgeons and center as well.
So, Kamal, should we conclude or?
I think, we can conclude. Dr. Mamas, your closing comments on definition of myocardial infarction post-CABG, post-PCI, 3 times and 10 times of the biomarkers. Do you agree or do you disagree? Because that's what we were discussing when you logged out for a couple of minutes.
Yeah, well, I think that the problem with this is that we've got now assays that are very sensitive. And so we've just published a paper in the European Journal of Cardiothoracic Surgery of patients undergoing CABG. And if you measure high sensitivity troponins in these patients, over 90% of them will have periprocedural MIs. That's ridiculous. You can't have that suddenly 90% of patients undergoing cardiac surgery have periprocedural MIs. So I personally think that we shouldn't be thinking about periprocedural MIs, whether it be in PCI trials or surgical trials, because in the era of high sensitivity troponins, many of the trials have suggested that actually it has no prognostic impact, a small rise in this very sensitive biomarker. So I wouldn't use this in these sorts of trials.
Kamal, when I was doing Kamal, can you hear me?
Yes,
Kamal? Yes, see, basically, when I was doing duty in Jaslok Hospital, we had one of the top cardiac surgeon of the country. And in post-operative round, I saw ST changes, means it's like non-Q septal MI, and phoned him at midnight. And he was so angry that from that day onward, I was out of his rounds. But because surgeons, they don't consider ST changes or non-Q MI as a MI. So their definition, as Kamal says, are very different than what we do. If after angioplasty you see ST changes, you are scared, but surgeons are not scared. So I think their thinking is very different.
Sir, I think 80% of time the graft closures are hidden under the sternal pain.
Yes.
That is why.
For the patient so scared.
And even the data show that on table or before discharge, there are around, I think, 3 to 5% graft which would close. I don't know. I mean, how many times we have diagnosed them, because half the time even the ECGs are not done on daily basis, and even some small changes and troponins, if they are elevated, because first we don't do it, and if it is done, usually that will be passed on as you have just fondled with the heart. So there is some rise in troponin which is likely to be there. So that's how things will go.
I have one question to Dr. Mamas. How frequently you have encountered that? You mentioned that after putting a graft in the LAD, there was a progression of the disease distal to the graft. So how frequently you encountered in your clinical practice? And what is the probable reason for that?
I mean, the problem is that we don't routinely do cardiac catheterization in these sorts of patients. So, we don't know. And we know from data that, for example, many vein graft occlusions are asymptomatic in patients. And so unless you do a systematic assessment, as was the case in the JACC imaging paper that I briefly showed during my presentation, there's no way of knowing how frequent something is. So the short answer is, in my practice, I don't know, because I don't routinely cath these patients unless there's an indication.
Thank you.
So, Kamal, should we conclude now? Okay.
Yes.
Yeah, thank you very much. Thank you, chairpersons. Thank you, moderators. Thank you, my friend Mamas. Thank you, my friend Priyank. Good to have you both. That was a wonderful debate and a very learning experience. Always a pleasure to have you all. Thank you. Bye-bye. And we move to last session of the day. I invite moderators, Dr. Nilesh Chandak, Dr. Vipin, Dr. Rishikesh, and chairperson, Dr. Pujan, Dr. Arvind, and Dr. Ashish Mishra to introduce both the speakers, the case, and then move to the debate. Over to chairpersons.
So good evening, everyone. So presenting the first speaker, basically we have a case-based discussion with the theme of coronary bed preparation. And with in fact, we have in blue corner Dr. Chirag Sheikh, who is basically uh, having multiple publications, and in fact, he's chief intervention cardiologist at Rhythm Heart Institute. And in the red corner, we have Dr. Hashit Joshi sir. Basically, he'll be discussing on cutting or scoring balloons as a safer technique for coronary bed preparation, as it is being a time-tested technique. And in blue corner, we have Dr. Chirag Sheth, who is backing up with high-pressure balloon-in-balloon technique, which is as most likely, which is to yield for optimal bed preparation. So over to Dr. Chirag.
Okay. Fine. So good evening, everyone. Thank you, Dr. Kamal Sharma and the organizing team at the CardioCon 2022. It's really an exciting meeting to having been participated. And let us quickly go to the session that we are supposed to discuss. As it has been introduced that we have an elderly male with non-ST elevation MI with blood pressure 170/90, preloaded with clopidogrel and aspirin, and has an ostial calcified 90% lesion with dominant circumflex vessel. And what should be the ideal pre-dilatation strategy? So as we know that angiography is insensitive as far as knowing the plaque distribution and composition is concerned. But if you have detected coronary calcium on fluoroscopy, on conventional angiography, at least on either side of the luminogram, in at least 2 different views, you are likely to have complex coronary calcification, and there are higher chances that you might end up having plaques with a rim of calcium exceeding about 90 to 180 degrees. So we are likely to have significantly complex coronary calcification as far as this patient is concerned. We know that the presence of calcific stenosis is associated with markedly reduced final minimal stent area achieved after PCI, as well as the OCT showing the stent expansion index, which is also markedly different when you have significant calcium versus mild or no calcium. And it's not surprising that coronary calcium is supposed to be a strong predictor of strong stent failure. This slide is very much familiar to all of us. We know that for bed preparation for calcific lesions, there are 3 basic techniques. One is debulking, ablative, and balloon-based techniques. In this patient, let us say that if the patient is likely to have balloon crossability, the pre-dilatation strategy after having imaging done should be based on non-complanted cutting scoring balloon system. In this particular flow chart, there is no mention of a high pressure balloon-in-balloon system, that is OP and NC for all practical purposes, for the sake of discussion. So coming back to this patient with 78-year-old non-STEMI diabetes hypertension with the calcific lesion, what do we want for this patient? We want a procedural success that should be without MACE. We want a strategy success that PCI should succeed and patient should not have emergency CABG done. We want a technical success, that means crossability and deliverability of the hardware, especially balloons and stents. We need an angiographic success, meaning thereby no significant residual lesion. This definition may vary from various, the parameters may vary. Some would say that less than 10% should be the residual lesion. And in presence of calcification, at times the studies have said that even less than 30% lesion could be acceptable. Residual lesion could be acceptable. One of the important aspects as far as our geographic is concerned is the cost of intervention, which should be restricted, and there should be lesser need of additional complementary hardware used. And finally, the acute result should be durable, and that would depend on the optimized result with imaging. So I think this is what I would want in given patient. Sharing just one similar case that we had recently, will not show the IVUS imaging, but we had a calcific LAD disease. You can see here fluoroscopically the stent boost image showing significant calcium. And if you see the IVUS image, again shows a significant arc of calcium exceeding more than 180 degrees. This patient, when we treated, we wanted to have a coronary blood preparation with plextome. After a routine NC balloon dilatation, plextome really could not cross the lesion. And in this patient, OP and NC, that is ballooning balloon system, could easily cross the lesion, and we could successfully prepare the bed. And this is what the final result of the PCI was. So this is just to show that how the coronary bed preparation successfully led to good stent expansion in optimal areas achieved. So the super high pressure balloon, that OPN NC by the SIS Medical, is a non-compliant balloon with a twin layer technology, and it is developed to deliver inflation pressures more than 35 bar and up to 55 bar. Now, is it surprising that the flextome or Scoreflex system could not cross, and the OPN NC balloon could cross? So if you see this chart very carefully, in this chart, we can very well see here the lesion entry profile of various cutting and scoring balloons, and the mid balloon profile of the same balloon systems. So lesion entry profile of practically every balloon system is more than 0.019 inch, and the mid balloon profile shortest is of Scoreflex, that is 0.032 inch. The newly introduced Wolverine has mid balloon profile of 0.036 inch and lesion entry profile of 0.017 inch. Now, if you compare this with the OPN NC system, the OPN NC has the lesion entry profile of 0.016 inch, which is least as compared to all previously documented the scoring and the cutting balloon systems, and the mid balloon profile is 0.028 inches. So balloon profile, despite ballooning balloon system that this OPN NC balloon is markedly lower as compared to the scoring as well as the cutting balloons. And it is not surprising, that's why that this can cross even in significantly complex lesions where the cutting or scoring balloons may not be able to cross. Now, coming to the issue of bed preparation. Now, we know that there is a proven role for optimization of stent result with OP and NC balloon, that is in the post dilatation. But what is its role in bed preparation as far as pre-dilatation is concerned? Do we have data as far as this strategy with using OP and NC system is there? So recently in the Euro Intervention 2021, there is an article by Tobias Rude about super high pressure balloon versus scoring balloon, which is used to prepare the severely calcified coronary lesion, the ISAR calc randomized trial. I will go through briefly the data that has been published as far as the pre-dilatation strategy with OP and NC system is concerned. There were 74 patients randomized to 1:1 fashion at 5 centers in Germany and Switzerland. And these patients were randomized after unsuccessful lesion preparation with conventional NC balloons. And if we see the salient characteristic, the vessel diameter for these patients was about 3 millimeter, the lesion lengths were about 24 millimeter, diameter stenosis was about 70%. But if you see the end results of the study, what it shows is that the OP and NC balloon system was associated with markedly lower diameter stenosis post PCI, which was statistically significant when compared to the scoring balloon. And if you see the minimal lumen diameter post PCI, that was also significantly higher as far as post PCI evaluation is concerned, and that was much superior in patients with OP and NC balloon system compared to scoring balloon system. Whereas the final OCT evaluation did not really show significant difference as far as stent expansion index is concerned. But if you go into the smaller details, that there was additional requirement of additional hardware as far as optimizing the coronary bed preparation is concerned in patients with the scoring balloon system. So almost 32.4% of patients from the scoring balloon arm required additional non-compliant balloon dilatation compared to only 5.4% in the OP and NC arm. So this is one of the important parameters which was statistically significant as far as their observations are concerned. It is reassuring to know that whichever strategy you choose, if you see stent expansion on the optical coherence tomography, there is no significant difference. And OPN-NC as well as the scoring balloon, both modality of coronary bed preparation resulted into almost equivalent stent expansion index on the OCT. So finally, all is well that ends well. And therefore, the study really did not show major difference in the outcomes of the patients. If you see the angiographic success, it was same. Strategy success was also the same in both arms. Procedural success, there was no significant difference. If you see the in-hospital MACE, it was not statistically significant. However, if you see actual numbers, numerically, we can see that in-hospital MACE was numerically higher in the scoring balloon arm as compared to the OPN-NC arm, which has not shown a statistical difference. But I think still this small data, this small number also should be alarming, and we should be careful about this particular observation. So it is also reassuring to know that in both the arms, the extent of coronary perforations were not significantly high. Less than 3% of patients had it, and all of them could be treated with covered stent implantation. So this is the only randomized control data that we have as far as the coronary bed preparation is concerned in with the use of OPN-NC versus scoring balloon. But I think based on the relatively short, small experience with coronary bed preparation with OPN-NC and large experience with the scoring and cutting balloon systems and the data from which I have just shared, the ISAR calc data. If we relook at this slide, what do we want? Procedural success, strategy success, technical success, angiographic success, cost of intervention without increasing the need for additional complementary hardware, and durability of acute result with the use of OCT. I believe the high pressure ballooning balloon, that is OPN-NC system, is most likely to yield optimal preparation. And I think with this, I'll end my talk here, and it would be interesting to have opinion and discussion with the panelists. Thank you.
Chairpersons? Dr. Hasid Joshi, over to you.
Yeah, I think share screen.
Share screen is there, sir.
Yeah, it's not allowing. It's not allowing the message.
No, sir. You have the right to share the screen, sir.
Yeah, but can you see my?
No, Sid, I think you need to probably log out and log in.
Again, log out and log in.
That's what happened with Mamas. So maybe you were logged in for too long. Maybe it's on.
Yeah, about 2 hours.
Because
more.
we have allowed you the share from here.
I will try once again.
But you are not able to do it.
Just a second. I will log out and. Can you see my screen?
Yes, sir. Yes, sir. Yes, sir. Right now.
Okay. Okay.
Yes, sir. Put it on a slide so much.
Okay. So, thank you, Kamal, for allowing me this opportunity. And
sir, put it on a slide so more, please.
Okay. Yeah. Sorry.
No, first option.
Okay. And Dr. Chirag has very well elaborated the need for bed preparation in a LAD ostial lesion. So why would we hesitate to do a PCI for LAD ostial stenosis? And this again, surgeons would happily say that we would just put a mid-cab Lima to LAD, and that would do the case. So whenever we do, we have to be better than the surgeons in terms of safety and long-term outcome. All ostial lesions are essentially bifurcation lesions, 0, 1, 0 at the best, or it can even be 111 or 011. There is usually involvement of distal LMC and LCA ostium. And ostial lesions have high elastic recoil. They are different from mid-LAD or mid-circumflex lesions. There are concerns for side branch occlusion due to plex shift and dissection. So, as Dr. Chirag said, that ideally we should treat it as an distal LMCA bifurcation lesion, and imaging should be done in all cases. So probably if imaging is available, IVUS available, we would do IVUS in this case and assess the lesion severity, pre-procedural plan that appropriate stenting strategy, landing zones, whether circumflex or distal LMCA is involved or not, optimization post-procedure, and management of immediate complications, if any. Now, vessel bed preparation, what we aim at: minimize risk of dissection, maximize lumen gain, and the stent size and MLD to be achieved. Now, cutting balloon is a very old thing used in PCI right from about 2002 to 3, we were using cutting balloons. The advantages of cutting balloon: it reduces the vessel stretch and vessel injury by scoring longitudinal rather than an uncontrolled disruption of plaque. Entire force is focused on wire or blade edge mounted on balloon. It creates a fault line and a dissection which is in an orderly fashion. And we can go with lower balloon inflation pressure recommended with the cutting balloon. The risk of slippage when you are doing at ostium with the normal balloon, the risk of slippage and a dissection extending proximally would be disastrous either to the circ ostium or to the LAD, and plex shift is minimized with cutting balloon. Another thing, role of inflammation, that calcification and inflammation goes hand in hand. Which is the chicken, which is the egg, we don't know. And when we do balloon dilatation, there is inflammatory activation of vessel wall injury, which can lead to intimal hyperplasia and restenosis. Most of the inflammation studies are on intima and media, but when we do at high atmospheres, the perivascular and adventitial tissues come into play. And many porcine studies have showed that this might lead to long-term restenosis rate increase with high pressures. So cutting balloon can create equal MLDs or better MLDs with low atmosphere and low inflammation. This is how NC balloon expands. There can be dog boning effect, while with cutting balloon, when you go up to 8 to 10 atmosphere, you create a routine. This is Wolverine, which we are routinely using from Boston Scientific. This is the non-functional blade height is reduced, and then there is a cast pad of about 0.005 inch, right? And there is a T-shaped notch which has enhanced flexibility and fixation to pad. Now, this is the mechanism of action. When the balloon atherotom, it creates microsurgical incision into the vessel wall and weakened areas which can be dilated at lower pressure, changing the lesion compliance. The most important thing here is dissection only in the needed place without balloon slippage, with changing lesion compliance, so that a low balloon atmosphere would lead to expansion. If plain POBA is done, there are chances of hematoma. Acute overstretch can lead to hematoma and recoil at 14 days. So cutting balloon in fibrotic lesions, ostial and bifurcation lesions, these are the advantages which we have already discussed. These are few trials. There are no trials between cutting balloon and high pressure balloons, but cutting balloons versus plain balloons which were available for ostial lesions the primary success rate, procedural success, acute gain, late loss is much less in LAD ostium. These are two trials way back from 1999 and 2000. Then this is in cutting balloon. Whenever there is a bifurcation lesion, the immediate and 3-month follow-up of cutting balloon versus plain balloon, the procedural success of cutting balloon was much better than POBA, and post-procedure MLD was quite high. This is a reduced trial where when used with IVUS, it reduced the MLD, it reduced the restenosis with cutting balloon. There are angiosculpt, this Lacrosse and Alpha. This was considered Scorflex. This was used in the trial, but it has nylon, and nylon definitely probably has inferior cutting effects. It scores more like a buddy wire than with cutting balloon. These are OCT images of cutting balloon device. With one inflation, it causes 4 clear cuts in the vessel wall, and with 2 inflation, much more, about 5-6 cuts into the vessel. Now, if in this case, how would we go? Probably we would do an IVUS. If LAD ostium shows an arc of more than 270 and shows superficial calcium all over, dense calcium all over, probably a rotational atherectomy would be the first choice with a low burr so that it causes less inflammation, and then post dilatation after rotational atherectomy with a cutting balloon at a low atmosphere probably would be the ideal thing. There were 2 trials, 2016 and 2019, that effect of cutting balloon after rotational atherectomy in severely calcified coronary artery lesions assessed with OCT, and the results were that calcium fractures were much better with cutting balloon. MLD was much better, 6 versus 5 with cutting balloon. Stent area was much higher with post cutting balloon than with conventional balloon. These are the OCT findings post cutting balloon. And if we see this is a proximal, so probably if we dilate either with rotablator or with a 2O balloon, there should not be much problem in crossing the lesion with a cutting balloon. Head-to-head trial with high pressure balloon, there are 2 trials, not in coronary, but in pulmonary artery stenosis and native hemodialysis fistula, where cutting balloon did much better than high pressure balloon in terms of success. Perforation rate was low, and 6 months restenosis rate was quite low than the high pressure balloon. So for this patient, imaging followed by, if necessary, rotablator or a just plain balloon of 2O, followed by cutting balloon would be best for lesion preparation. Thank you.
Yeah, so fantastically presented, both of the speakers. Over to chairperson, Dr. Ashish, Dr. Arvind, your comments?
Well, I think in an acute MI setting, which is there in this case, non-ST elevation MI is an ACS situation. Do we or should we go for a rotablation, as Dr. Joshi has said? I would be very reluctant unless I try with a high pressure balloon or at least non-compliant balloon at a reasonable pressure, and if it is not cracking, then maybe after stabilizing the patient we can go ahead. But in an acute MI situation which is there,
Rotablator, if That's why imaging comes in. If you do imaging and you see thrombus, rotablator is out of question. If we do an imaging, if there is no visible thrombus and a dense calcium, superficial calcium with an arc of more than 270, probably rotablator would be choice. Otherwise, rotablator always should be a second choice. If you can do away with balloon and get adequate expansion, probably rotablator would be second. So imaging would be the first thing. Your further things probably would be guided by the imaging. If there is a thrombus, visible thrombus in this, then probably rotablator is out. Again, then probably we would go in with the 2O balloon, dilate, put a cutting balloon, and then do this.
Sir, I would be still skeptical in an ACS situation, which is a activated platelet. We know that rotablation itself leads to platelet activation and lot of inflammation at that site. So in an already inflamed patient, I mean, I don't know whether anyone else would be very keen on or we can just go for probably a, IVL balloon for this patient if we can negotiate. If it is so bad and if the lesion is more than 170-degree calcium, then probably IVL in an acute MI situation could be logically more appealing than doing a rota in this non-ST elevation MI patient, even if there is no visible thrombus.
Rota would be an optional thing only, not the first choice. But if there is inflammation, why would you go with a very high balloon, high pressure balloon, go up to 20-30 atmosphere?
No, sir, even though it gives,
I think, Dr. Arvind, it would depend on the thrombus burden also. I mean, what you're dealing with in an ACS situation. You are right. In an STMI, surely you would be very skeptical. In STMI, if the thrombus burden is not much and it's a plaque which is eroded, which is otherwise a calcified one, it will, of course, I mean, you're right. It would depend on the inflammation and thrombus burden on the case-to-case based on the anatomy. And maybe then you can image as well. Dr. Poojan, your comments?
Yes, sir. What I would, I agree completely with what Dr. Arvind has told, that actually in an acute MI scenario would be very scared to use rotablation, would try avoid at best. In some cases of STEMI also, what we have done is like we cultivate the STEMI by just doing POBA and achieving TIMI3 flow, and or either thrombolizing the patient, and then we, if at all rota is needed, then we do it as a state procedure. But like ongoing STEMI, we usually avoid doing rota as such, and because at the small centers availability of rota or IVL on table is also an issue. So many of times what practical scenario that we face working at a peripheral center is that to establish the flow is our chief goal, and then we decide whether to do either a rota or an IVL, or whether we send patient for surgery. So that's what we practice.
There is one question from both the speakers. I mean, we know that osteal lesions are always tough fibrotic ones. So we don't know, and behind the calcium, which is seen visibly on X-ray, how much is the fibrosis which is there? So, I mean, Chirag bhai, how much effective an high pressure balloon or a ultra high pressure balloon would be for, taking care of fibrotic lesions? Calcium we know, and what would be the size which would be advisable as far as, I mean, cutting, or I mean, OPN you would be considering for pre-dilatation? We know 1-to-1 post, probably 0.5 centimeters, 0.5 millimeters lower if we go for that. So what is your take on pre-dilatation with an OPN balloon?
So I guess given a choice, one should have imaging based evaluation. I mean, given a choice, OCT first, because depth of calcium is one of the important parameters that you have to look into, which IVUS may not be able to show. So at least some form of imaging, whatever is available, is recommended deciding the size of the balloon. And for OPN, I think I would be comfortable by about 0.25 to 0.5 millimeter lesser than what the media to media diameter would suggest, and then go with a high pressure, and if required thereafter go with conventional NC balloon dilatation if required. Otherwise, you may not be able to, you may not require additional hardware to optimize the lesion.
So you would go with a smaller, relatively
0.25 to 0.5 mm, yeah.
And how about fibrosis? I mean, how much do we expect the fibrotic lesion to yield?
I mean, the patient profile that has been given to us, which practically says that heavily calcific lesion, and practically for all practical purposes, we know
about this patient
that yeah, see, fibrotic lesions may not yield, that is true completely, but I still feel that OPN ultimately is a NC balloon, so why it should not respond well even in presence of dense fibrotic lesion, that is a question. I mean, it will respond, I believe so, it will.
I think osteums and bifurcations are different. Whatever you do, the recoil is very high, and here is where cutting balloon has a definite advantage. If it had been even 5 millimeter inside the LAD, probably either or would not have made a change. But at the ostium, if it is at the ostium, the chances of slippage, first thing, we many a time see that due to fibrotic lesions, when we inflate the balloon, it slips either this way or that way. And if it slips towards LMCA, cause a dissection there, or even give a balloon injury, that would in long term would make difference. So for this patient or any patient, if it is a real osteal lesion and you want to avoid doing a left main bifurcation, start from LAD ostium dot, probably a cutting would definitely help. And here the distance between LMC and LAD is very low. Once you dilate with low atmosphere with 2 millimeter balloon, probably you don't have to push the balloon very much. So crossability also would not be a major issue.
Agreed. So what I feel is that unless the lesion is heavily calcific, where your NC balloon does not open well, there comes the role of OPN-NC. I don't see the role of OPN-NC balloon for bed preparation if your conventional NC is not working, and for coronary bed preparation that we are talking about. If we try to learn from the data what SR Calc has given, it is only for patients where your routine NC is not yielding. But if excluding this subset, I think cutting or scoring balloon is always an option and much better as far as bed preparation is concerned at osteal lesions.
You've seen Hasid Bhai do a lot of cutting balloons for the ostium ever since my residency. He's always been a fan for cutting balloon, and he's done it with excellent results. And I was sure that he had good enough scientific deliberations to justify it, which he did. For high balloon, I think Dr. Chirag also got good, fantastic evidences. I was wondering how will he dig it up, but then he did. So wonderful talk. Both of you, fantastic session. But I think we need to be treating osteums very differently than we do for, say, other. And landing with perfection can often be an issue. So a lot of times people do a crossover and then do a pot to the left main, which is a very common strategy. But sometimes landing with precision also has been adopted when you have a wide angle and you can put a side wire and then try to mark it and then inflate suboptimally with the side branch, smaller size hanging balloons into the left main. People do all kind of funny things, but then cutting balloon is always something, or the osteal lesion, as was mentioned by all of you, is a very different ball game, which that's why I thought I should be keeping it as a separate topic. Chair, over to you, chairperson. So if you have anything to add, else we can conclude the session.
One small question to Dr. Joshi. I mean, where would he prefer a cutting balloon and which patients he would prefer a scoring balloon? I mean, is there any way where we should be choosing one of the two? Or if we talk about scoring balloon, Scoreflex versus angiosculpt. So what is your opinion, Dr. Joshi?
I have used cutting balloon most of the times. The Boston Scientific.
I use scoring balloons for ISRs, cutting balloons for the ostium. That's what I do. But we do use cutting balloons for ISR as well, because of the cost. When you get into Wolverine or something, you'll actually need to have more money coming in, and they are costlier than the stents themselves. So that way, an Oxford cutting balloon would save your skin. Oxford cutting balloons, you check. We have learned that technique also, how to check them. You're not losing a blade. You inflate gradually outside. Actually wear a single glove, palpate all the 3 blades, gradually inflate outside, gradually deflate outside, then check the center flush, then again check for the balloon, and then when you go in, make sure that you're not pushing too hard, and then inflate gradually and deflate gradually. So these are some of the tricks that I've learned from Asit Bhai only, how to use an Oxford cutting balloon. So I thought this topic was justified for him to speak. So that's why.
Corflex we have used, but where you feel it is very tortuous and very distal, probably the cutting balloon won't go. If the angle is more than 45 or 50 degree, then I've used Corflex in 1-2 patients. But otherwise, cutting balloon, and with Wolverine, now they have given a bend at every 5 millimeter. So the flexibility has increased.
Actually, Wolverine, you can go up to high pressure of 14 to 16 atmospheres, even 20 atmospheres also, as Dr. Shamin Sharma has shown in many of his live cases. So that restriction of low pressure now no more exists with the, I think, cutting balloon. Same way, Corflex have given now NC balloons in it.
No, this is only for the Oxford balloons. I'm teaching you a trick. You have to go high pressure with the New York. I'm teaching you the trick of Oxford cutting balloons, how to you reuse. That's what I'm teaching you in my Ojana trains. That's the difference. Otherwise, you're right. You have to go high pressure. Oxford, when you're using, don't go high pressure. You will shave off the blade.
Yeah.
And then you'll have to, you have no access to snare it off. Then you're stuck.
True.
So one question from my side to Dr. Chirag, like the role of OPNNC in underexpanded stents, basically post deployment, and what is the current experience?
I would say it almost always works. I mean, I am yet to see OPN failing in my limited experience. I can't quote that I have a huge experience.
No, actually, Dr. Chirag told me, Kamal bhai, OPN का बोलना है तो post stent में बोलूँगा. नहीं, wait नहीं होगा. So that's right, actually, because that's Dr. Ashish, that's the scenario where most of the times we've used OPN balloon. Whatever 10, 12 balloons I've used are all been post stent. I mean, because we have learned from others when they've used it in pre-dilatation and end up with perforation. It's not that you don't perforate through stent. People have had perforations, but I think that's the easier and safer strategy to use OPN balloon rather than preparation. I mean, to pitch this debate, I had to give this case to Dr. Chirag, but
I think majority of
I think it works. It's safe.
You rarely need pre-dilatation OPN balloons. I mean, if you have selected your strategy very nicely up and you are using imaging, majority of time you will end up going for a rota or an IVL upfront, and then you don't actually need. But sometimes, you are stuck.
That is what
you have dissected the vessel, and you don't have in-hand rota. Then that in that case, I think twice I have used OPN balloon as a pre-dilatation strategy, but definitely I would undersize, just crack the calcium, and then go with an NCF balloon 1-to-1 and go with the real high pressures of 18, 20 or maybe 24.
So if I may add, Arvind here, that if in all such complex cases, if you have an access to imaging, use of OPN is very safe.
Absolutely.
Like a 3 millimeter OPN NC, even at 35 millimeter or let us say 40 millimeter, does not go more than 3.1. So if you're sure of vessel size and you select the proper size of the balloon that you're using, OPN is not likely to be associated with perforations.
True.
Right?
Absolutely.
So it is otherwise safe if you respect the vessel sizes either by your own experience or with the use of imaging, whichever is visible in a given scenario. Probably you will not perforate.
I think we overshot the time, but because we were last, so we had plenty of time for discussion.
Yeah.
That's the advantage of being the last case scenario. Yeah. Thank you, everyone. Thank you, Asit Bhai. Thank you, Chirag Bhai. Thank you, speakers, chairpersons, and moderators, Dr. Ashish, Dr. Arvind, Dr. Pujan, Dr. Rushikesh, Dr. Vipin, and Dr. Nilesh. Good night, everyone. See you all tomorrow again for
Good night. Thank you.
sessions again.
Thank you, Kapil bhai. Thank you for inviting.
Good night, everyone.
Bye.
Yeah.
Good night.
Good night.
Thank you. Good night, everyone. Bye.
Recording stopped.